Good morning, everyone. We start our second day this Sunday morning, and hope it runs through as smoothly and as successfully as it did yesterday. For our first session of the morning, we have our chairpersons here already, and I would like to invite Dr. Prasenjit Das, Dr. Saurabh Mittal, Dr. Mahendra P. Bhatt, Dr. C.P. Pandey, and Dr. Malkit Singh to chair the session. Speaker. Those who are sitting behind, can you please come forward? Let's just move forward, fill up these seats. आइए ना. Our first session of the morning is a talk by Mr. Gagandeep Singh. He'd be presenting about the association between glycated hemoglobin and triglyceride levels in type 2 diabetes mellitus. Insights from a cross-sectional study in a tertiary care laboratory in Punjab, India.
A bright good morning to all of our presented here, respected delegates and dignitaries. Myself, Gagandeep Singh, PhD scholar, RIMT University, Mandi Govindgarh, Punjab. Here I have today here for presenting a PPT or oral presentation on the topic association between glycosylated hemoglobin and triglyceride levels in type 2 diabetes mellitus. Insight from a cross-sectional study in a tertiary care laboratory in Punjab, India. These are the list of contents with the introduction, aim and objective, material and methods, result, discussion, and references. So let's start with the introduction. Type 2 diabetes mellitus is occurred when our blood glucose level increased due to resistance in insulin in our body. Dyslipidemia is the imbalance of lipids such as cholesterol, low density lipoprotein, HDL, TG, and your high density lipoproteins. Dyslipidemia is quite common in non-insulin dependent diabetes mellitus patient. Keeping lipid and glycemic levels under tight control is crucial for maintaining or preventing the micro and macrovascular complications that can be result in that context. Elevated levels of triglyceride lead to elevated level of free fatty acid, which may induce insulin resistance and beta cell dysfunction. These are the aim and objective. The study's main aim was to demonstrate the connection between triglyceride levels and HbA1c, that is glycosylated hemoglobin, in type 2 diabetic patients. As the WHO announced that India is the capital of world in the diabetic stage right now, and we are in the pandemic state because more than 75% is our pre-diabetic, and we have 168 plus millions of the population that is again a diabetic in our country. So this is a pandemic situation for global as well as India too also. So by predicting the triglyceride level or status of the type 2 diabetes patients, this may identify patients who are more likely to experience cardiovascular, stroke, or diseases. One of the typical risk factors for coronary artery disease is in people with type 2 diabetes mellitus is hypertriglyceridemia. That is the hyper level of triglyceride levels in our body. Due to increase of levels in our body, it may lead to the cardiovascular event as well as the beta cell dysfunctions. Now material and methods. Our material method include data is collected at the Life Care Laboratory Foundation, Dera Bassi, Mohali, Punjab. A sample of patients who were 18 years of age and older was gathered. Over the course of 4 months, this study included 502 type 2 diabetic patients type 2 diabetes patient who provided their insight were enrolled. Prism 9 software was used to make the statistical analysis positively to make the connection between triglyceride level and glycosylated hemoglobin. So by using the statistical analysis, chi-square and Pearson correlation was implemented on the relationship between triglyceride and HbA1c. Based on our cutoff levels, we have divided our HbA1c level into 4 categories. That is, number 1 is 7, 8, 9, and 10 respectively. As you know that 6.5 is the pre-diabetic stage, and more than 7 we include as a diabetic personalities. To calculate the odd ratio at its 95% confidence interval, the risk between high triglyceride level and HbA1c level group was estimated. The p-value less than 0.05 was considered as a significant to demonstrate the significant relation between HbA1c and triglyceride levels. Estimation of triglyceride was done by the glycerol kinase method. Total cholesterol was done with the CODPAC method. HDL cholesterol was done by the enzyme inhibition method. And it's done on the Bachmann Coulter, that is DXC 700 AU. That is the again one of the most important auto analyzer in our country. We are leading that because Bachmann is the American company. So estimation of HbA1c was done with the help of HPLC ion exchange method. That is most probably we are using to diagnose the disease. After that, Turbo 2 Biorad was fully auto analyzer we are using for the HbA1c analysis. So these are the results. Glycosylated hemoglobin is decommercialized into 4 categories, that are 7, 8, 9, and 10 respectively. With a cutoff level 7%, 75%, 74%, that is n is equal to 220 patient had high triglyceride level, that is more than 150, and show a significant association, that is the p level is less than 0.01, and odd ratio was calculated by 2.038 at 95% CI, that is confident of intervals, that is again put up for demonstrate positive and negative point of on that values, whether our results are accurate or not. With a cutoff HbA1c 8%, 48%, that is 9, n is equal to 142, had a high triglyceride level and show a significance association, that is p value is less than 0.01, and odds ratio was calculated to be 2.26 with a 95% CI. Utilizing the same decremental scheme, a cutoff value of HbA1c as 9%, 68.6%, that is n is equal to 203, had a high triglyceride level and showed a significant correlation, and p value is less than 0.01, and odds ratio was 2.69 at a 95% CI, that is confidence of interval again. With a cutoff as a HbA1c 10 respectively, 78.4%, that is n number is equal to 232 patients had a high triglyceride level and showed a significant correlation that a p level, that is p value is less than 0.01, again significant, and the odd ratio was calculated to be 2.66, and at a 95% CI was used. So these are the again mean values of the age in years. After that we have a serum cholesterol levels, the mean values are there, then serum triglyceride levels are there, and then serum LDL, that is low density lipoproteins are there. Their mean levels are different at different stage, that means 7% they have a different mean value, at 8% they have a different mean value, 9% they have a different mean value, and 10% they have a different mean value respectively. So in our study we include 58% are the males candidate and 42% are the female candidates was there. And this is again a flow chart of that summary and with a bar chart. Yes, sir. Okay, sir. So this is the flow bar graph of that whatever I have presented here. This is the bar graph of graph between lipid profile and HbA1c levels. Now discussion. A variety of lipid abnormality can occur in diabetes, which is multifactorial disease, compared to other lipid abnormalities, that is hypertriglyceridemia is most common in type 2 diabetic patients, mellitus patient. This result of this study evaluation high relationship between glycosylated hemoglobin and triglyceride levels reveal a statistical significant relation between high HbA1c and high triglyceride level. This may then help to identify individuals who are more vulnerable to have a cardiovascular event by predicting the triglyceride status of type 2 diabetic based on their level of glycemic control. According to the recent study, high triglyceride level and HbA1c has a favorable link, and both of them can be used as a powerful indicator of dyslipidemia. No, sir. Listen to me. So, conclusion, a positive correlation exists between HbA1c and high triglyceride level indicated that HbA1c is a predictor of cardiovascular risk factors in type 2 diabetic mellitus. Monitoring HbA1c level can help in estimating triglyceride level and managing cardiovascular risk in diabetic patient. Glycemic control and triglyceride level in this cohort of this patient with type 2 diabetes are significantly correlated in this study. Understanding the idea can aid in the diagnosis of lipid abnormalities in patients with a poor glycemic control, as well as then the prevention of cardiovascular events in high-risk patients. Thank you, sir. These are the references. Thanks, sir.
So very good, Gagandeep. So do we have any history of the treatment of these patients? Means were they on some drugs? Because the diabetes control and triglyceride would vary if patient is on a statin or fenofibrate or any other medication.
Yes, sir.
Then this correlation may not exist. So they were treatment naive or were on treatment something?
Sir, there are control people are also available for that while we are running the controls, and that because if you can say that below the 6%, we have meaning that these are the control values. And the patient who was on metformin drug therapy, they were totally excluded from the categories. The patient who are newly diagnosed with the type 2 diabetes mellitus, they are included in our study. That is the main point.
Okay. Thank you.
Are there any questions from audience?
Yes.
If there are no questions from audience, there is a
Sir,
simple observation.
There is a question.
There's a question.
There is a question.
Please. I'm sorry.
Sir, have you selected the age group for this type of a study? Because you have just separated into the male and female. Have you considered related to the children's also in this case?
Ma'am, I have considered 18 to 65 is the age group for the patients. They are male and female, both are included in that range, because as the youngsters, because the lifestyle interventions of the youngsters are not good, and they are also having a high favorable event है कि वो आगे जाके diabetic हो सकते हैं, because they are in the pre-diabetic stage. आप देख सकते हो कि food habits, these are not good, inadequate proper diet ले रहे हैं और सब कुछ कर रहे हैं, so this is not a good.
Yes, sir. So that's the second question, ki how you handle the indirect variables, the direct and indirect, independent variables and that.
See, if something exists, so we have to be backup plan also available for that. Suppose a patient who is on a therapy for some time, or a drug therapy, we can give him a drug for some time, little time. After that, we will say that you please discontinue this drug. To say that, to see the effect, whether our drug or whether our जो metformin हमारा है, it is working on that patient or not, by analyzing their levels, HbA1c and triglyceride levels. Because as you know that due to the lifestyle intervention, and especially in Punjab, because we all people are eating too much oily foods in Punjab, so this may lead to that fat content is too much high in our Punjab, so that can also be as a predictive one factor.
Okay. Thank you.
Thank you.
sir.
Thank you, sir. Thank you.
Very well presented. There are a few observations basically
Yes,
in
sir.
your PPTs, like when you are mentioning any equipment within the bracket, it
Yes,
should
sir.
be in caps. Okay.
Okay, sir.
And then you have mentioned in result section 7, 8, 9, 10.
Yes, sir.
What that 7, 9, 8, 9, 10 is, that should be mentioned. You
Yes, sir.
started off with glycated HbA1c,
Yes, sir.
but then when you are mentioning, it should be there, like, because it's a break in sentence and then you are mentioning, right?
Yes, sir.
It should be clearly labeled there that group 1 is this, group 2 is this.
Yes, sir.
Like that.
Thank you, sir. Thank you very much. Thank you. Thank you very much to all.
That was an interesting talk. Good luck, Mr. Gagandeep. For next presentation, I call Ms. Shaina Banu to talk about hepatic dysfunction in dengue fever, a biochemical analysis. Okay, as she's not available, we'll move to the next speaker. Call upon Dr. Sonal Chitroda to talk about the evaluation of knowledge and practice towards biomedical waste management among healthcare workers.
Good morning, everyone. Respected dignitaries on the dais and dear colleagues. First of all, I would like to thank the scientific committee and the whole team of ICMLS-2024 for giving me an opportunity to present my research work. Myself, Dr. Sonal Chitroda. I have MSc and PhD in Medical Lab Technology from Bhai Kaka University, Karamsad, Anand. Today I am going to present about the evaluation, the research project which we have done on the evaluation of knowledge and practice towards biomedical waste management among healthcare workers of Anand. So first of all, I like to disclaimer that the findings and interpretations and the conclusions which are expressed in this presentation are solely of the authors and do not necessarily represent the views of any institutions or organizations. All the data which are used in this study was collected and analyzed with full respect of participants' confidentiality and ethical standards. This research may have limitations which related to the sample demographics and regional context, which could influence the generalizability of the results. All the images which are used in this presentation either sourced from open source platform or created by me. They are intended for illustrative purpose only and not for any commercial use. So before that, I just want all of you to have a look of this, which have a small introduction regarding the biomedical waste management, how it can threat our healthcare work, community. So the waste that has been thrown out, that was in the water, and the persons who are using, the persons from the villagers who are using that water for the daily routine, they might get off infection. So many of the bacteria who cannot kill by this. So it can cause the other HIV, hepatitis B, all the antibiotic resistant bacteria. So coming to the research now, the background that we all know about this biomedical waste management. What is biomedical waste management? So managing biomedical waste management is essential for the
Sonal,
safety.
Excuse me.
Yes.
You have already shot up the time actually. The permitted time is only 8 minutes.
Yes, 8 minutes.
8 minutes. And you have already gone 6:37. Pause. I'm sorry.
It's okay, okay, sir. So managing biomedical waste management is essential for safety of healthcare workers, patients, and the environment. So improper handling of biomedical waste, which can spread diseases, contaminate the environment, and harm communities. So therefore, it is very crucial to have strong biomedical waste management system that prioritize safety, environmental protection, and compliance with regulations. So this study, it is focused on evaluating how healthcare workers in a hospital understand and follow the biomedical waste management practices. So that's why we investigated the difference between what healthcare workers know about biomedical waste management and how they actually handle it. So what need of the study? So first of all, it is a need to control the infections. So ensuring healthcare workers which have knowledge and skills properly to dispose of biomedical waste is essential for infection control. The secondary, to have a better practices at healthcare organizations. So we need to understand where the knowledge is lacking and improve safety and environment protections. And third, the compliance. That is understanding the current knowledge and practices that helps to identify the gaps in compliance with biomedical waste management regulations. So review of literature says that one study in 2024 done by Bhatia and Tandon that effective biomedical waste management emphasizes the importance of segregating waste at the point of generation to prevent contamination and ensure safe disposal. Another study that many healthcare workers exhibit poor segregation behaviors, leading to the increased risk of needle stick injuries and exposure of infectious waste. So many healthcare facilities lack the necessary infrastructure, proper biomedical waste management segregation and disposal, which leads to the increased risk of exposure and hazardous materials. The absence of the color-coded bins also and designated disposal areas, which also complicates the segregation process, resulting in improper waste handling. Healthcare facilities often lack the financial resources necessary for proper BMW management infrastructure and training. So another study that said that BMW management rules 2016 provides a structured approach of waste handling, yet adherence remains inconsistent. So barriers which are effective implementation include inadequate treatment facilities, lack of awareness among healthcare staff, insufficient monitoring, and challenges in adhering to the regulations, which will hinder compliance and ultimately impact public health and environmental safety. So the aims of the objective is to evaluate the adequacy of knowledge and practice concerning the biomedical waste management among various healthcare workers, with the objectives to assess the knowledge, and second, that is to what are the current practices being followed to manage the biomedical waste management by healthcare workers. And the third objective was to identify the challenges and barriers for the effective management of biomedical waste management. So methodology of the study, we coming with the framework of the methodology, we have generated phase 1, generation of the validated questionnaire, that all the questions were in the proper separation, that is expert review. We have done pilot testing, content validity, construct validity, criterion validity, reliability testings, and the revisions in if depending on this validity and the finalization. After finalization and validation of the questionnaire, we got for the ethical approval from the institutional committees, and then distribution of the questionnaire to the target populations. After that, we have collected the data, analyzed the data, and the disseminations of the results. So our target populations were the healthcare workers of the Anand district. So doctors, nurses, laboratory technicians, and grade 3 and 4 workers. So total healthcare workers, the study participants are 1910 healthcare workers, which includes 350 doctors, 600 nurses, 410 laboratory technicians, and 550 grade 3 and grade 4 workers, healthcare workers. So we have calculated the knowledge and practice score of that, and we found that the knowledge score are higher than the doctors, followed by the nurses, and so on. And the practice which are being followed for the biomedical waste management are higher in the doctors, followed by the nurses itself. So the main findings of this study is based that the age group, that is 20 to 29 age group, showed the higher knowledge, which shows that recent education may be more up to date. Designation wise, if we look, that doctors exhibited the higher knowledge and better practice compared to the others, that is the role specific interventions are need to, training and educations that is need. Workers with the higher education level showed the better understanding regarding the management of biomedical waste, that is the importance of continued professional developments, it shows the need. And the experience wise, that varied impact on knowledge, though it does not have any relation with the experience, because we have not shown any significant association with this experience. So balanced needed between fresh knowledge and the experienced knowledge. The barriers which we are identified during the study was the insufficient PPE kit and the color-coded dustbin at the hospitals, lack of education and training, insufficient waste management in the waste management staff, lack of incinerator and autoclave, lack of guidelines and policy, and lack of cooperation from local authority. Majority of the barriers were first two, that is insufficient of the dustbins, color-coded dustbin, and PPE, and the insufficient staff for the biomedical waste management. Limitations of the study, we lack the interventions. If we could have done the interventions, so that could have a greater impact of the study. So this study provides only an overview of current knowledge and practices, but cannot provide a direct link between the training and improved waste management practice. So it is a self-reported data. The study relies on information which is provided by the healthcare workers by ICMLS. So it is important to remember that people may not always be completely honest answering the questionnaires. So the conclusion of the study is that the inadequate knowledge and poor practices were observed among healthcare workers in Anand and Gujarat. Inadequate knowledge and poor practices were more prevalent in laboratory technicians and grade 3 and grade 4 workers compared to the doctors and nurses. And the third, insufficient PPE, dustbins, lack of instruments like incinerator, lack of proper guidelines, insufficient educational and training programs were identified as best possible barriers in effective management of biomedical waste management. So for the future directions, we have thought at our levels that we will do the targeted interventions in the Anand districts, conduct targeted interventions and longitudinal studies to track the effectiveness of interventions over the time, and identify the knowledge gap where the knowledge is where there is a gap in the knowledge and areas for improvement. And the future collaborations, we will try to foster collaborations between healthcare institutions and waste management agencies for the safe practices. Last but not the least, I would like to acknowledge all the participants. I would like to extend our heartfelt gratitude to all the doctors, nurses, laboratory technicians, and grade 3-4 workers who participated in the study. We are grateful to all the hospitals and healthcare organizations of Anand district of Gujarat for their support and collaboration. Special thanks to the Research and Ethics Committee for their guidance and approval. Heartfelt thanks to the Baikaka University Anand for their financial support for research and to participate in the conference. So thank you so much all for listening me. Thank you.
So very good, Dr. Sonal.
Yes.
So I have a few questions and comments. So one was with the data you presented, ideally it should be presented in percentages rather than absolute number, because it's easier to kind of find out which is better, which is not, if you have
Yes.
absolute number, because it will vary between the groups. So if you have a presentation in percentage, it would have given a more impactful information. Second is, how did you identify the barriers for the part of the question that do you find, do you have a questionnaire which you could show us?
So that is based on the questionnaire itself. We've asked the patients that what are the lacking at your institute that is hindering in the proper management of biomedical waste at their organizations, at their levels. So based on the validated questionnaire itself, we have identified that.
So do we have any study from India before yours that has identified the key problems in biomedical waste management in hospitals?
Yes, sir. I have in my review of literature, I have identified these two studies, which also states that
No, that's okay. You just tell me.
it also said that these are the most common barriers. I think they have also identified the most common barriers like insufficient PPE kit and the color-coded dustbins at their different areas.
Okay. Thank you.
Yes, sir.
Ma'am, it was a nice presentation.
Thank you so much, sir.
I just wish to know whether the subjects included in the study were from the same single institute or from different hospitals?
No, sir, it is from the different hospitals of Anand area.
Okay. Then what about ethical clearance? You have taken from all the hospitals?
No, our university, sir, it is a registered ethical committee over there.
Okay.
And in ICMLS-2024, it is registered on there. So we have got the approval from the Institutional Ethics Committee. We have initially validated our questionnaire, so that in the questionnaire was in both the language, local language, as well as in the English language, because we are including grade 3 workers also that do not have they do not understand the English language properly. And if the participants do not have access to the mobile phones, then we have taken into the hard copy. We have taken the consent from the hard copy itself. So it is approved by the Institutional Ethics Committee, and the questionnaires were also validated through our Hospital Infection Committee, which is very well maintained at our university itself, sir.
And did you take written consent from the participants?
Yes, sir, definitely. So we have included only those participants who have given the consent, sir. So in that questionnaire itself, sir, in the last statement, we have taken the consent, sir, and taken the signature.
Okay, thank you.
Thank you so much, Dr. Sonal. You have conducted very nice research because biomedical waste management is very challenging part of our health service. So I'm little bit surprised on your result you presented. Doctors
Yes.
has significantly very high awareness and knowledge
Yes.
about the biomedical waste management in comparison to nurses.
Nurses.
Others
Nurses
are
and
okay.
doctors,
So
there is a very less difference,
okay,
sir.
because I was just expecting doctors and nurses must have almost similar level of knowledge for biomedical waste management, even though you know doctors are highly qualified than nurses maybe in practice. So in the practical field, biomedical waste management of operation theater, laboratories, or every department, OPD or wards, nurses are more practically involved in biomedical waste management, I think. So another more thing, so in this regard, how can you explain why this difference is there?
Sir, actually, as you said, the doctors and nurses, because of their higher education level, they exhibit the higher knowledge better than the laboratory technicians and grade 3 workers. But if we see the laboratory technicians and healthcare workers are the main things who exposed to this biomedical management of the waste, because they have to segregate, and all the segregation process and the separation process, they are involved. As a laboratory technicians, we have needles and all the very cotton plugs, infectious materials, we are in contact with them. So we see that when we are employing educational and training need for that laboratory technicians and grade 3 and 4 workers who are more उनसे उनका ज़्यादा involvement रहता है for their management and segregation process. So they should be educated for that. So because they have less knowledge regarding that, because they are less educated, they have not properly trained, they have not training should be there.
I think it's okay. So finally, just I want to suggest one more thing. There might be a trained and non-trained professional in the hospital. So if you have any data between trained and non-trained one, then it can give us some new, insight for the further training requirement in the hospital.
Yes, definitely.
Just one another, sorry.
Yes.
I wanted to ask that just you have compared doctors to class 4 in between everyone, okay, nurses, doctors, laboratory technicians, class 4 employees. I think there may be something biased, because their education level is very high and their level education is very low. You cannot compare the both.
No, we have not.
I think you should have compared just within a category, that this percentage of this category did not have knowledge and this percentage, so that some solution can be taken out for them.
Definitely. Thank you so much.
Thank you. It was a wonderful presentation, and the number of questions asked itself suggests that it was interesting.
Thank you.
We
Thank
move
you
on
so
to
much.
next orator now.
Thank you. Yes. No, Anand city of Gujarat, sir.
Yes.
Anand city, in the
Yes,
city.
that is main study is it is cities. So this main study is on the cities, that is the urban areas only. But in district hospital, the situation is very bad. I have visited so many hospitals to district level. They don't have even the dustbin with proper color code. So this study is mainly on the urban area concern.
Yes.
And second, your view regarding the different categories have less knowledge.
Yes.
So there is a other factor also.
Yes.
And Dr. Mulkit has hinted to that side also, because this data is first of all come to the higher authority.
Yes.
So they knows better, and
Yes.
it takes a lot of time to come at the lower categories. This
Yes.
is also a basic questions.
Yes.
And that whatever you're talking, that this kind of knowledge should be distributed to lower category, that takes a lot of time.
Yes,
to
sir.
come at that
Definitely it will take a lot
level
of
also,
time.
in
Yes,
my
yes,
view.
yes.
Maybe something else.
Yes.
Thank you. Anybody else?
Yes. We have things at all the data we have submitted to the infection control committee to look after that and to identify the knowledge gaps. Yes, sir.
Thank you, ma'am, for bringing out
Yes.
the importance of biomedical waste disposal.
Thank you so much.
I'm a non-medical. Please
Okay.
pardon my question if it is wrong.
It's okay, sir.
In your video, you have shown three viruses which are spreading through water: HIV and hepatitis. So as far as I'm aware, HIV cannot be spread through air and water. तो आपने वो mention किया, please.
No, it cannot be sprayed through air and water, but
Yeah.
the initial way that we have seen that the waste containing the HIV infection, the blood, the cotton plugs that already have HIV infection, right? That is
Yes.
thrown off. But the HIV virus, it cannot be killed. It cannot be killed over that.
That is true,
So
ma'am,
that
but
can
it
be
is, in your video
transmitted.
you are showing it is going through the water.
Yes.
Water
yes.
channel, what I'm aware, it doesn't spread, ma'am.
Okay.
Maybe
No,
I'm
not
wrong.
HIV,
Yeah.
but my main aim is that there are many of the things that can be sprayed through. So
Yeah.
whatever waste we are throwing outside, so that are the common community who are living in the environment, so they might get affected.
Right.
for
Thank
that.
you. Thank you.
Nice observation, sir.
Yes, sir. It is nice.
I must say,
Yes.
Major Saab, you put up a very good question, good
Yes.
observation for that.
Yes, yes,
And
definitely.
thanks, Chitrada. We'll move on to next orator now.
Sir, one
Thank you.
question, please, sir.
Ma'am, we are running short of time. You can ask question later
it's
now.
related to the
it's-
questionnaire only, sir. It's related to the questionnaire. I just want to ask you,
Yes,
ma'am.
Yes.
The questionnaire you have selected for this, is it a standard questionnaire?
Yes, sir. I have already mentioned that it is validated through proper infection control committee and then institutional ethics committee.
Okay. All
And
right,
then
all
we
right,
have
all right. Thank you. Thank,
Thank
you.
you. Thank you so much. Thank you so much all. Thank you.
Okay, welcome. Next orator, please.
Good one, ma'am, and good luck to you. I request a couple of our speakers who haven't yet submitted their PPTs to bring them and submit them backstage. Ms. Dhruvi Patel, Ms. Priyanka Poddar, and Ms. Monu Kumari. I invite Ms. Ripal Sadhu to talk about the incidence and risk factors of surgical site infections in Parul Sevashram Hospital.
If I may start, before you start, I just want to make a short comment. Stick to questions, stick to timeline, and because timeline has also scored. And to the audience, I would request be precise in your questions, and if you miss out on some information which was there in the PPT, please don't put that as a question. Okay, otherwise I'll snub, right? Thank you.
Yes, good morning all. I am Ripal Sadhu from Parul University, Gujarat. So today I am going to present about incidence and risk factor of surgical site infection in our hospital. Introduction. What is surgical site infection? That is the infection, the definition provided by the CDC guideline, that infection within the 30 days of after surgery, and for the implantation surgery there is a time limit for 19 days. So that infection occurs within a 30 days, or in implantation surgery there is 19 days. That is a surgical site infection. So there are different infection types, that is superficial, deep incision and organ space. So these are different types of classification for surgical wound and patient risks. Surgical wound classification, there are 4 types: clean, clean contaminated, contaminated wounds and dirty. Then ASA classification, that is provided by the American Society of Anesthesiologists. Then analyzed risk index, that is provided by the National Nosocomial Surgical Surveillance. So that is the aim and objectives of my study, that is to determine the incidence and risk factor of our hospital. So this is method and study design. This is prospective and observational study. The 3 months data collected from the different surgery departments from the hospital. Sample size, that is 160 patients, was studied over a 3 months period. Then laboratory procedure, we collected the samples for swab and pus, then proceed in the microbiology lab. For the AST, we use VITEC system, and for inclusion and exclusion criteria, that is we select the patient above 18. So this is my result. We have incidence rate like 4.93. We collect the sample from, we have operations like 2,250 operations, and that 160 patients are observed for the SSI. From that 152 were analyzed. From that 99 culture positive and 53 are culture negative. So this is the bacterial profile. We have identified the bacteria like gram positive. They are Staphylococcus is the most common organism. There are 28 samples from the gram positive. Then gram negative, in that E. coli is most common organism. So here there is a correlation between pre and post-operative hospital stay. So we found out the positive correlation in the positive correlation in a post-operative like 0.007 p-value, that is the correlation. Longer pre-operative hospital stay were associated with an infection or developing SSIs. This may be due to greater exposure of the associated pathogen and potential changes in the microbial flora. So there is a correlation of SSI and wound class like ASS score. We study that the increased rate progressively with the higher wound classes, reflecting the greater risk contamination in more procedure. Additionally, with the patient ASS score greater than 2 showed a significantly higher SSI rate, 72.9, including that proper prospective health status is major risk factor for developing surgical site infections. Here that is NNIS risk index and duration of the surgery. So NNIS risk index increased from 0 to 3, the largest proportion, that is greater than 2, 69.4%. Then here there is correlation between during of surgery and the rate of SSI. Longer duration of surgery is associated with the high rate of that is 68.4. Adjusted analysis results show by the significant association and the occurrence of a surgical site infection like 0.00. That is a p-value. So that is the age-wise differentiate, that positive ratio was found be more in over 50 age group. The elderly were clear. It was been found that have both increased risk and severity of the infection. Adjusted analysis showed that a significant association between age and SSI. That is 0.0020 p-value. Then other comorbid condition like 50 patient with diabetes, 105 patient with anemia, 10 patient with CKD, 5 patient with AKI and 6 patient with hyperthyroidism. So there is a conclusion and recommendation. Key findings: the overall SSI rate, that is 4.93%. Staphylococcus aureus as the most common pathogen. Significant correlation between NNIS risk index, ASS score and surgery duration, impact of pre and post hospital stay on the SSI rates. So what are the recommendations? Implant and targeted patient surgery for high risk patient, optimize pre-operative patient health status, minimize unnecessary hospital stay, enhance pre-operative infection control measures, and conduct regular surveillance of the feedback and to surgical items. Then future directions, the future as it needed to evaluate the effectiveness of trial SSI prevention protocols, investigate the role of emerging pathogens in SSI, assess the impact of new surgical technologies on infection rates, develop predictive models on early risk assessment. These are the references. Thank you, all of you. Yes, sir, questions?
Any questions from audience? No.
So very good study, Ripple. So I just wanted to know, this was from just one hospital?
Yes, sir.
And the duration of study was how many?
3 months duration, sir.
3 months. So
Yes.
this was a big hospital, means you had almost 3,000, 2,200 surgeries?
Yes, that is the surgery count, sir. 2,257 surgery are done. From that, we have suspected 152 patients. From that, we are 99 something positive and 58 something negative of the bacteria.
And what kind of surgeries were these? These were like abdominal or all types?
All type surgeries.
Okay, so did you find any risk between abdominal surgery, thoracic surgery, neurosurgery, something of that sort was also analyzed in risk factors for infection?
So these are the longer duration of surgery also, then longer hospital stay also. Then some comorbid condition like diabetes patient and anemic patient also there, sir.
Okay.
Thank you, sir.
In very short period, as my co-chairperson told, you have isolated so many organisms.
Yes, sir, but I have less time, so
did you perform any antibiotic profile, antibiotic susceptibility profiles?
Yes,
did
sir.
you find any organisms?
Yes, sir. Isorius MRSA.
What about MRSA?
Yes, sir.
MRSA.
Yes, that is methicillin resistant Staphylococcus aureus.
No, how many MRSAs you isolated?
Sir, that study conducted by I have only found out the risk factors and SSI rate. The AMR pattern, that was my other colleague.
Okay, anyway. Okay, if there is no question from is there any question from audience? No? If there is no question, thank you.
Thank you, sir.
Next auditor, please. Dhruvi Patel.
Very good morning, one and all present here. Good morning, juries. I'm going to present a study of the serum magnesium level in chronic kidney disease patient with and without hemodialysis. As a management strategy, the study site was the primary care kidney clinic in Barodara district at Gujarat. According to the National Kidney Foundation, the CKD is defined based on the two values, EGFR, which should be minimum of 60 ml per minute, and the presence of albuminuria, approximately albumin creatinine ratio less than 30 mg per gram in 2 of 3 urine specimen which we are collecting for consecutive days. Here are the CKDs, limit of CKDs and the stages of chronic kidney disease which should be measured according to the EGFR value of the patient. Risk factor for the chronic kidney diseases are mainly hypertension, acute kidney injuries, age-related, gender, and obesity. As we know that magnesium, which is an important cofactor for the several enzymes and responsible for various essential metabolic functions, it is very important to measure serum magnesium level along with the serum creatinine while patient is on dialysis. Kidneys play a role in maintenance of normal serum magnesium which is a compensatory mechanism from by our body. It always reabsorbs magnesium in a deficient state and excrete excess of magnesium in magnesium overloaded conditions. The blood magnesium concentration is close to renal threshold of magnesium. Therefore, minor excess of serum magnesium is quickly excreted by the kidney. This is the side effect of, this should be considered as a side effect of dialysis. When patient is on dialysis, serum magnesium level varies on the after dialysis process. Healthy individuals with normal renal function approximately should be 1800 mg to 2400 mg magnesium filtered per day. Only 5% is excreted in a urine with normal patient. 95% would be absorbed by the nephrons in an area of ascending loop of Henle. Now, aim and objective of my study is to identify the significant differences between serum magnesium level in CKD, patient with or without hemodialysis as a management strategy. Objective that we have find out is to find any significant relationship in serum magnesium level and to study any difference in present serum magnesium level at different stage of CKD. The study was conducted at Vedanta Kidney Care, Vadodara, Gujarat. Sample size would be 82 samples. The study subjects were grouped in patients suffering with CKD. The number of patients identified is 41 and exclude the patient on hemodialysis. Study group 2, patients suffering from CKD on hemodialysis, the same 50% of ratio which we have taken is number of 41%, include only patients which is on hemodialysis. The age group was selected as an inclusion criteria is age above 35 year. Exclusion criteria, we haven't selected any patient which is undergoing with this cardiovascular diseases. The sample collection, estimated and data analysis. Group 1 and upon selecting 82 chronic kidney disease patient, we have distributed in a group 1 and group 2. We have collected the blood sample in a plain tube, serum was extracted and blood samples were analyzed for serum creatinine and serum magnesium level using a dry chemistry method on vitros, 5600 autoanalyzer by microslide method. All statistical analysis and generation of table and graphs were done using IBM SPSS software. The result is showing that group 2 was finding out higher magnesium level value in comparative to normal range. Group 1 is having low or estimated to fall under approximately the normal range. Group 1 CKD patient less likely to suffer from hypermagnesemia or hypomagnesemia, but other than that, group 2 CKD patient are more likely to suffer with hypermagnesemia. The numbers which I have shown in percentages, 65.9% normal serum magnesium level found in CKD patient, 29.3% patient has suffered with the hypermagnesemia and 4.9 patients suffered with the hypomagnesemia. 63.4% elevated serum magnesium level found in group 2 CKD patient and 36.6% serum magnesium level within the normal range. Here is the diagram shows about group 1 and group 2 statistical analysis. In our study, the null hypothesis was rejected. There was no equality in serum magnesium level of group 1 and group 2 patient, but the alternative hypothesis shown a positive correlation. Serum magnesium value of group 1 is not equal to serum magnesium value of group 2 patient. It was performed by using the independent sample test and the result indicated the rejected null hypothesis. This suggested that there is a significant difference in the magnesium level of the two groups. At concluding, serum magnesium level varied significantly between two groups. Group 1 individual have normal serum magnesium and group 2, most individuals in group suffered from CKD stage 1, 2, 3. Initial stage, a compensatory mechanism increases the fractional Mg excretion to the compensate for decreased renal function. Upon having dialysis, patient need a magnesium level for the normal metabolic process that was maintained by our body as a compensatory mechanism by losing out the fractional mg from the body. Group 2 individuals suffered from hypermagnesemia. Patients suffered from stage 5 where the compensatory mechanism shows inadequate and loss of renal function, inadequate to compensate for the loss of renal function. Therefore, hypermagnesemia was observed in the individuals. The limitations which has shown to our study is the sample size which we have taken are very less. Unlike previous studies, the research did not estimated serum magnesium level before and after hemodialysis for group 2 patients especially. That was also the rationale of the study. The researchers were not aware the medications and magnesium supplements that the patient is consumed. Ideally, it is found that along with the serum creatinine and EGFR, as a prognostic diagnosis, no clinician addresses the magnesium level. So it is also one of the changes in the guideline that they must have to look out the serum magnesium level regularly for the patient. The researchers were not aware of the dietary intake and lifestyle specifics of the patient. It was not considered in our study and not looked after for the diet and any other things that they have taken. Thank you. Thank you all.
Thank you, Ms. Dhruvi. So one of your secondary objective was to correlate the magnesium levels with the kidney stage disease, but I didn't see that analysis. Did you show a stage-wise analysis of? Your objective was to have a stage-wise analysis, but it was not shown.
Yeah, it was not present in the PPT, but we have made the percentage we have taken and the CKD patient which we have identified. This is based on the group-wise analysis. Due to limitations with the slide, we have just maintained in our data sheet.
Okay. Any questions from the audience?
It was really a nice presentation, Dhruvi. But one thing I would like to point out that in inclusion criteria and exclusion criteria of the study participants, we have mentioned that in group 2, there are the CKD patients without hemodialysis, right? So I think you have to mention, do you have mentioned the stages of, if I'm not wrong, all the patients after the stage 3 and 4, they all might have undergone the dialysis, I suppose. So in the previous stage only, they are without the dialysis. So could you have to find the patients on the stage 4 and 5 without dialysis? Ma'am, group 2 is with dialysis, group 1 is without dialysis. Okay, so the patients without dialysis, have you,
yes,
in your exclusion criteria?
We have categorized in a 1 to 3 stage of CKD patient.
Okay, so in the inclusion criteria, that you have to mention the patients with the stages of 1 to 3 only. That can be included in the study because the stages 4 and 5, they must have undergone the hemodialysis.
Yes, yes.
So that can be excluded.
Yeah,
Thank you. Thank you.
Thank you so much. For our next speech, to study the adverse reaction in allogenic whole blood donor at Parul Sevashram Hospital, Vadodara, I invite Ms. Priyanka Poddar.
Good morning, all of you. I am Priyanka Poddar. Assistant Professor, Paramedical and Health Sciences, a part of Parul University, Vadodara, Gujarat. Today I will discuss about my topic, the adverse reaction in allogenic whole blood donors at Parul Shivashram Hospital, Vadodara. So as you know, the blood donation is a very safest and simplest way to save the life. Blood donation is provide vital life-saving resources using in surgery, trauma care, and cancer treatment and other chronic conditions like thalassemia, sickle cell anemia, and other anemia. Blood components such as RCC, platelets, and FFP is highly in demand, making regular donation essential to ensure a safe and sufficient supply. Now, allogenic donation. Allogenic donation means one person blood is given by one person and used by another person. In this type of donation, including all blood components, offering flexibility in patient treatment. While whole blood donation is generally a safe procedure, most blood donation happen without any issue. But sometimes in small amount of donors are suffering from any side effect. It's called a adverse donor reaction during donation or after donation. Although this reaction are uncommon, the importance this reaction for blood bank ensure the donor safety and maintain the continuance of blood supply. Adverse donation in whole blood donor can include the various symptoms and issues that may happen during and after the donation process. The reaction range is mild to severe, serious problem that may medical emergency also. They need a medical emergency also. Knowing about and managing this reaction is important too for blood donors, healthy and safe. Adverse reaction in whole blood donors can multiple causes, including specific donor criteria, procedural aspect, and other is the health condition of donor. The donor experience like vasovagal reaction, then allergic reaction, hematoma, nerve damage, and infection. Now, factor influencing adverse donor reaction in three criteria: donor characteristic, procedural factor, and health condition. In donor characteristic factor like age, gender, body weight, donation history affect the donor chance to having a reaction. Second is procedural factors. The phlebotomy skill, donation setting, and equipment use can also play a crucial role. And additionally, some health condition not detected during screening. When the donor's form is, we have feel the screening time might lead to unexpected reaction. Now my study objective. My primary objective is identify and classifying adverse reaction in whole blood donation. Specific goal: examine the frequency of adverse reaction, analyze the demographic factor like age, gender, and weight influencing reaction occurrence, and third is development recommendation to enhance donor experience and safety. My study design retrospective. I had done retrospective study. I had taken a total 6 months of data from Parul Shivashram blood bank. I had observed total 6,030 donors during my study, and 49 donors are affected from the adverse donor reaction. My excluding criteria: voluntary and replacement both donor, considering age, gender, weight, and donation history, and my excluding criteria: addiction to tobacco or smoking. Now my methodology. Study's methodology was carefully structured through the capture and assess the adverse reaction among the blood donors. Throughout the donation process, from initial registration to post-donation care, donors were closely observed for various signs and symptoms of adverse reaction. These symptoms included anxiety, increase the breathing rate, then pylore, sweating, dizziness, yawning, nausea, vomiting, then slow pulse, convulsion, and abnormal movement. Ensure the safety intervention in case of any emergency. Essential medication and the oxygen cylinder were kept readily to available. Here the three methods are used for acquired data: on-site observation, donor call, and blood bank follow-up. On-site observation, real-time monitoring of blood during the donation process for immediate reaction. Then recording of adverse reaction reported by donor after leaving the donation site. And third is blood bank follow-up. Proactive calls to donors to inquire about the delay adverse reaction. All data gathered in the Microsoft Excel 2007. Now result of my study, total 6,030 donors were noted, of the which 1,025 voluntary and 5,005 is replacement donor. Among the 6,030 donors, 49 male donors were suffer from the adverse donor reaction. 16% donor will suffer from class as a voluntary donor, and 84% class as a replacement donor, which are affect from the adverse reaction. Here in chart the 0.8%, very low percent, is suffer from adverse event among the all my study. This graph shows the number and percentage of adverse reaction which are shows in the different types of donor. The very less amount of adverse reaction is coming in donor, very lightly, like sweating, giddiness and hematoma sees very more number in the reaction. But the serious like cardiac arrest, nerve damage and loss of consciousness is not noticed. So the conclusion is my study is donation is blood donation is generally safe with a good safety record. Some more common complaint is tiredness, sore arm are the most frequent complaint among the donor. Now improvement opportunity, addressing these common complaint may the improve donor retention rate. And reaction affect to renal, negative reaction significant lower the chance of future donation. No clear predictor, no specific factor has been identified as a significant predictor of return rate after the reaction. These all are my references. Thank you all of you to attending me.
Thank you, Priyanka. It was a good study, an important topic. So just one question. So is it a routine practice at your hospital to call the donors after they leave the blood bank and ask for adverse reaction, or it was only for the study purpose?
No, sir. I'm routine doing the blood donation because I'm from the technical supervisor in blood bank. I have a total 6 years experience in blood bank.
So do you guys call the patient, the donors specifically after maybe 1 day, 2 day, or it is just a retrospective information whatever the donors gave to the blood bank?
Sorry sir, pardon.
So did you call, आपने patients को call किया था blood bank से जाने के बाद कि आपको कोई reaction हुआ या?
सर ये हमारा प्रोटोकॉल है हमारा ब्लड बैंक का कि हमें मतलब वहाँ कोई ऑब्जर्वेशन दिख रहा है तो हम जाने के बाद वैसे डोनर्स को कॉल करते हैं कि आपको बाद में कोई एडवर्स रिएक्शन आया था. और ड्यूरिंग माय स्टडी आई वाज इन ब्लड बैंक, सो मैं अपने हिसाब से कॉल करती थी कि आपको कोई रिएक्शन आया है यहाँ से जाने के बाद, क्योंकि कभी कभी ऐसा होता है कि डोनर जब रिप्लेसमेंट डोनर होते हैं स्पेशली, वो जाने के बाद उनका जो हेक्टिक होता है, मतलब उसका पेशेंट वहाँ एडमिट है, उसका जो पूरा शेड्यूल है वो अप डाउन होता है, हाइड्रेशन ठीक से नहीं होता है, तो उसको बाद में जाके रिएक्शन आता है. तो हम फॉलोअप ले रहे थे. मैंने जब ये स्टडी किया तो स्पेशली वो 6 मंथ मैंने पूरा फॉलोअप लिया था डोनर को कि जाने के बाद आपको कोई ऐसा रिएक्शन हुआ है कि नहीं हुआ है.
Okay, okay, good. Thank you. Any questions from audience?
Okay.
Hello. It is good study, but madam, I want to know that the person who donated the blood, volunteer and a replacement, I think volunteer cannot told everything, whatever, whether is affected by some disease or not. In the replacement, there are chances that is not revealing that things. So have you asked those people who have donated the blood and reactions has been taken place to the recipient.
For replacement donor, sir.
जैसे कोई donate कर गया blood,
क्या sir?
आपने कहा whole blood में
हाँ.
there is a reactions to the recipient.
हाँ.
तो उनको भी आपने फोन करके पूछा था कभी कि उसमें कुछ
हाँ सर, मैंने सारे होल ब्लड डोनर्स ही लिए हैं सर, रिप्लेसमेंट और वॉलंटियर।
ऐसा है तो why it is so?
Why?
ये जो रिएक्शन हुआ तो क्यों हुआ इसके बारे में कुछ?
हाँ सर, वो कोई ऐसा मतलब कोई फैक्टर सामने
अभी
नहीं
सामने
आया
आया
कि नहीं कि एज की वजह से या कुछ। हम इतना जान सकते हैं कि रिप्लेसमेंट डोनर में ज़्यादा दिखाई दिया है, क्योंकि फर्स्ट ऑफ ऑल तो उस पर प्रेशर होता है ब्लड डोनेशन का, और सेकंड कि उसका जो हाइड्रेशन स्टेटस और उसका जो मेंटली स्टेटस होता है वो भी उस टाइम ठीक से नहीं होता है, क्योंकि उसका खुद का पेशेंट अगर वहाँ रिलेटिव वहाँ एडमिट है इसलिए। सो इन रिप्लेसमेंट डोनर वी आर शो द हाई नंबर ऑफ एडवर्स रिएक्शन अमंग द वॉलंटरी डोनर। थैंक यू वेरी मच।
Thank you, Ms. Priyanka. For the next talk, I would like to invite Ms. Nalli Arasi R to talk about the evaluation of serum hepcidin and its relation with glycemic status in gestational diabetes mellitus.
A very good morning to one and all present over here. I'm Nalli Arasi, Medical Biochemistry PhD full-time scholar from Mahatma Gandhi Medical College, Puducherry. Today I will be presenting my research on evolution of serum hepcidin and its relation with the glycemic status in the gestational diabetes mellitus. Mine is an interdepartmental research, and I have done with the collaboration of Department of Biochemistry and Department of Obstetrics and Gynecology. So let's move on with the introduction part. First I will be starting with the gestational diabetes mellitus. So here, gestational diabetes mellitus, it's a glucose intolerance that is diagnosed during the pregnancy, and the prevalence of is about 7 to 25% of the pregnant women were affected globally. So the study imparts the clinical significance as increased amount of the adverse maternal and fetal outcomes. So the study focused on the role of serum hepcidin and the electrolytes, especially the sodium potassium chloride, as the potential markers in the GDM. So I'll be walk through the rational, methodology, clinical findings, and the clinical implications of my study. So the background and the rationale of the study, here the hepcidin, a liver-derived peptide hormone, and it is a key regulator of iron metabolism that influence the iron in absorption and glucose homeostasis. And the electrolytes are altered, such as the sodium potassium chloride, are associated with the glucose metabolism and the fluid balance in the diabetes. So the aims and objectives, the aim of my study is to explore the diagnostic and prognostic potential of hepcidin and electrolytes in managing the GDM. So with the primary objective, I'll be moving on with the assessment of serum hepcidin levels and the electrolyte concentrations in GDM patients. Following the secondary objective to evaluate the diagnostic potential hepcidin and its correlation with the glycemic status. Thus, the research hypothesis of my study is of serum hepcidin levels are altered in GDM and it correlates with the glycemic status. So, with the methodology of sample size calculation from the review of literature, I have taken with the women with the GDM was taken as 15.3 plus or minus 9.3 from the review of literature, and by assuming the alpha of 0.05 with a precision of 15% of the mean, the sample size was about 68 plus 68, that is the 68 cases, and the equal age of the parity and matched controls were included in the research. And the study parameters are followed by the serum hepcidin levels and measurement of serum sodium potassium chloride and the non-fasting blood glucose level with respect to DIPSI criteria. So the materials and the methods, the study design comprises of the prospective case control study conducted over 1 year. Thus, the sample population was included from the patients who are attending the obstetrics gynecology OPD during their particular trimester or second trimester with a 24 to 28 weeks of gestations, and the assay principles were carried out for hepcidin through the ELISA, and for electrolytes we are using ion selective electron method, and for non-fasting blood glucose level, GOD, POD, glucose oxidase peroxidase method was carried out. And here the inclusion criteria, we have included the patients who are attending the obstetrics and gynecology OPD during the second trimester of 24 to 28 weeks of gestation, and the GDM diagnosis per DIPSI criteria were included, and we have excluded the hypertensive disorders, pre-gestational diabetes diseases, acute and or chronic inflammatory disease, prior liver or renal disease, multiple gestations, and iron deficiency anemia of less than 8 gram per deciliter were excluded from our study. So the data analysis were carried out by the Mann-Whitney U test for the comparison of the groups, and Spearman correlations were carried out for the relation between the variables. Thus, the ROC curve was carried out for assessing the diagnostic performance of serum hepcidin and glucose. Thus, the result shows here the comparison between the controls of normal pregnant women and the cases of GDM who were diagnosed GDM with the DIPSI criteria. Here, the serum hepcidin levels was shown in the middle was the normal level, and in the cases criteria, the hepcidin level were higher, and in the sodium, potassium and chloride, in potassium there was no appropriate change, and in sodium and chloride here we can see the levels were low, and with the p-value of 0.01 was considered to be the statistical significance. And here the result of serum hepcidin levels, we can see here that there is an inclined curve of the scatter diagram towards the right, and it shows a positive correlation. Thus, the serum hepcidin levels are higher in GDM people with a range of 10.46 nanogram per milliliter, and the controls of 7.5. Thus, the statistical significance was found to be p is equal to 0.001. And here, with the alterations of electrolytes, we found the inclination in the left side, that is the negative correlation. Thus, the finding states the lower sodium and chloride levels in the GDM, and which is of less than 0.001, the statistical analysis was done. And here the correlations between the hepcidin and blood glucose and the sodium blood glucose and chloride and glucose were shown. And the interpretation was hepcidin was positively correlated with the glucose, and sodium and chloride levels decrease as the glucose increases. Thus, the ROC analysis here proves that hepcidin is a diagnostic marker, as it shows a moderate diagnostic marker with an area under curve of 0.91 with the sensitivity and the specificity. And for the glucose, here we can see the diagnostic criteria, which is a standard golden method for analyzing the GDM people. Thus, the ROC curve analysis for hepcidin reveals that it is a diagnostic marker when compared to the DIPSI criteria people. And thus, the discussion of my study here is elevated hepcidin level and reduced electrolyte levels in GDM suggest a metabolic changes linked to the glucose regulation. Thus, the diagnostic potential of hepcidin moderate, but the value as a complementary marker. Thus, the clinical relevance is of potential for hepcidin to support the early diagnosis and monitoring. And in the elevated hepcidin of GDM, increased levels may be linked to the inflammatory markers and oxidative stress pathways impacting the glucose metabolism. Thus, the glucose-induced hepcidin increases suggest a compensatory role for the hepcidin in response to hyperglycemia. In iron metabolism, the impact is of the hepcidin role is in iron regulation could contribute to impaired insulin sensitivity. Thus, Shang et al. In 2023 proved that elevated hepcidin in GDM aligns with the glucose dysregulation, and Durbin et al. Proves that the strong link between the hepcidin and the glucose metabolism that supports our reference articles. And here the electrolyte disturbances in the GDM findings were lower sodium and chloride levels in GDM suggest to the hyperglycemia induced osmotic diuresis. So the inverse correlation, which was lying on the inclined on the left side, reveals that the sodium and chloride levels are inversely related to the glucose, indicating that the electrolyte shift reflects GDM associated metabolic stress. And these were the supporting references from Park et al. In 2023 proved that electrolyte disturbances in diabetic conditions due to the osmotic diuresis, and Rodriguez et al. Found similar electrolyte shift in GDM, emphasizing sodium and chloride roles. Thus, the limitation of my study is of a cross-sectional design, single center study, lack of inflammatory marker measurements, and the potential is of using the hepcidin and electrolyte profiling as an adjunct tool for early diagnosis of GDM screening. Thus, the research priority could be of longitudinal tracking, hepcidin and electrolytes, and the mechanistic studies on the glucose-hepcidin interactions. Thus, my study correlates with the hypothesis, as my hepcidin shows a promise GDM marker but with a moderate diagnostic accuracy, and the electrolyte disturbances highlight the metabolic shifts in GDM. And the final insight is of potential for novel biomarkers in improving GDM detection and management. And I thank you all.
I just one comment that if you would have done an iron levels or iron profile of these patients, maybe that kind of contributed as a, if you have a kind of factor which is affecting the both sides. If you had a difference in iron levels or iron profile of the control in cases, your hepcidin levels would also vary based on that.
Okay.
So I think that's one thing. Otherwise, I feel it's a very important topic and a very good insight into the metabolism of iron and glucose in pregnancy. Any questions from others?
Any questions from the audience? From you, please.
Thank you so much. This is, I think, very nice study you have done. And given the results, those are correlated with the mechanistic, mechanistic correlation is almost clear, showing relation with the insulin resistance, right? So just I want to ask a small question, because this research is of good impact. So what could you say the relation of histidine with glucose transporters?
Is because hepcidin is an important key regulator of the iron metabolism that involves in the absorption and distribution of iron into the bloodstream. Here, the glucose is linked with as it induces the inflammatory markers, such as like low grade of inflammations, and the diagnostic criteria could be efficient for analyzing as it regulates the iron and glucose metabolism. So it is it could be a better marker.
Okay, it's okay. So again, your results showed this could be a good marker for GDM, I think,
yes,
right?
Sir. According to
So
the DIPSI criteria.
for the GDM, we have a glucose testing and glucose challenge test. So over this test, how hepcidin can work as a marker? What is more benefit?
As it involves the iron metabolism. So when the pancreas.
Okay, thank you so much. Just you have to answer somewhere. Any question, please?
Okay, thank you so much.
Thank you.
Wonderful presentation.
Thank you.
Next orator, please.
Good presentation, Ms. Nalliarasi. I call upon Mr. Aditya Tanwar to come and talk about the seroprevalence of scrub typhus.
Good morning, one of all present over here. My name is Aditya Tanwar from VMMC and Safdarjung Hospital. Today, the topic of my oral presentation is seroprevalence of scrub typhus. So for the introduction of scrub typhus, it is an acute febrile infectious illness caused by the obligate intracellular gram-negative bacterium, that is Orantia susugamushi. So it is transmitted by the bite of an infected trombiculate mite larva, which is also known as chigger. As you can see in the top right corner, that's how a chigger looks. The symptoms of scrub typhus include fever, chills, headache, body aches, and these are the non-specific symptoms of scrub typhus. And one of the common and the specific symptoms of scrub typhus is a scab-like region at the chigger bite site, which is known as eschar. You can see in the bottom right. The aim and the objective of this study is to check the seroprevalence of scrub typhus, and this study was also conducted to compare the results of different diagnostic tests available, like rapid immunochromatographic test or the IGM-ELISA. So first of all, it's an prospective observational study, and the cases were selected from the outpatient and inpatient departments of Safdarjung Hospital, and total of 1762 samples were collected and tested. In the materials, 2 ml of blood was taken from each patient in a serum separator tube, and the testing kits that were used were the J. Mitra's IgM-ELISA kit and the J. Mitra's rapid immunochromatographic test cards. As you can see in the figure 1, it's the IgG and IgM rapid card, and in the figure 2, it's the IgM-ELISA kit. A total of 1762 blood samples were collected and tested, and after the testing was done, the results were recorded. As you can see in the table number 1, it's the serological testing done by the ELISA. The total number of patients, as mentioned before, was 1762, and only 84 samples came out to be positive, and the positive percentage is 4.76%. And in the table 2, you can see the rapid card serological testing, and in this only 85 samples came out to be positive out of 1762, and its positive percentage is 4.82%. All the samples were tested on rapid card and the ELISA both, and we observed that only 66 samples were positive by both ELISA and the rapid cards. So for the results, total of 1762 samples were tested, as mentioned before, and only 85 samples were positive by the rapid card alone, and 84 samples were positive by the IgM-ELISA. In the end, the 66 samples came out to be positive by both rapid card and IgM-ELISA. So the overall prevalence of scrub typhus based on the serological testing came out to be 3.74%. So for the discussion, that's the most important part, I guess. The scrub typhus is a common cause of undiagnosed fever in the tropical parts of the India, but can be challenging to diagnose due to non-specific symptoms, as I mentioned before. These symptoms usually overlap with other diseases, and in the end it can be misdiagnosed. The results of this study suggest that serological testing, particularly ELISA, can help identify the scrub typhus in patient presenting with a fever of unknown origin. And if we compare the rapid card and the ELISA came out to be more sensitive, and rapid card may also have the utility but for initial screening only. This study also highlights the need for larger prospective studies using more sensitive and specific tests to better understand the true burden of the scrub typhus. One of the most important, or we can say that the most sensitive test for scrub typhus is the IHA, the immunofluorescence test, but it usually requires more expertise, and it's quite expensive. That's why it was not used in this study. The improved diagnostics critical to ensure timely and appropriate treatment and to guide public health interventions to prevent and control this neglected tropical disease. Rapid tests could provide a quick initial assessment but should be confirmed with ELISA or other more definitive assays. So for the acknowledgement, I would like to thank the Department of Microbiology of Safdarjung Hospital, especially Dr. Samir Vyas and Dr. Monica ma'am. Through their guidance and scholarly guidance and advice, I could successfully complete this study. These are my references, and thank you.
The study was nice. I just wanted to know whether you checked the sensitivity and specificity of both these tests in your study? Sensitivity of ELISA and sensitivity of the card test.
So the ELISA is usually more sensitive than the rapid cards because the rapid can usually...
You have not shown here whether you checked the sensitivity and specificity?
So we checked, but we did not mention in the PPT.
Or otherwise, the study doesn't show anything different from others. There are so many studies which show such results.
Yes, sir.
The big thing was if you could have suggested some sensitivity and specificity of these tests in your study.
Okay.
Any question from the audience? Okay, if there are no question, thank you.
Thank you, sir. Thank you, everyone.
Good luck, Mr. Aditya. To talk about the promise of dyes for an effective solution in diabetic nephropathy detection, I call Ms. Monu Kumari.
Good morning, everyone. Today, I would like to share a piece of my work with you, which is the promise of dyes for an effective solution in diabetic nephropathy detection. Diabetic nephropathy is silent yet devastating complication of diabetes affecting millions worldwide. So the detection methods or the early detection could save countless lives, but the methods or the existing methods, they often fall short. So I'll share with you how the diagnostic dyes are poised to revolutionize this space and offering early and accurate detection will journey through the challenges, the science, and the promise of these fascinating tools. Microalbuminuria, which is 30 to 300 mg of the protein excreted in the urine per day, is a critical biomarker for diabetic nephropathy, and its early detection can significantly reduce its disease progression. The most popular methods for diagnostic, they are immunoassays and the dye-based assays. Immunochemical-based methods where cannot detect the immuno-unreactive albumin fragment that is generally present in the diseased condition, whereas dye-based methods, they are not specific for albumin as they cross-react with the other proteins that are present in the samples, leading to the false positivities. So the basic idea, we wanted to keep the ground simple and to innovate a dye-based method, which is with more sensitivity and specificity for microalbuminuria detection. Coming to the study aim and objectives, the aim is to study a dye-based method again, which is more sensitive and specific for detecting albumin at microalbuminuria levels in diabetic nephropathy patients. To achieve our aim, we have studied or we have performed the in silico screening, in vitro validation, and in clinical studies. Under in silico screening, the molecular docking study was performed to check the interaction of dyes with human serum albumin and other proteins that are excreted along, and the proteins were human serum albumin and alpha beta gamma globulins, alpha 2 macroglobulin, transferrin, and immunoglobulin G. The dyes that we were considered were amido black as a control dye, bromocresol purple is a dye which is being used in a clinical biochemistry for albumin estimation, and fast green. Autodoc and Gold were the softwares we have considered for such screening. The different residues of human serum albumin, alpha 2 macroglobulin, immunoglobulin G, and human serum transferrin were considered for such screening. Under in vitro validation, the electrophoretic and spectroscopic techniques were utilized to test the sensitivity and specificity or dyes for human serum albumin. Agarose gel electrophoresis, absorbance and fluorescence study was performed for such purpose. Under in clinical testing, the dyes which we have selected from in vitro study, in silico and in vitro study, we have tested the dyes again, the urine samples of diabetic nephropathy patients with microalbuminuria and overt albuminuria along with their healthy and diabetic controls. Patient samples were 30 each for each category, 30 for each category. Protein dipsticks and immunoturbido method were used to categorize these patients again after I've collected them from OPDs. Native page electrophoresis was performed, followed by fluorescence gel imaging to check the sensitivity and specificity of the dyes under in clinical studies. Coming to the results from objective 1, which was performed from Autodoc, which explored the interaction between human serum albumin and other proteins that are excreted along in the form of binding energy and or interaction energy. So for example, fast screen has shown the binding energy or interaction energies highlighted in red means the dye is interacting much more with that particular residue of protein. The binding energies which were highlighted in green, that means the dye is interacting lesser with that particular residue of protein. Coming to the results of in silico screening that was done using gold software, which explored the fitness score of the dye interacting with human serum albumin and alpha beta gamma globulins. This is for human serum albumin and this is for globulins, alpha 2 macroglobulin, immunoglobulin G and human serum transferrin. This is the concluding table from in silico screening, where we can see that fast screen has interacted with 7 different residues of human serum albumin showing low free binding energy and 2 residues under the gold software. At the same time, Comasi Brilliant Blue has shown 13 interaction with 13 different residues of human serum albumin under gold software, but the dye also interacting with globulin, 9 different residues of globulins. Bromocresol purple under such criteria was not able to show any interaction. So from this data, we can say that fast green has demonstrated the highest interaction energy with HSA as compared to globulins on the basis of the results produced from Gold Score and Autodoc. Coming to the result or the electrophoretic results of in vitro screening, the agarose gel electrophoresis was performed with the different samples, for example, plasma, albumin formulations, and pure proteins. Coming to the plasma, 1 to 10 microliter, after 15 minutes of staining, fast green and bromocresol purple was able to stain albumin predominantly, where fast green, where the bands, albumin bands stained from fast green was much more prominent, or the band density was much more than that of bromocresol purple. After overnight destaining, all the dyes were able to stain the different proteins present in the sample. Coming to the results from albumin formulations, 20%, after 15-minute staining, bromocresol purple and fast green both have stained albumin, but after overnight destaining, the bands or the albumin bands stained from fast green were much more prominent or intense than that of bromocresol purple. Then the dyes were also tested against pure proteins, which is human serum albumin and alpha beta gamma globulins, where we can see that after 15-minute staining and 20-minute destaining, fast green was the only dye which was able to stain albumin predominantly, where other dye, that is bromocresol purple, was not able to do so. After 1 hour of destaining, fast green could sense albumin with negligible binding to globulins. For your information, the gel, the picture which I'm showing, the first well, the second well is for human serum albumin, the fourth one is for transferrin, sixth one is for IgG, and the last one is for alpha 2 macroglobulin, where we can see that fast green was able to stain albumin only. So fast green tends to be more sensitive for human serum albumin, as it was able to detect 13 microgram of the protein. Coming to the spectroscopic results of in vitro screening, where the dyes were tested under absorbance spectroscopy ranging from 230 to 700 nanometer. Amido black, which is a control dye, was able to bind to human serum albumin, but there was no gradient effect which was seen when the protein was varied. Upon IgG addition, the dye again has shown enhanced absorbance. In case of fast green absorbance was increased with varying HSA doses, but it was decreased when the IgG was added. So this was the unique result which dye has shown under absorbance. Bromocresol purple, which was the comparison dye, has shown absorption maxima. It was decreased upon addition of either of the protein, if HSA or with immunoglobulin G. So here also IgG tends to be uniquely showed a significant increase absorption with human serum albumin and decrease with IgG, highlighting its distinct interaction with these proteins. Coming to the spectroscopic results of the dyes when tested under fluorescence spectroscopy from the excitation 300, emission 600. When the dye was tested at the concentration 0.10 micromolar of the protein with 15 micromolar of dye, the dye has significantly shown the stronger interaction with human serum albumin than with IgG. At lower protein concentrations, the dye was able to show the fluorescence increase with human serum albumin, indicating its specificity and sensitivity of detection as compared to globulins. For your information, the red one is HSA, blue one is IgG, transferrin is green, and the orange one is alpha-2 macroglobulin. The fast screen detects as low as 13.5 nanogram of HSA, demonstrating its higher sensitivity for albumin. These are the clinical results that I've produced. The dyes were tested against the patient samples of microalbuminuria and overt albuminuria, where bromocresol purple dye was able to stain all the proteins that were present in the sample, and fast screen was able to detect or stain albumin which was just present in the sample. Conclusion slide, again the same which I've discussed. I would like to thank Dr. Dibya Jyoti Banerjee for guiding me throughout, and the CSIR for providing me the funding assistance, and the ethical clearance was obtained initially with a wide number this, followed by the picture of my lab. Thank you.
So excellently done and excellently presented, Monu, and I was actually waiting for the clinical results which you had to kind of rush through. But I think this is something which needs much more clinical validation now, since you have actually proved it in lab work.
Yes.
So probably that sample size of 30 has to increase, and then a clinical validation of this has to be done along with the outcomes. Because
Yes.
you don't know if you pick up it early whether you can actually improve the outcomes.
Yes.
So that's the next step which you should do with your endocrinology department. Okay. Very good work. Thank you.
Thank you, sir.
Any questions from the audience? Okay. Thank you. Very well presented. Okay.
Thank you, sir.
Good luck, Ms. Monu. I now call Ms. Diksha Gagar to talk about the prevalence of carbapenem-resistant strains of Klebsiella pneumoniae isolated from various clinical samples by using Vitek-2 in a tertiary care hospital.
Good morning, one and all present, to all the faculties of respected colleges, hospitals, and all the judges. So my topic is prevalence of carbapenem-resistant strains of Klebsiella pneumoniae and isolated from various clinical samples by using Vitek-2 in tertiary care hospital. So first of all, it is very important for us to know that what is carbapenem resistance. Carbapenem is a kind of antibiotic, a beta-lactam antibiotic, which is being given to the patients suffering from the infections, especially who are admitted in hospitals and having the nosocomial trend, which is now being increasing. And this kind of infection, nosocomial infection, that is hospital-acquired infection, is much more being caused these days by Klebsiella pneumoniae. But the problem here comes is the threat of antimicrobial resistance, which are nowadays called as AMR. And in this topic, the main focus is being done on seeing what is the prevalence rate of carbapenem resistant strains that are present in the hospital. So there are many drug resistant strains, and the antibiotic through which the resistance of carbapenems has been observed is ertapenem, meropenem and imipenem, which are prescribed as the antibiotic therapy for the patients having the Klebsiella infection. So infections that include in the hospitals, they were covered like septicemia, bloodstream infections, surgical site infections, UTI, and many more. And in all of them, the most common cause of worry was the intensive care unit, ICUs, that were most predominantly found in my study having the carbapenem resistant strains. And in this carbapenem resistance, so the basic mechanism of carbapenem resistance is being taken by the production of the enzyme which is known as beta-lactamase, and this beta-lactamase is now offering the resistance to various kind of beta-lactam antibiotics. And in my study, the beta-lactamase enzyme, the class beta-lactamase enzyme, and particularly in my study it has been taken as carbapenemase. So the aim and objective of my study was to study the prevalence of carbapenem-resistant Klebsiella pneumoniae, and in this present study, an attempt was made to detect the carbapenem-resistant Klebsiella pneumoniae from various clinical samples in a tertiary care hospital from Dehradun, Uttarakhand. So the methodology was, it was a prospective observational study, and the time period was a bit short, that is January 24 to March 24, and all the clinical samples that we included in our study was the skin lesions, CSF, sterile body fluids, abscess, pus, ET, bowel samples, and all the tips. And all these samples were processed in Vitec 2 in the central laboratory facility of Sri Mahendra Hospital, Dehradun. Now these strains were being processed under CLSI guidelines in Vitec 2 with the MIC detection of the carbapenem-resistant Klebsiella pneumoniae. So here I begin with my results. So the carbapenem profile of Klebsiella pneumoniae isolates, the total sample size was included was 74, and in that 74 sample size, the 54 samples were found to be resistant with the carbapenem antibiotic. Then we have 18% that were sensitive and 3% that were intermediate. So you can very well appreciate the fact that the resistance is increasing day by day. So then comes the gender-wise distribution that the samples were taken. In that, the most common percentage, the most high percentage was from the males, that was 61%. And now most important thing, that the clinical samples that were being taken. So as I said, there were many clinical samples taken, and in all of the clinical samples that were taken, the most predominant clinical sample that was being found was urine sample showing 35% resistant strains of Klebsiella pneumoniae that were being found in this particularly sample, followed by the blood culture, then suction tip, then pus, then sputum, ET, endotracheal tips, bone marrow aspirations, EIF is intra-abdominal fluid, and BAL is the bronchulo-alveolar lavage. So this was the ward-wise distribution. So it is the problem of worry that the most of the samples were being obtained from ICU, intensive care unit, then comes the medicine ward, then gynae, then surgery, and then ortho. Now the resistance of carbapenem antibiotics. In the resistance of carbapenem antibiotics, the three most common antibiotics that can be taken as the treatment protocol can be meropenem, imipenem, and ertapenem. And the kind of resistance that was observed is very close in all the three antibiotics that was being taken, such as in meropenem, it was 73%, in imipenem 71, and in ertapenem 70%. So we can easily see that the percentage level in all the three carbapenem antibiotics is very much close. So here comes the discussion. So all my results were being properly taken from the lab, and these results were correlated with many research publications. So the sample size that included as 74 sample size, among them 54 that were found to be resistant, in this kind of, this result was being comparable with the study that was taken in 2015. Although the study is old, but still from then we can see that for how long time period back, the same kind of pattern is being continuously observed, that the resistant profile is still the same. Now we are in 2024, but still the resistant profile that was observed in 2015 and now we are dealing is all togetherly same. Then the gender-wise distribution that was also being taken from a study. Now, the samples that were being taken, and in my study, as the maximum samples were, maximum sample size was taken, and in that case, the maximum percentage were being shown by the urine sample, and this study is shown by the similar kind of study by in 2017. And in ward-wise distribution, as the maximum percentage of samples of resistant samples were being taken from ICU, and a similar kind of study was taken in 2017, where the same pattern, a complementary finding was also being taken, and the maximum samples were being taken from ICU. Now, in the resistant rate, all the antibiotics that have been taken, like imipenem, meropenem, ertapenem, the three most common antibiotics that are usually prescribed, these antibiotic profile that was being matched exactly with those taken from the study in 2012 also. So, as this was a small scale, small research that was being taken, a small study, but the further kind of research perspectives is still being added continuously to the research, that we are going to find about the enzyme which is responsible for causing this resistance, that is the carbapenemase enzyme. So we are trying to detect this carbapenemase, presence of carbapenemase enzyme in all the resistant samples through carba-NP test. And then after, we will go further with the genotypic detection that involves the gene presence, that is black APC gene, that is responsible for causing the resistance genotypically in all the Klebsiella strains. So in this case, all the microbiologists are being continuously studying about the AMR trends that is continuously being increasing, because nowadays it has been said that even in the WHO, there is a guideline that next whatsoever pandemic would be there, it would be very much related with the AMR. So that is why our study more focuses on antimicrobial resistance. So continuously the efforts are being made to have the antimicrobial resistance pattern to be detected, and then it should be rectified at a very scale, at every point that is being needed to prevent ourselves from any kind of next pandemic that would become. So these are my references for the study, and thank you for your patience listening.
Thank you so much for your presentation. Very nice research. So, any question, please? Please.
Thank you, ma'am. Yes, ma'am. Ma'am, most commonly the drugs that we have used in our studies, imipenem, meropenem, and ertapenem.
these three major drugs we have used for only carbapenem detection. So our study more focuses on the carbapenem-resistant antibiotics.
That I agree, but you have shown that in meropenem, 73% of resistance is there.
Yes,
so that 73% will be the higher, means
Exactly.
from your denominator, whatever. So 73 should be the higher prevalence rate, what I identified, means, I hope you understood.
Yes, ma'am.
Okay. And the second question is that you have seen more cases in ICU,
Yes,
right? And the third, you have seen that more from urine sample. So have you recognized that urine sample might be obtained from all clinical samples? What is the cause from ICU, from which sample you have obtained more carbapenemase resistant strains?
Ma'am, maximum samples were taken from maximum kind of study was being taken from urine sample only. But the correlation, I guess you are asking of that why ICU is getting.
Yes.
Yes, ma'am. So, ma'am, in case ICU, we usually have the patients that are being supplemented with antibiotic therapy. Now, it is our major concern that if in ICU only the resistant strains are being obtained in a large quantity, and that too, we are left with a limited kind of treatment choice available to us. So that is why this cause of worry in ICU sector is much more in comparison to rest all wards.
That I agree, but it will be better if you recognize that from ICU, which samples are showing more, means because the urine sample recognize that the person who are having UTI infection, right?
Yes,
they
ma'am.
are showing. So all the patients in the ICU, they are suffering with UTI infections, or whether it is hospital acquired or community acquired carbapenemase resistance is seen, that can be further traced.
Yes, ma'am, sure.
Okay.
It would be
Good.
added, ma'am.
Okay, good.
Thank you so much. I think there is no any question from others. So I'd like to appreciate all those research presented over here, and thank you so much, please.
Thank you, sir.
Next.
We'll not break now. We'll continue because we are running short of time. And since one of our panelists will be leaving and Dr. Prasenjit is here, so we'll have a minute, sir. Right. Okay, please, go ahead.
We do not yet have presentations submitted with the technical desk for the second session's speakers. We have received only 2 of them. So if any of you are there here, can you please bring your PPTs and give it backstage? As our first session is over, we would like to call upon all our chairpersons and request Dr. Malkit Singh to honor our his co-chairperson, Dr. Saurabh Mittal. Thank you for joining us, sir. For our second session, the chairpersons would be Dr. Prasenjit Das, Dr. Mahendra P. Bhatt, Dr. Sunita Meena, Dr. C.P. Pandey, and Dr. Malkit Singh. Welcome, sirs. Ms. Rosie Paul is here. Okay, we have not yet received this one PPT from her. And Dr. Sumanta Bera, due to certain unavoidable circumstances, is not able to join us today. Her talk would have been very informative and very interesting. Sad to have missed it. Next, I call upon Ms. Sonal Sangwan to talk about bisphenol A, clues for acting beyond insulin resistance for the development of metabolic associated liver disorder.
Good morning to you all. Today I'll be talking about bisphenol A, clues for acting beyond insulin resistance for the development of metabolic associated liver disorder. Okay, it's not working. So this is not a very rosy picture to begin with, but what the world is facing today is the global threat caused by the menace of plastics. It is found everywhere in our everyday use and is a major contributor to the environmental pollution and is ubiquitously present from the highest of mountains to the deepest of oceans. And one of the major environmental pollutant, which is a component of plastic, is bisphenol, and prominently bisphenol A, which is found in our daily use plastic from day-to-day food and drink containers, dental sealants, compact discs, and variety of other components. And inadvertently, they are finding our way into the biological systems and human systems by the way of oral exposure, inhalation, dermal contact, and even more so, it has been found to enter our living systems by crossing the placenta-fetal barrier. And these chronic low-dose exposure has been found to enter our human system and has been imparting a deleterious impact in the humans with the mounting evidence of scientific literature which we encounter on the daily basis. And it has been, we can see that recently there has been a rise in the non-communicable diseases, especially metabolic associated liver dysfunction. So taking a look at a little bit at the spectra of this liver disease, so we have healthy liver where fat cells contribute to less than 5% of the liver, but problem arises when the fatty liver happens by the contribution of fat cells when they are more than 5% of the liver cells. And if unattended, this condition can contribute to MASH, which is metabolic dysfunction associated steatohepatitis or steatosis. Here, the liver cells are burdened with the fat deposition plus inflammation is happening. Till this condition, MASH, the condition is reversible by the dietary interventions or therapeutic modalities, but if continued in the same way, it can lead to cirrhosis or hepatocellular carcinoma, where the patient needs liver transplant, and in case of, it can also lead to fatalities or death. So now the nomenclature of NAFLD, which was earlier called non-alcoholic fatty liver disease, here to note that patient is not consuming any alcohol or very little alcohol is being consumed. But the contributors now, it has been seen that in such patients, the obesity, diabetes, high blood pressure, high cholesterol are some of the risk factors that are associated with these conditions. So the nomenclature has now been changed from NAFLD to MASLD. It is a recent advancement. So it has reached global proportions, being affected 30% of our global adults worldwide. And so it has reached the endemic proportions. And more importantly, now BPA has been recognized as a risk factor for the genesis of MASLD. So the aim of present study is to investigate the effect of bisphenol A on insulin resistance, which can lead to the contribution of this disorder of MASLD, as I'll mention it in my further slides, of metabolic associated steatotic liver disease, which is characterized by the high deposits of fatty acids or fats in the liver. So for this in vitro work, we have designed and taken HepG2 cells, which is hepatoma cell line, a liver-based cell line, and has been acquired from the standard source and maintained in DMEM under standard conditions. And then we gave the BPA to these cells in these particular 6 doses with respect to DMSO controls, as BPA was dissolved in DMSO for 24, 48, and 72 hours. And then we studied the glucose estimation in the cell supernatants via commercially available kit in a dose and time dependent manner. And wherever statistical analysis has been performed, independently 3 experiments were carried out, and p-value of less than 0.05 was taken as significant. So briefly, we have taken 50,000 cells in each well and treated them with BPA, and the culture medium was collected after the incubation. And with the method of glucose oxidase method, we have calculated the glucose in the media. This is the standard curve obtained after the 6 independent experiments carried out. And the standard curve, we were able to obtain a linear range. And these are the results of BPA-induced insulin resistance on exposing these HepG2 cells with various doses of BPA at 24, 48, and 72 hours treatment. And we obtained a linear pattern of increase in the glucose in the cell supernatants at 48 and 72 hours, but in the higher concentrations of 10 to 100 micromolars, it was reported in 24 hours, and they were all significantly elevated. So we conclude that the findings of this insulin resistance, BPA exposure induced it in HepG2 cells in a dose-dependent manner, particularly palpable at higher concentrations. And insulin resistant impaired the cell's ability to respond effectively to insulin. Here data is not shown, but when we gave insulin to these cells, we required a higher molecular concentration of 5 micromolars to bring down back this glucose in the cell supernatants. So we thought that it might be that it is very insulin, there is some other pathway which might be involved in the development of insulin resistance in these HepG2 cells, which might lead to NAFLD-like features in these cells. So elevated glucose levels, as we know in the culture media, indicated decreased glucose uptake by the HepG2 cells, and insulin resistance typically reduces the glucose uptake, as we know, leaving more glucose in the external environment. So this suggests that BPA exposure hindered the cell's normal glucose metabolism, further indicating towards a metabolic dysfunction happening. Now taking a look at the thyroid hormone, T3, which is the active form of thyroid hormone, we know that thyroid releases T4, which is deiodinated, into the liver cells in the form of T3, which is taken up by liver cells and is very important to maintain glucose homeostasis, energy regulation, and lipid contents in the cell. We know that pituitary is the master gland which releases TSH, and it thereby releases the T4, which enters the liver cells and is deiodinated and converted to T3 via these THR beta receptor, which is predominantly found on the liver cells. Now, it is well reported that in case of hypothyroidism, where the patient has high TSH values, the risk of MAFLD or MASLD was found to be increased by 23%. Thereby, now we have found that prevalence of MAFLD has increased in patients who have hypothyroidism. Now here, THR beta plays an important role, which has given, studies have found that this THR beta has a major role to play in the development of NAFLD. And thereby THR beta agonist studies were carried out, and now resmetirom, which is a therapeutic modality and has recently been FDA approved for this particular NASH condition, was helpful in bringing down the lipid contents in the cell. So we thought that maybe BPA is also meddling with this THR beta receptor and thereby causing the NAFLD-like condition. So question arises that whether BPA is also interfering with thyroid hormone functioning. So for that, we have designed an in silico experiment design. We took thyroid hormone receptor beta, and the ligands taken were resmetirom, BPA, and T3, which is a natural ligand for THR beta receptor. And we carried out docking studies to see the energies or binding energy in these particular case of thyroid hormone receptor beta, and these 3 ligands that we took to check the energy interactions through docking studies, and Autodock software was used for that experiment. Now, this was interesting to see that BPA was in fact binding very strongly to THR beta. You can see the energy minimized, mean binding energy was approximately at par with this natural ligand and the drug which has been developed for THR beta agonist. And if you appreciate these pictures which has been developed through PLIP and PyMOL tools, here we can see the interactions of BPA, resmetirom, and T3 in this case. And these all are interactions, hydrophobic hydrogen binding, that we can see here. So the finding concluded that BPA in fact is interacting with THR beta, and that can interrupt the normal THR function. So these interactions can lead to abnormalities in thyroid hormone signaling, and this dysfunction in THR signaling could contribute to insulin resistance and increased lipid accumulation in the liver, which is potentially linking BPA exposure to metabolic and liver diseases. So BPA can meddle with these thyroid hormone receptor function, lipid metabolism, insulin signaling, to give rise to fatty liver condition and leading to the pathogenesis of liver disorder or MASLD. These are the publications that have been published recently out of this work, and the references that I have taken. This is the team I'm working with. Thank you so much.
The presentation was good, but I have few observations.
Yes.
One is the title you submitted that clearly shows the clues of BPA causing MASH. So you have observed the changes, but are you also looking at the mechanistic aspect?
Yes,
how
sir.
the BPA is
Yes,
causing insulin resistance?
Yes, sir. I've been
and
working on organ to
THR.
organelle dysfunction, basically mitochondrial function I have worked with, and found that lipid oxidation was in fact found to be affected via electron transport chain inactivation, and the mitochondrial membrane potential was also found to be dissipated. So we propose that it might be leading to decreased beta oxidation and increase in DNL or de novo lipogenesis in the liver cells, which can lead to the progression of this condition. Yeah.
Any questions from the audience? If there are no questions, thank you. Very well presented.
Thank you.
Next.
Good luck, Ms. Sonal. Next talk will be devising a multiplex panel for early diagnosis of bloodstream infection by Ms. Aarti Tyagi.
Hello. Very good morning to all the people who are there on the dais, off the dais, and present in the auditorium. This is Dr. Aarti Tyagi from Charusat University, and here I am presenting a work which we have done on devising a multiplex panel for early diagnosis of bloodstream infection. So in bloodstream infection, I have focused because it is well known that blood, which is one of the connective tissue, which easily make a localized infection to a generalized infection. And when a generalized infection occurs, the rate of mortality and morbidity increases. So here I have just shown one figure which will show the background of the problem, that any site, any source of the infection, the localized infection, that is either respiratory tract infection, UTI, or surgical site infection, or skin or soft tissue infection. From there, if the pathogen has entered within the bloodstream, if it is unrecognized, it undergoes an dysregulated host response. With a dysregulated host response, it results in sepsis, and due to sepsis, it can result in septic shock, resulting in multi-organ dysfunction, and hence it is very harmful and very threatful for us. The second is that its diagnosis is very worrisome part. Here, still we are using culture and sensitivity, which is a gold standard method for identification, but due to time consumption and due to not isolating the non-cultivable organisms, we cannot identify those organisms and we miss it. So by knowing the merits and demerits of the existing methods, that is blood culture, as we have seen that it is time consuming and we miss the fastidious organism, the molecular diagnostic methods are opted out. But again, the molecular diagnostic methods which are available, due to cost effectiveness and due to availability of resources in the laboratory, it is worrisome part. Major is that it is quite costlier because the available kits which are there, that is costing, which is having a multiple panel where the frequency of, if it is containing 25 majority organisms, out of that hardly 6 or 7 are the one which are more frequently seen, more prevalent. The next is multi-TOF. Again here, though it is very advantageous for rapid diagnosis, but again it needs the pure culture for accurate identification, and again there is it's limited for the ability to detect antibiotic resistance. So with this, we have hypothesized that pathogen-specific genes should be targeted, which are more prevalent in our area, and a multiplex panel should be optimized to trace these organisms. With this aim, we have developed a multiplex PCR panel for detection of frequently encountered bloodstream bacterial pathogen. We have these objectives that first we have selected the pathogen-specific primers. We have optimized this, the pathogen-specific primers we have selected, and the second objective is endpoint PCR optimization, and the third objective is multiplex PCR panel standardization. So the methodology which followed is, first for selection of pathogen-specific primers, first we identified the common bloodstream pathogen by reviewing the literatures in the local, regional and global level, as well as by observing which are prevalent in our area specifically, which we have obtained through clinical samples. The second is selection of pathogen-specific primers, and these primers genes were identified by in silico amplifications and by using bioinformatic tools. The next is multiplex PCR panel standardization. For that, we have revised our control strains, DNA isolation from the control strains, and doing endpoint PCR. Through gradient PCR, we have optimized our endpoint PCR, and the primers were validated by using positive control, negative control, and other strains. Next is multiplex PCR optimization. So here we have selected this common bloodstream pathogens from various references. The commonest bloodstream pathogens which we identified were Staphylococcus aureus, Enterococcus faecalis, and coagulase negative staphylococci, which were very common as a bloodstream pathogen in amongst gram-positive organism, and amongst gram-negative organism, that is Escherichia coli, Acinetobacter baumannii, Klebsiella pneumoniae, and Pseudomonas species. So these were the commonest pathogen which we have seen in different studies, from liver transplant recipients, even from CLABSI, central line associated bloodstream infections, septic patients, neonatal early onset sepsis, and so on. So here we have selected these genes. The genes were selected on the basis of their pathogenesis by identifying that which gene is responsible for initial attachment to the host cell, and which helps in its progression which plays a role for invasion and evasion of host defense mechanism. And somewhere we have lacked that we missed the gene. So there we have opted for 16S rRNA specific for that genus. So here we have selected these genes such as FEMH for E. coli, 16S rRNA for Staphylococcus aureus. For that we have also selected coagulase gene, which is showing the adhesins and exoenzymes property, which helps in the evasion of host defense mechanism. For Acinetobacter baumannii, we have selected BFMS. Then for Klebsiella pneumoniae, KPHS. So these all are involved for some function which is involved in its pathogenesis. This is how we have selected the pathogen-specific primers. Now, after selecting these pathogen-specific primers, we have performed the endpoint PCR. The endpoint PCR was performed on the control strains which were there, which we have isolated and confirmed. So first we revived those strains and we have confirmed, especially through initial macroscopic appearance, cultural characteristic and biochemical characteristic. These were the strains which we are preserving, the clinical isolates which we are preserving. The next we have isolated the DNA. So DNA isolation protocol, the same DNA isolation protocol were followed for both the clinical isolate, and we have performed on whole blood as well. So the DNA which has been isolated, that was quantified and qualitative estimation was done. The quantification was done through nanodrop, and this is qualitative estimation was done through gel PCR. So we got very good DNA isolated, and then PCR optimization was done here. So initially the gradient PCR was done at different temperatures. The different temperatures were used to know, because in case of multiplex PCR we were planning to keep at higher temperature to avoid the non-specific amplifications at lower temperatures, and we got a very good result at higher temperature as well. So here these are the results which we have obtained at higher temperature as well. So here we have seen at the endpoint PCR optimization, what we identified that we can perform the multiplex PCR at 56 degrees Celsius. So we performed the next PCR, endpoint PCR, initially at 56 degrees Celsius for primer validation. For primer validation, what we have done is we have taken the positive control strains and negative control. In case of negative control, we have not taken any organism, and we have also seen the amplification with other strains to identify whether it is specific for the organism which we have targeted. So here are these results which we have seen for validations, primer validation. This is just one of the example which I am presenting here. That is, in case of Enterococcus faecalis, we can see that we have taken the primer and we have run with Pseudomonas, then this Hemolyticus, Staphylococcus hemolyticus, epidermidis, but we have not obtained any amplification here. It has shown specific amplification in case of Enterococcus faecalis. So this is how we have validated all our primers, and at last we have validated the multiplex panel. The multiplex panel which we have standardized, that was standardized because here we are using multiple primers and even multiple organisms, because it is obvious that in bloodstream infection, it could be because of multiple organs. It is not necessary that only one or two organisms may be behind. So we have used for multiple organisms as well. So here we obtained a very good result for especially 4 of our organisms, that is, so here we can see the results which we are obtained, that is showing good amplification for Pseudomonas aeruginosa, Pseudomonas species, then Klebsiella pneumoniae, the Klebsiella pneumoniae, that is this Acinetobacter baumannii, and Staphylococcus aureus. So here these two are the one which are seen for Staphylococcus group. But here what we identified that when we have used 2 different primers, that is Pseudomonas aeruginosa and Pseudomonas species, non-specific band because of this cross binding was seen at 525 base pair, so we have omitted that. So what we concluded with this observation that multiplex PCR panel was validated especially for Staphylococcus aureus, Pseudomonas species, Klebsiella pneumoniae and Acinetobacter baumannii. Done, sir. And this method, the next what we have seen is that Enterococcus faecalis, this was the panel, means where we have seen that it was validated for this BFMS, Klebsiella, Acinetobacter baumannii and Staphylococcus plus Pseudomonas species. But the Phe match that was for E. coli that has shown non-specific, it was not validated, so it has been removed and we will further target for the Aceracea coli. And for Enterococcus faecalis, though it is giving good result in endpoint PCR, but in multiplex PCR, it has not given a result. So the new primer will be targeted for Enterococcus faecalis and Aceracea coli. These two were opted out. So the future perspective is that the devised multiplex panel will be tested for further diagnostic accuracy with the comparing to the gold standard method, that is blood culture method, which is a gold standard method still followed. Then Enterococcus faecalis and E. coli gene will be targeted between 300 to 500 and 800 to 900, the blank space which we see here, because here we can trace and monitor the gene easily. And Enterococcus faecalis can be followed through endpoint PCR panel at individual level. A multiplex panel for detection of drug resistance gene will help to identify the suspected level of resistance and prevalence of resistance genes amongst blood-borne pathogen. So this is our next target. Respective validation, cost-effective and timely resulting multiplex panel can be applied to the clinical laboratory for early diagnosis of bloodstream infection, and therefore it can mitigate, can reduce its complications. Thank you so much. Thank you, everyone.
Interesting work, Aarti. I have few questions.
Yes,
regarding some of your results. You said that some of the primers did not perform well on multiplexing, like for Enterococcus and Escherichia coli. So can you offer some explanation for this? Why didn't they perform well on multiplexing, or why were they not detected on multiplexing?
Yes. In case of Escherichia coli, madam, we have targeted Phe match. Phe match is the one which initially helps in the attachment to the host cell. So that's why we targeted it. But this gene recognized that it is showing result for all Enterobacteriaceae group of organism. So it is not specific for Escherichia coli. It can be seen in Klebsiella as well. It can be seen in other Salmonella or Shigella group as well. So we cannot identify that specific E. coli. It is not validated for specific E. coli. That's why we need to opt it out and we have to target any other.
So to begin with, you should have chosen a target which was specific for that genus?
Yes, yes. In many of the studies, Phe-H has shown a good response, but in our studies, we have recognized that it is non-specific.
Good work.
Is there any question from audience? Well, thank you.
Thank you so much, sir. Thank you, everyone.
Sorry about the slight delay. There was a small technical glitch. It's corrected now. Inviting Mr. Surendra Kumar Sharma to talk about nerve biopsy, clinical utility and technical aspects in modern neuropathology practice. To you, sir.
Good morning, everyone. Myself, Surendra Kumar Sharma, Technical Officer, Department of Laboratory Medicine, Manipal Hospital, Jaipur. And welcome to all delegates, faculty and students present here on the dais. Also, and special thanks to Vipan Singh and the scientific committee for the permission for the oral presentation present here. My topic is nerve biopsy. Overview of the nerve biopsy. Indication, choice of the nerve, sample, transportation, process, how to normal structure of peripheral nerve, how to recognize the artifact, and actually process of the nerve biopsy on the structure of the nerve biopsy, normal and pathological overview. Indication of nerve biopsy: suspected vasculitis, suspected disorder, clear prognosis of the nerve. Example, amyloidosis, laparoscopic sarcoidosis. Nerve result from biopsy and other tissue, abdominal fat, conjunctional skin biopsy and other nerve biopsies. Treatment failure, atypical presentation was CIPD and GBS, cytogenetic neuropathy and CIAP also. Criteria of the selection of the nerve biopsy: minimal morbidity, distal nerve favored, accessibility to conduction studies, predictable anatomical course and feasibility of arrangement. Motor nerve are not suitable except pure motor nerve, avoid area of local trauma. Choice of nerve: sural nerve, most commonly biopsied, superficial peroneal nerve combined with muscle and skin biopsy also. Index branch of radial cutaneous nerve, early leprosy neuropathy also. Species nerve, superficial greater auricular nerve. How to send biopsy? Ideal length of the nerve biopsy is 2.5 centimeter. Only use of the fixation of the nerve biopsy 2.5% glutaraldehyde. Not other fixators are recommended for nerve biopsy. Avoid commercially available side X. 10% non-buffered formalin is least preferred. Do not send crush. Avoid tie nerve with thread also, not staple or pinch wipe. Nerve biopsy grossing. How to grossing the nerve biopsy? What is site of nerve? When you receive the specimen in your lab, in 2%, 5% glutaraldehyde. Receive the 2.5% glutaraldehyde nerve specimen in your lab. Taken the specimen. And how do you gross? It's a staple of the site of nerve and tie of thread of the specimen of nerve biopsy. Avoid to crushing, staple and tie of with thread site of biopsy and taken the tissue. Why you avoid the taken nerve biopsy? Tie of thread and crush and staple side. So many artifacts are occurred during microscopically examination. Processing and staining. Capal, TNS, LS section also done. And use of stents. Some stents are available in our lab Kepal, MTS, HNE, and Pulse, iron stent congruent, and so many more. Stent को myelin, Kepal stent, filming solution, buffer preservation in myelin, structure of peripheral nerve. You see the blood vessels in TS section of the nerve biopsy, perineural, endoneural, and epineural also. Square cells also present here. Epineural specimen of the biopsies. Perineural laminary structure, no laminivarous, directly with the side of the fascicle, flattened polygonal cells, EMA, elastic properties, and many more. Perineural. Endoneural fluid is under hydrostatic pressure, hypertonic or plasma. LS section of the HE and MTS. Blood nerve barrier. Two types of blood nerve barrier are present, endoneural and perineural barrier. Myelination, squamous cells. Section of the nerve axis, axion, squamous cells, maxillary squamous cells, and myelin sheath. Component of the myelins, water content 40%, lipid and proteins also present in specimen. Normal variations, how to find out the normal variation of the nerve axis. Reynolds body, superneural parallel, long axis of nerve, round of the ellipsoid, Horald structure, contain fibroblastic blood vessels. Trichoma may be confused with amyloid and edema. Reynolds body. Reynolds body is present here. All related changes are also seen in nerve biopsy for the microscopically. Thickened, hydrolyzed, increased endoneural, reduced fiber density, fragmented axonal, segmented demyelination, increased Reynolds bodies, occasional polygonal bodies also. Related changes in how to find out the related changes in microscopically. First slide is in right side to arteriosclerosis. A second is neural classification, and third is polyglucosan bodies. How to find out the artifact? Good fixation isomer in 2.5% glutaraldehyde. HA and mesenteric stent, hyper osmolar artifact, HE and MAT also, and foreign fixation artifact seen in microscopically this type. Pinch biopsy. Also always when you do the grossing site in the biopsy, avoid to pinch, tie with thread and crushing nerve. Saline induced autolysis. Basic pathological mechanism, axonal and segmental. Axonal degeneration. Axonal nerve biopsies, so many structures are available. Proliferation squamous nerve, macrophages are present here. Proliferation squamous cells and regeneration. Segmented demyelination. All same is previous slide. Demyelination, remyelination, degenerating myelin or entirely degenerate axonal thick myelinated fibers. Kepal staining interpretation. Is there loss of myelin fibrosis? Normal, mild, moderate, and severe. Normal myelin fibrillation is present in normally seen in microscopically this side in first in upper left, and mild and moderate and severe. Myelin is removed completely. Nerve biopsy examination. Is there neuropathy? It is axonal, demyelination or both. It is acute, chronic or polyphasic. It is fascicular involvement, focal and diffuse. It is there in specific diagnosis. Axonal neuropathy and demyelination neuropathy. Find out in so many diseases. Axonal is diabetic, vascularity, leprosy, amyloidosis, toxins, polypyrene, perineuroplastic, HMSN, and demyelination neuropathy present in GBS also, HNNP, leukosporosis, mitochondrial rare. Utility of nerve biopsies, essential or helpful? Essential for definitive diagnosis of the cause of neuropathy. Revealing diagnosis find out that may after management 20%. Vasculitis, sarcoidosis and leprosy. And helpful diagnosis of diabetic neuropathy, HMS and leprosy and vasculitis neuropathy. Thank you.
Mr. Surendra, very informative presentation.
Thank you.
And to acknowledge that processing a good nerve biopsy is not very easy and not done in many centers.
Yes, sir.
At our department in neuropathology, it is being done since years. But how many routinely stain do you do routinely? Means during the initial examination?
One neuropathologist present here in my hospital,
Okay.
and done the perfectly in clinical side also, and contact to neurologist and skin specialist.
Okay. Otherwise, very informative presentation.
Many samples are received many times as per requirement of the patient, and which type of diseases are occurred, and then communicate to how taken the nerve biopsies, when what type of fixative are used and what type of not used for the taken of the specimen.
Thank you. Understood. And any question from the audience? Because this is a very interesting topic, and I guess the budding technicians, they will be very interested in the topic.
Basically, sir, is not a clinical side, technical aspect, expertise of technical aspect. Thank you.
Thank you, sir. Next, we have a very interesting invited talk by Dr. Tushar Sehgal, MD Pathology and DM Hematology, to talk about quality control in a clinical laboratory. He is a faculty in the Department of Lab Medicine, AIIMS, New Delhi.
Hello, good morning everyone. So at the outset I would like to thank the organizers of ICMLS for inviting me for the talk. And this talk is about a very important but yet very common topic in the clinical laboratory which we regularly follow every day. So it's about the quality control. So I'll be dealing about the basics of quality control and a few examples, and about the LJ charts and Westgard rules which are a common practice nowadays, and how to interpret those charts. So let's move on with the presentation. So when we talk about quality control, so it's about the two important words, the quality as well as control. So what is quality? It's a high grade measure, it is a superior measure, and it is a measure of excellence. And about the control, it's a way of keeping something within certain limits. So when we talk about quality control, we have to talk about quality control materials. So the quality control materials are, I have three or four major characteristics. These are the color coding. So color coding helps us to identify the type of quality control materials, whether it is high control, normal control or low control. The levels again I discussed, high, normal and abnormal controls. The matrix of the control, whether it is a blood control, whether it is a serum control or whether it is a lyophilized control. And the use, so what is the use of quality control materials? It is to maintain what? The internal quality, so which is very important aspect of the lab. So once again, so it is a series of analytical measurements to assess the quality of data. And what is the importance? So it ensures that the results generated by the lab are correct and precise. So when we talk about the quality control, so it has two major components, the IQC and the EQA. So can we have a more interactive presentation? What is IQC? Yes. It's the internal quality control, very good. And what's EQA? external quality assurance, right? So let's talk about IQC first. So IQC, as you rightly said, it is internal quality control. So it involves the use of multi-parameter controls, which can be 2 or 3 levels. Or it can be done on a retained patient sample, or it could be a combination of the above. So why am I talking about retained patient sample when we have the control materials? Because sometimes what happens, the manufacturer provides these internal quality control, and the internal quality control don't reach the lab on time, maybe a couple of days late, so due to the shipment, etc. So we can use retained patient samples which are used, and then they can be tested against the timings as well as compared for the coefficient of variation. If the coefficient of variation is within the normal limits, then we can use the retained patient sample and use them as a quality control material before actually running the actual patient samples, right? Or it could be a combination of the above, because sometimes you may have one level of control and the other levels of control may not be there. So you can use one level of IQC along with a retained patient sample, right? So this is a common example of a IQC chart. So you can see these are the demographic data which is there. So the nickname of the instrument is there. This is XN1000, which is the hematology analyzer. You have the material, the quality, control level 1 material, the registration number, file number, the lot number. All the QC materials have the lot numbers and the expiry date. So these are the common characteristic of a QC material. Then on the left side you can see the items which are the parameters for which the quality control data is obtained. The red blood cell, hemoglobin, hematocrit, mean corpuscular volume, mean corpuscular hemoglobin. And you have these target values as well as the upper limit and the lower limit. And in the center you will see this pattern of graph. So what is this graph called? Yeah, I could hear the answer. Sorry? Very good. So it's a Levy-Jennings chart. It is composed of, you can see troughs and valleys and mountains are there. And the characteristics of the graph should be close to the mean, right? With high values as well as the lower values. And after some data points, for example, 20 data points, we generate a SD, mean and CV. So the results of SD, mean and CV are depicted on the right side, correct? So as you rightly pointed out, Levy-Jennings chart were the charts which were shown in the previous picture. So how did it started? So in 1931, W. Shewhart, which is an American physicist, an engineer and statistician, he developed this control-based chart in interpreting the industrial manufacturing process. And in 1950, Levy and Jennings suggested the use of these control chart in clinical laboratories. So this is the cartoon which you can see. In a general population, you have people who have kind of normal height, and then you have people who are 1 SD or 2 SD higher, right? Or they can be 1 SD or 2 SD lower than the normal representative height. Similarly, in the patient sample also, we can have data points which are close to the mean, and you have data points which are outside the mean, which can be +2 standard deviation outside the mean, or it could be +2 standard deviation on the left side of the mean, or they could be a 3 SD plus on the right, or -3 SD on the left. So this is not abnormal, because in the general population also we have this particular pattern. So likewise, in the Levy-Jennings chart, when we plot the patient sample, you have this kind of data. And what is this data called as? The Gaussian distribution, right? And so there is a Gaussian distribution which gives the name of a Gaussian curve. So you can see this is the X bar is the mean, and then you have -1 SD, +1 SD. So between 1 SD, -1 and +1 SD, you have 68% of the data points. And when you see -2 SD and 2 SD, you have almost 95% of the data points. And when you consider -3 SD and +3 SD, there are almost close to 100% of the data points, that is 99.7. So what is a Gaussian curve? It is a normal distribution observed by well-preserved biological material on repeated examination. This property is used in statistical quality control monitoring. the SQC monitoring is used to check the ongoing performance of the analytical system. These are the things which we use regularly and we see regularly in our labs. And this is the key to understanding the LJ chart. So if you see, this is a Gaussian curve to the left. It has been tilted towards the right, and here you see the LJ chart. So what is the analogous thing about these two? The analogous thing is that the LJ chart is a Gaussian on its side. So you see the LJ chart and you see the Gaussian distribution, right? So this is the mean. So this is the X bar mean, and this is 1 ST minus 1 SG. So these are all your SG values here. So LJ chart is a chart which is Gaussian on its side. So this is a classical example of LJ chart in which we can see most of the values are close to the mean, right? And then you have some values within 2 ST, plus 2 ST, minus 2 ST, and you also have some values which are going outside the 2 ST range. These are between 2 ST and 3 ST, and then you have values which are in the 1 ST range as well. So we can have various problems in the LJ chart when we study patient samples or the control samples. So we can have a widened LJ chart which corresponds to a random error. You can see there is a dotted line here, and this LJ chart, which is using the control data, is giving a widened plot because of a random error, which is this value. You can see it is outside the 2 standard deviation. So it is outside the 3 standard deviation actually. So it leads to the widening of the LJ plot. Likewise, you have LJ chart which can be shifted also. So you can see in this one, this is the mean, and you have many values on the same side of the mean. So that causes a systematic error problem which causes a shift in the LJ chart. And you can see this is the dotted line which is the normal LJ plot, and you can see this is the shifted plot which is due to the systematic error which is there. So LJ chart is a graphical method to display the control results. The daily controls are plotted against time, and the lines are drawn from point to point to understand any trend, shift, or any errors. So what is the use of LJ chart? It tells us whether our procedure is in control or out of control. Secondly, a chart is created for each test and each control. Standard deviation values are automatically set to decide the decision limits, 1 ST, 2 ST, or 3 ST, and you fill the kappa. What is kappa? Yes? Yes, so absolutely correct. So it's a corrective action and preventive action. So this is an example of a corrective action and preventive action data. So you can see this is our laboratory report. So date and protocol title is there. So what is the deficiency? So level 2 QC was out of range, right? So the technical staff gave the auto rinse. And what was the corrective action plan? So it has a corrective action and a preventive action. So what is corrective action? It is action to taken to correct the specific deficiency. So the staff changed the new level to QC as the QC volume was inadequate. And these are the actions taken to prevent the problems so that it does not happen again. So what are these? So it was to check the volume of the QC before running, to avoid the contamination of QC, and to give maintenance before making a QC. So this is a classical example of how a kappa is filled. So when we talk about LJ chart, we also have to discuss about some rules. So these are called as the Westgard rules. And this is the gentleman who actually initiated the Westgard rules. This started. So Dr. James Westgard is from the Department of Pathology and Laboratory Medicine at the University of Wisconsin of Medicine and Public Health. He's a co-founder and principal at the Westgard company, and he suggested all the Westgard rules. So to apply the LJ chart, we have this Westgard rules. They detect changes in analytical system, in control, whether it is in control or out of control. And they are applied when the QCs are plotted within the range of 3 ST. So what are the use of these rules? So basically to maximize the error detection to the tune of more than 90%, and to minimize the false rejection. we have to make sure that the false rejections are very less. And there are some nomenclature to it. So this is the number one nomenclature, which is depicted by the letter N and L. And then you have number two with the, which says about the within run and across run data. So this is example. So N is the number of control measurements involved, L is the limit exceeded. For example, when it says that it is 1 to S, so 1 meaning the number of control measurements involved, and 2S meaning the standard deviation which has exceeded by the control data, right? So, and there is one more nomenclature to it, which is called as the within run or across material data. So here you can see, this is an example. So whenever you run the QC in your lab, you have various levels, right? So day 1, level 1, 2, 3, day 2, level 1, 2, 3, and day 3, level 1, 2, 3. So in day 3, all the QCs are out. So this is called as across material or within run. And then you have QC material which are there, in which you can see in day 1 to 3, all the level 1 QCs are out. So this is called as within material control rule. So this is an example of the first Westcard rule, which is called as the 1-2S rule. Here you can see the controls were running okay, but suddenly there was a problem here when there is a control data which has gone outside the 1-2S, right? It has again come back to the to be close to the mean. So what is this rule? So it is 1-2S. So one observation was outside the two standard deviation. So 1 is for the observation and 2 is for the 2 standard deviation, right? So it depicts a random error or a beginning of a systematic error, right? So what is this? It is a warning rule for a random error. You will not take any action immediately, but you will observe your data points on the next day and the subsequent cycle whenever the control is run, and then plan accordingly. So it's a warning rule, but it can be a rejection rule in the condition when you run only one level of QC, right? Because अगर आपने एक ही QC run किया है और this you are obtaining 1-2S rule in that QC, so it is a rejection rule, not a warning rule. So the second rule is your 1-3S rule. So you can see that the controls were run normally on these particular days, and then when suddenly there was one episode when the control value was outside the plus 3S 3 standard deviation rule, right? So that is called as the 1-3S rule, and it is a random error, again a beginning of large systematic rule. So here it's a rejection rule. You cannot run the patient data when you obtain this. So you have to work out what is the problem with the control, and then only when the control is passed, then only you can proceed with the patient samples. The other third rule is the 2-2S rule, in which you will see that these are two set of examples. So and these are depicted by various colors. In this particular thing, one control material was run and there were two values outside the 2 standard deviation. So that is 2-2S. It is called as across run because one level of control was used. In this one, it is 2 levels of control were used, depicted by yellow and the gray or the blue thing, and then you will see that both the levels of controls were out. So this is called as within run 2-2S rule. So it's again a systematic error, and you cannot run the patient sample once you have obtained this problem. So you have to rectify this problem, and then only you can run the patient data. So as I said, this is a systematic error, and there are 2 examples of it, within run, across runs, depending on the quality control material. Another rule is the R4S rule. Here you can see that 2 quality control material were used. This is the mean, and you can see there are values of these control which actually differed by 4S. So you can see plus 2S here and minus 2S here. So this is 4S violation. So that denotes a random error. The other error is the 3-1S. You can see that 3 observations are going outside the 1S rule. So this is across the run, and this is within run. When the quality control materials which are used differently, all 3 are outside the 1S, so it is called as 3-1S rule. The other rule is the 4-1S rule. 4 data points are outside the 1 standard deviation when you run within the run, and across run when you use different types of quality controls, so that can be applicable to both. Yeah, so these are the 4 1S rule. Then you have sometimes you have 10 1X rule. You have 10 sets of observations which are falling on the same side, which denotes a systematic group of errors. It can be 6S, 8X, 9X or 12X even. So these rules are violated when there are 6 or 8 or 9 or 10 or 12 control results on the same side of the mean, regardless of the specific standard deviation they are located. It could be minus or plus both. So another set of rules is the 7T rule, in which you can see that all 7 observations are falling on the same side of the mean. So denotes a systematic error. So when 7 control observations trend in the same direction crossing the mean, this is called as 7T rule, and it is applicable across run. So this is a summary of what I told, like 1 2S rule, 2 2S, 1 3S, 4 1S, then 2 3 2S rule, 3 1S, 10X and 70, and what are these type of error, whether it's a systematic error or a random error. And these are the explanation and the error type. So you can see that 1 2S is a warning rule, whereas the others are all rejection rules. It can be also a rejection rule when you use only one set of controls, right? So it's important to train your eyes to see, and train your eyes of the technical staff also. So with this, I end my presentation. Thank you so much. I'm open to questions if there are any.
Interesting talk, Dr. Tushar.
Thank you.
Very informative. I just wanted to comment upon your presentation. Are there any exceptions to Westcard rules in like testing for certain parameters when we don't actually follow Westcard rules to the core?
Yeah, there are exceptions to it. Actually, that depends on the test which we are running. For example, when we are using some sets of biochemistry samples or hematology samples, there can be exception to it.
For infectious serology also, we don't follow them to the core. Because they are not mostly quantitative parameters, they are mostly qualitative results.
Yes.
And plus the reaction can't be controlled to the most possible extent as it is for quantitative parameters in biochemistry and hematology.
Thank you.
Any questions from the audience?
Thank you.
I invite our organizing chairperson, Ms. Saroj Singh, to honor our speaker, Dr. Tushar Sehgal, with an award. We have come to the end of this oral presentations session 7, and we now request our chairpersons, Dr. C.P. Pandey, Dr. Malkit Singh and Dr. Mahendra Bhatt, to honor Dr. Prasenjit Das and Dr. Sunita Meena with a memento.
I request the chairpersons to take their seats in the audience. There are many heroes in different fields. Today we have our lab heroes who inspire and motivate us with their speech. The first hero of the session is Dr. Mahendra P. Bhatt. He is an associate professor and head of the department, Laboratory Medicine, Manmohan Memorial Institute of Health Sciences, Kathmandu, Nepal. He is also a president, Nepal Association, Medical Lab Sciences. I invite Dr. Mahendra P. Bhatt to continue inspiring us with a talk.
Good afternoon. So this is very nice and pleasure to be here from Nepal. I think I am the alone representative, and maybe this is good opportunity to share the experience of laboratory profession from last few decades, what we are improving in the profession. So thank you so much. Thanks ICMLS for giving me this opportunity to share my knowledge and experience of profession. So, professional sharing, medical laboratory technology, medical laboratory science, or laboratory medicine, whatever we say, this is central professional, center profession in our modern medicine. As we know, as we realize even after post-COVID, this realization has taken good space. So this, contribution of profession in medicine from the side of medical laboratory science has significant role in academic improvement in the future, scientific innovation in the future, as well as professional service in the future to make the better health worldwide. So for the health security purpose also, in the United Nations, in the WHO point of view, we can say medical laboratory profession is proud profession in every nation. So national health security security also consider the laboratory medicine is a very important profession in the medicine. So first of all, I would like to introduce myself so that we can share the experiences. Especially, it will be very good to find the scope of laboratory medicine worldwide. That's why I'm sharing my knowledge here. So this is almost my history. I have completed my BSc MLT from India. That's why I love the culture, I love the scientific innovation as well as everything. I would like to touch with the Indian scientific culture. That's why I came at the last point. Some of our ICMLS active members invited. Thank you for giving me this opportunity again. So I completed my BSc MLT from the SBS University, Dehradun. Previously it was the SBS Institute of Postgraduate Institute of Medical Sciences. So after completion, immediately Manipal Shikshan Aspatal, you can see here, that is the Manipal group of education. One of the teaching hospital was established in 1994 in the Pokhara city, very beautiful city of the Nepal. So I, along with me, Dr. Surendra Sharma is here. We have started job over there. I was the first medical technologist after, along with me, he was the colleague in the clinical biochemistry department. The designation was the medical laboratory technologist. Here we have a varieties of designation, that's why I would like to focus on that. Next one, I have started the lecturer post in the Pokhara University, newly established university after Tribhuvan University is Nepal. Then we have a broad opportunity worldwide to work in the field. That's why I can give one example. I'm involved at the time to establish a new private medical college, Gandagi Medical College in the Pokhara city. I have invested some money now I remember. So we established medical college, and I realized further study is very important to upgrade our services in future. That's why I go for the master and PhD program through the scholarship in the South Korean University, one of the Kangwon National University. I have done the master, PhD, postdoctorate, academic, clinical, and research experience I gathered from there and returned back to Gandagi Medical College. 6 years I have taught clinical biochemistry to the MBBS, BDS, BPH, Bachelor of Public Health, nursing student, and almost this experience was sufficient for the, sharing knowledge. And now I shifted my job to the Kathmandu as an associate professor of clinical biochemistry and head of department of laboratory medicine. We are responsible for the BSc MLT program, master in clinical biochemistry, and some research we do collaboratively with various country, various university. Thank you so much for taking patience to listen all those things. So, scope of laboratory medicine, why I am sharing, because I am a leading person in the Nepal, neighbor country. We must be in communication for upgrading the professional association. That's why our scope should be clear: academic, professional services, health policy and research, and entrepreneurship are the opportunity in front of us. Basically, please, new, energetic and youth manpower of laboratory medicine must realize those scopes so that we don't stuck on the only one laboratory technician type or laboratory technologist type job in future. We have many more worldwide opportunity. Even India is growing economy as well as technology leader in the world. So laboratory medicine has various scopes, that's why finally, after the COVID, we realized the health security and prosperity of the nation is very important. That's why we must gather all those knowledge through the job and experiences. After experience, we can go any time for the further study. And one of the very important component, I was very surprised and very happy to see various innovative research presented over here. Thanks laboratory professionals. We are doing very good, and then these innovation and all those business industry upgradation can make big prosperity of the nation, and this, South Asian association, we can upgrade the health system, health security and prosperity together. So, in the academics, what we are doing, just this must be the sharing and, reference for each other. I remember always, whenever I do the curriculum development contribution in the country. I do the policy, some act or some, policy discussion. We take reference from the academia of India and professional, health services of India. That's why, obviously, we can share the knowledge of this type of, systems in neighbor countries, because we are the very closest neighbor country. We need very good cooperation in future and always. So in academics, we have these tier of the courses. Certificate level in medical laboratory technology. This course is conducted by the TEBT sector. Every country has a TEBT sector. We have a vocational and education and vocational trainings council in our country. That is a special act. Through that act, 10 plus 2 equivalent course, 3-year course after the 10th class, CMLT program is running. This program, after completion of education certification, they go for the licensing exam in the council. So similarly, next tier is the BSc Laboratory Medicine, or we can say BSc MLT or BMLT, whatever. But now we made a national curriculum framework. I will talk in detail about that national curriculum framework. I think ICML is also working on that. So in that, we have given name a BSc Laboratory Medicine, because most of the responsibility, practical things we are doing in the laboratory, we must cover the preventive as well as curative basic life support training, and then become a best laboratory professional. That's why these curriculum framework covers this type of title. So after that, MSc in clinical biochemistry, microbiology, and PhD are everywhere open for the specialization. So this is the national curriculum framework. Only last year this is released by the Medical Education Commission. We know NEET exam we pass for the MBBS admission in various medical college in the India, as well as NEET passed student can join MBBS in Nepal. This is very clear, entry criteria for the medical students. However, no one can join BSc, MLT in Nepal after passing the NEET exam. Only they have to go through Medical Education Commission entrance examination. This is a national entrance like NEET in India. So we have equivalent NEET exam in the Nepal for the entry criteria. This is one of the additional thing we have introduced last year. So undergraduate as well as postgraduate medical education, we say health professional education. Under health professional education, through the Medical Education Commission, there are many courses: MBBS, BDS, nursing, BSc lab medicine, imaging, public health, all those things covered by the Medical Education Commission. Final certification as well as accreditation is governed by the Medical Education Commission. So academic and professional licensing body is established in Nepal, before 3 decades around here. So it was 2001 established a National Health Professional Council Act through the Health Ministry. This is almost all offices are, you can see the board: Nepal Medical Council, Nepal Nursing Council, Nepal Swasthya Vyavasai Parishad. This cover all BSc MLT, public health, and other allied sciences are licensed by this through the licensure exam. So services in the Nepal, job service started after registration of our degree. Then after getting license, we can start the job. there are various type of jobs, monitoring, evaluation of the profession. So there are two types of lab medicine jobs in Nepal. One through the line of pathology, MBBS, MD, then pathology, biochemistry, or microbiology. There are parallel opening of job through the pathology sector as well as medical lab technology sector. So all manpower, all collaborative, approach is applied for the human resource management in the health sector, especially in lab medicine. So professional services started from the laboratory assistant. This is the 18-month course after 10th class. So lab technician, that is the CMLT course, 3-year course after 10th class, equivalent to +2. Medical technologist course is the 4-year course, and this 4-year course has a special, focus. We focus final year in the research, so that in master and PhD they can contribute good research like we presented earlier. So in pathology we can see like that, and medical technologies there might be this type of designation in the private and government sector. So entrepreneurship, we are involved in the trading business. Lab medicine professionals can be a good trading, self-employment services, like they can open a lab, they can report laboratory investigation, laboratory services in the government as well as private service, production of laboratory kits and equipment. This is the open opportunity in future, and consultancies for the education as well as professionals. So finally, I want to focus the research is very important contribution in the modern medicine and future development. We are talking about the artificial intelligence in every field. However, those in artificial intelligence will be, operated by the people. So these are the research which are contributed by myself. That's why I'm giving the example, so that laboratory medical profession can be involved in various type of research. I don't go in detail. So this is one of the research focus of mine in the, my research field. So these are the achievements what I contributed globally. So these are the technologies we can perform in the future. These are some confocal laser scanning microscopic approach in the mitochondrial dynamics. So there are various, research approaches we can apply and give the, contribution to the laboratory, not only in laboratory science, in the medical science globally to assure the health security in future. Thank you so much. And finally, I would like to request, I would like to highlight the global health security agenda, which is UN agenda. Even though India and Nepal are not here, 67 countries collaborative approach, they are connected for the future health security. This also should be in our focus. Thank you so much. Multidisciplinary approach is very important. So all disciplines should be together and collaborative in future. So from the Nepal side personally, or from the organization Nepal Medical Laboratory Science Association, we are always together to upgrade Asian as well as global laboratory medicine field. Thank you so much, and I am very pleased to be here. Thank you, seniors as well as all the future laboratory scientists. Thank you so much.
Well, thank you so much, Dr. Mahendra, for enlightening us, and rather being an inspiration to students and forthcoming medical technologists. This session was actually planned with an intention to put through across people who have excelled after getting into this profession. So one of the heroes, inspiring heroes, is here, Dr. Mahendra P. Bhatt from Nepal. So a big round of applause for him. And I'll quickly run through his brief CV. Till then, I think I'll request backstage to organize a memento for him. Yeah, memento, please. For Dr. Mahendra Bhatt.
So I hope 2024.
For Dr. Bhatt. I think I'll request Dr. Kaptan Singh Sehrawat to honor Dr. Mahendra Bhatt. Actually, the objective of this session was basically to encourage people and not to like feel that as if they have chosen something which where you cannot excel and reach achieve heights. So, a brief about Dr. Mahendra Prasad Bhatt. He is an associate professor of clinical biochemistry and laboratory medicine. Besides this, he is heading the Department of Laboratory Medicine at Manmohan Memorial Institute of Health Sciences, affiliated to Tribhuvan University Institute of Medicine, Kathmandu. He is president of Nepal Association of Medical Lab Science, that is NMLS. He is president of Korean University of Alumni Association, KUAN. He is ethical review board member of Nepal Health Research Council. He chairs Doorstep Healthcare Services, Kathmandu, Life Care Diagnostics and Research Center, Pokhara, Life Care Diagnostics and Research Center, Dhangadi, and he is a past member of Expert Services in Resource Management. So this is an example that if you have zeal and will to excel, you can excel in the field you have chosen. So the next person in this, although we had found some 3-4 names, but unfortunately one of them could not arrive because of some personal engagements. He was supposed to come here, join us physically. We have in queue video messages from 2 of our eminent personalities. One of them is, can we have a video for Dr. Mr. Neeraj Lal? He is an alumni of PGI Chandigarh, and he is currently Chief Operating Officer of Apollo Hospitals at Ahmedabad. Video, please.
I passed out from PGI Chandigarh way back in 93, 96. I did my bachelor's in medical technology from there. I had a wonderful time. I was staying in ODH hostel there. And from there, I moved to Delhi. So I got a job at Indraprastha Apollo Hospital when Apollo Delhi was starting there. So I did a job for 2.5 years. Parallelly, I did my MHA, that is Postgraduate Diploma in Hospital Administration from YMCA School of Business. So in the morning, I was doing a job at Apollo Delhi, and in the evening, I was doing a part-time Postgraduate Diploma in Hospital Management. And that is a time when I get to know the importance of hospital management, because during those times, I think Apollo was the very first corporate hospital which was started in the capital city of Delhi. Then I did pass entrance of Tata Institute of Social Sciences, Mumbai. I went to Mumbai, gave the exam there, and finally I got selected there for a 2 years master's program in hospital administration from TIS Mumbai. and that is an intensive course for 2 years where I've been placed in various hospitals including Tata Memorial Hospital, Leelavati Hospital and various other hospitals in the country. And after this course, through placement, I've been placed in different hospitals. So if you see, I have worked in Rainbow Children Hospital as a Vice President Cluster Head in Bangalore. I was a Group Senior Vice President for Medicover Hospital based in Hyderabad. I was Vice President in the Shelby Hospital in Ahmedabad. So I've worked in various private and corporate setups. Currently, I'm heading Apollo Hospital in Gujarat, taking care of PNL. We have 6 hospitals here in different format. It includes cancer hospital, cardiac hospital, main multi-specialty hospital, and our OPD centers in Rajasthan. So I wish you all the very best in this conference and looking forward to meet you sometime in this healthcare ecosystem.
So a big round of applause for Neeraja and to our profession as such. So, sorry. Well, in excitement, my mobile fell. I'm sorry for that.
This is Vivek Kumar.
Okay. All set? When I say, then only play. So, like, the next person is, again, one of my friend and junior from PGI Chandigarh. He happens to be Director, Quest Diagnostics in US. His name is Dr. Vivek Kumar. Video, please.
Hello, friends. This is Vivek Kumar. I'm currently working as a scientific director at Quest Diagnostics. I'm responsible for chemistry and immunology departments, and I also teach pathology residents. So I hold the academic title with Texas A&M University. And I'm speaking to you because Dr. Chandprakash Pandey, who was my senior at PGI Chandigarh, asked me to attend the ICMLS-2024 meeting. However, I am not able to attend, and I actually will be visiting India starting December 1st. So I'll try and see if I can meet some of my old friends over there. I just wanted to let you know that my career actually started as a medtech trainee in a WHO funding program at PGI Chandigarh. That was way back in 1984. 1986, I started a job as a medtech in biochemistry department at PGI Chandigarh. Over the years, I always thought, how can I move forward? So I ended up going for master's program at PGI Chandigarh for biochemistry. And there was no stopping after that. And I met some of my good friends, some of my mentors, some of my seniors who encouraged me to keep moving forward. And that's how I ended up going for the PhD program at PGI. So I've been at PGI Chandigarh since 1984 until 2000, but that's when I completed my PhD. After PhD, back in the day, as you know, lots of people from PGI Chandigarh would end up in US to do some research. I started my postdoctoral research at Mayo Clinic in Rochester, Minnesota. Extremely cold weather, but very, very warm people over there, and great learning experience. So I was able to get some fellowship and then a career development grant. And during the process of reinvigorating the Mayo Clinic Research Fellows Association, I was actually the steering committee member to revive that association along with 2 other people. And the very first thing we did was we had some sort of a career guidance meeting in the tri-state area of Minnesota, Wisconsin, and Iowa. And what we learned from the esteemed speakers was that do not confine yourself only to a so-called niche, if at all possible. Why? Because there are so many opportunities that may be available outside of what you may be thinking of. So at least be aware of those and see if you can figure out a way to advance your career in any which way. And that's what we did. Me and my wife, we both were at Mayo Clinic, and we ended up going through a clinical fellowship program in clinical chemistry. So I had done research for like 7 years, and now I'm doing a clinical chemistry fellowship program, which will bring me back to the laboratory. That's where I started. So I took a scenic route to get back to the laboratory. So after my fellowship program, I was finished in clinical chemistry, I started a job as a clinical chemist at Beaumont Health System in Michigan. I was there for about 3 years, and then my wife and me both moved to Dallas, Texas, at a company called MedFusion, which was a startup laboratory, but we both were working together along with 7 other scientific directors. And it was very fruitful because we were able to get a lot of work done, lots of new tests we were able to bring in, even the lab developed tests. And then eventually 2017, Quest Diagnostics acquired that startup laboratory. So we have been with Quest Diagnostics since 2017, so 7+ years now. And it has been a great experience learning about quality and the whole culture of quality, and making sure that we as medtechs or the laboratorians ensure that we treat each patient's sample as a patient itself, so that we always do the best we can under the circumstances to ensure we provide the most accurate and precise result as possible in our lab environment. And there is a saying by Mayo brothers, who brought up the Mayo Clinic along with their father, that the patient's need always comes first. So being in medical laboratory sciences, being a medtech, being a pathologist, being involved with any of the healthcare, we must ensure that the patient's need always comes first, and we must do whatever we are required to do per our regulatory agencies, per our needs for the patients. We must do that day in and day out and ensure that we have quality culture. And then, at the end of the day, always keep that in mind, that you must find a way to continuously improve. Because that's another saying that I love. There is always room for improvement. So I wish you all the best. Keep improving upon your workflow, and keep making sure that you do the best for your patients every given day. So I wish you all the best. I wish I was there. I'll try and meet some of my friends when I'm visiting India later this year. All the best to you. Enjoy the meeting. Bye.
So, thanks for this round of applause. There were a few more actually, rather, 10, 15 out of them, but I could muster these two videos, and one person was supposed to come. I'll talk about him because he is here in India, and this fellow actually cracked that NET exam, and then he did his PhD at PGI Chandigarh under Professor and Head Biochemistry Department, Dr. Rajendra Prasad. The next person, PPT please, is Dr. Sudhir Kumar Sharma. He is again an alumni from PGI Chandigarh, and he was, after pursuing his PhD, obtaining his PhD, he went abroad for about 6 years. Then he came back and became Chief Operating Officer of Panisha Biotech, a company which deals with vaccines, and currently he is advisor to Quantum's, another RNA-based vaccine company based at Belgium. So, what is the purpose of intent? I've already mentioned, and I'll reiterate that even if you are into medical technology profession or medical lab technology profession, don't ever think that you are down under somewhere, you could not crack or you could not become something. So you should feel pride, you should be proud of what you're doing, and as my friend Dr. Vivek Kumar said, try learning new things, keep yourself up to date, and you will develop like anything. So message is basically to keep you motivated and inspired, and learning never keeps you, learning always enables you to achieve a bigger height, right? With those lines, I'll invite Dr. Kaptan Singh Sehrawat to take over further ahead. A big round of applause for all our heroes again, once again. So I've been entrusted upon to acknowledge the contributions of scientific committee, which was responsible for whatever scientific activity which we could muster during these 2 days. So I first of all acknowledge the contributions from all those who submitted their abstracts for making their presentations, either in oral form or poster form. A big round of applause for all the applicants who submitted their abstracts, because without them this conference wouldn't have happened actually. So besides that, I would try to recall all names actually. If I may miss out certain names from my committee, I at the outset only, because I have to read through, those names are the scientific committee. Besides me was Dr. Pankaj Kaul, then Dr. Malkeet Singh, keep clapping, then Dr. Tirumurugan Murli, and then we had Dr. Surendra Kumar Sharma, and then Alujit Kar, he's from Assam, and the local hero, Dr. Pramod Kumar Verma from AIIMS. So we should hear it loud. Dr. Ashwinder Rana, I have mentioned that. So I think this is it. If at all I have missed out certain name, due apologies to them. And we had probably you will give a feedback how it was. I am not here to invite any feedbacks right now. Probably we'll have it in the valedictory session. So thank you once again. We had a very great event. Thanks a lot. Now over to Dr. Kaptan Singh Sehrawat for the next.
Thank you, sir. Thank you for Dr. JIPMER team for giving this idea of inspiring heroes during last conference. And thank you, Dr. C.P. Pandey, sir, for repeating this idea again in AIIMS conference. Oh, Manojji, you are also. Thank you. So, this was a wonderful initiative. Last time during the JIPMER conference, it was first time introduced, and really, I hope you would have enjoyed this young students, leaders. Sky is the limit. क्या कुछ नहीं, कहाँ नहीं हो सकता. Everywhere is the possibilities. आप सोच सकते हैं BSc MLT from PGI Chandigarh is now leading a pharma company. Recent development हम बहुत hesitate होते हैं simple research पर. This is a very means lot of potentials are there in academic research, teaching, training, other even in industry, entrepreneurship. So many areas are there, unexplored areas are there. We have. So thing is कि इन सब चीज़ को हम कैसे इस ट्रेन वर्कफोर्स को पहले तो स्टैंडर्डाइज करें और फिर यूटिलाइज करें. बहुत सारे स्टेक होल्डर्स का. कमिंग बैक टू द आफ्टर दिस एक्टिंग एंड वेरी नॉलेजेबल सेशंस, कमिंग बैक टू द थीम ऑफ द कॉन्फ्रेंस, insight on navigating the future of medical laboratory sciences. यही तो शुरुआत की थी और यहीं से हम कोशिश करेंगे just to summarize the proceedings. I'm not here to summarize the technical proceedings, scientific proceedings, उसके लिए already scientific committee है. But what was the mission behind organizing this conference? The vision and mission of choosing this very relevant theme in current era of lab sciences in India when the regulatory landscape is also changing. बहुत सारी expectations, we have a lot of expectations from this new regulatory framework. सब कुछ तो शायद ये अच्छा, ये फॉर्मेट ज़्यादा अच्छा है, मिक्स रखते हैं, कुछ स्टूडेंट्स यहाँ से हैं, कुछ वहाँ से. इज इट ओके? और किसी एक फॉर्मेट में हिंदी और इंग्लिश में, क्योंकि मुझे लगता है कि दैट इज ज़्यादा इसको कॉम्प्लिकेट नहीं करते हैं, फिर से फैमिलियर हो जाते हैं और बहुत इनफॉर्मल वे से चीज़ें डिस्कस करेंगे, उतना ही ज़्यादा इन्जॉय करेंगे. अब कोई साइंटिफिक सेशन नहीं है. सो दिस इज अगेन यस but this is very sincere discussion that we should introspect where we are and what future we are anticipating in this new era of regulatory the scenario, regulatory landscape. So as far as when we talk about a profession and we call us as a professional, lot of responsibilities are there. Lot of things are expected from being a professional. सीधा सा ऐसे नहीं होगा कि टेक्नीशियन, अभी तो हम ठीक से टेक्नोलॉजिस्ट भी नहीं बोल रहे अपने आप को. अभी भी कल परसों मैंने 2-3 टॉक जो थी खुद एम्स से, जहाँ डेजिग्नेशन आज की डेट में टेक्नीशियन नहीं है. वो बहुत सारे जो लीडर्स थे कल, काफ़ी स्ट्रगलिंग जर्नी रही है, काफ़ी इंस्पायरिंग रही है. अब इस पूरे एम्स में कोई टेक्नीशियन नहीं है, लेकिन फिर भी आदत से कुछ को लगता है कि अपना डेजिग्नेशन एक लेवल भी नीचे हो गया तो परेशानी हो जाती है. लेकिन जब हम सामने वाले को अप्रिशिएट नहीं कर पाते गिवन डेजिग्नेशन के साथ भी, तो कई सारी टॉक में मैंने वो करेक्ट कराया कि दे आर नॉट टेक्नीशियन, और जिस वेन्यू पे हो रही है वहाँ तो कोई टेक्नीशियन है ही नहीं. तो मैं ये नहीं कहता हूँ कि सीधा टेक्नीशियन से टेक्नोलॉजिस्ट नाम रख देने से बन जाएंगे. द थिंग विच आई वुड लाइक टू शेयर विद यू इज दैट ये माइंडसेट चेंज होना चाहिए, ये हमारा बिहेवियर चेंज होना चाहिए. अदरवाइज सिंपली एक्ट just after, even we are struggling a lot for the implementation of act. Even if this act is fully implemented, जिस पे ये पूरी कॉन्फ्रेंस फोकस रही है, पूरा इसके इर्द गिर्द ही हम डिस्कस करते रहे, NCHP एक्ट, और अभी भी हमारे पास जो क्लोजिंग में गेस्ट हैं वो भी इस पर दोबारा से चीज़ें रिवाइज होंगी. तो मेरा ऐसा खुद का मानना है कि किसी एक चीज़ से आप यदि एक जादू ढूंढ रहे हैं कि प्रोफेशन एकदम चेंज हो जाएगा, ट्रांसफॉर्म हो जाएगा, एकदम बहुत अच्छा सा हो जाएगा, स्वर्ग जैसा होगा, ऐसा कुछ नहीं होगा. इट्स टाइम टेकिंग थिंग और बहुत कॉम्प्लेक्स है हमारे यहाँ कोई चीज़ चेंज करना, बिकॉज इतना बड़ा देश है, हम पूरे यूरोप से भी बड़े हैं, तो फिर सबके स्टेट के अपने लेजिस्लेटिव एडमिनिस्ट्रेटिव सेटअप हैं. लॉट ऑफ डिफिकल्टीज आर ऑल्सो देयर, बट लीडरशिप तो वहाँ है जब आप बहुत सारी डिफिकल्टीज में काम करें और कोसना बंद करें, रोना बंद करें कि ये नहीं हो सकता, वो नहीं हो सकता, काफ़ी कुछ हो सकता है. और उसी के लिए हमने आपको इंस्पायर करने के लिए डॉक्टर CP पांडे सर ने या भी आपको वीडियो, तो इन लोगों ने उस टाइम में सोचा होगा. आज तो बहुत सारी पॉसिबिलिटीज़ हैं. जब इंडिया में बहुत सारा 10-20, 2%, 1% लोग ये PGI जैसे बड़े इंस्टीट्यूट जिपमेर से ये क्वालिफाइड, इन रियल मायने में तो क्वालिफाइड आज भी वही ज़्यादा लीड कर रहे हैं, क्योंकि बाकी जगह क्वालिफिकेशन के नाम पे एक तरह से बिजनेस शॉप की तरह चल रहा है ना, तो वो स्टैंडर्डाइजेशन सबसे बड़ा चैलेंज है. तो कमिंग बैक टू द अगेन द थीम, देयर आर मैनी पिलर्स टू स्ट्रेंथन टू नेविगेट दिस प्रोफेशन, फ्यूचर ऑफ दिस प्रोफेशन. इन फैक्ट वन इज हम खुद ही हैं कि हम अपने आप को थोड़ा सा स्टार्ट करें. स्टूडेंट हैं तो स्टूडेंट के रूप में लीडरशिप देखें हम क्या क्या जानते हैं. व्हेन वी आर ए वर्किंग प्रोफेशनल तो थोड़ा सा हम चेंज करें अपने तौर तरीके, बिहेव को, कि साइंटिफिक प्रोग्राम्स विल बी द नीड ऑफ द आर्ट. मतलब वो ज़रूरत रहेंगी. कुछ दिन बाद तो आपकी अपार का, दोज हू आर इन गवर्नमेंट सेक्टर, अपार का हिस्सा होंगी, वो एनुअल अप्रेजल का पार्ट रहेंगी. और अभी कुछ दिन बाद गाइडलाइन उस पर आ भी जाएंगी. NCHP आपको मैंडेट करेगा कि आपको एनुअली आपने कितनी कॉन्फ्रेंसेस, क्या कुछ किया है, कुछ और भी कर रहे हैं, जो कि बाकी फैकल्टीज़ के लिए, बाकी कैडर्स के लिए, हायर लेवल पे जो इंजीनियर्स, डॉक्टर्स हैं उनके लिए ऑलरेडी ये प्रोविजंस हैं. एंड रेगुलेटरी इज एडवोकेटिंग फॉर दैट. तो फर्स्ट थिंग इज दैट वी शुड एजुकेट, रियली एजुकेट. सिर्फ एक डिग्री डिप्लोमा लेकर के हम खुश ना हो, डॉक्टरेट लेकर के खुश ना हो. उस डॉक्टरेट से बहुत सारी उम्मीद बढ़ जाती हैं. बहुत सारे मास्टर डिग्री के बाद यू आर ए स्पेशलाइज इन ए पर्टिकुलर एरिया. सो when we are a student we have lot of responsibility, when we are a working professional we have lot of responsibility, when we are as a faculty member in a particular university, whether in government or in private, तब भी बहुत सारी जिम्मेवारी हैं. प्लीज़ अदरवाइज मत लीजिएगा. हमें सिर्फ जॉब के लिए ऐसा नहीं है कि मैनेजमेंट को खुश रखने के लिए, कहीं कहीं थोड़ी सी आवाज़ उठानी है कि ये सही है, ये गलत है. तब थोड़ा थोड़ा कोशिश सबकी होगी, तभी तो चेंज आएगा. अदरवाइज आप कहेंगे मैं मैनेजमेंट के लिए काम करना है, इससे वी आर बाउंड टू फॉलो द रूल. यस ऑफ कोर्स वी आर बाउंड टू फॉलो द रूल एंड रेगुलेशन ऑफ द एस्टेब्लिशमेंट, बट स्टिल देयर आर लॉट ऑफ थिंग्स वेयर जब कैडर पे बात आए, जब प्रोफेशन पे बात आए, जब रिस्पेक्ट पे बात आए, तब खड़ा होना बहुत ज़रूरी होता है. चेंज यदि लाना है आपको. एक चीज़ एजुकेशन, ऑफ कोर्स उसके पीछे मैंने कहा मेजर पिलर है कि एजुकेशन का स्टैंडर्डाइजेशन देश में बहुत ज़रूरी है. आप किस माहौल में पढ़े, हम सब ने कैसे डिग्रियां की, किस स्ट्रगल में की, उसको रिपीट, और उसको बहुत ज़्यादा गाने बजाने से कुछ होगा नहीं कि हम तो ऐसे पढ़ते थे, हम वैसे पढ़ते थे. अब यहाँ से स्टार्ट यदि हो रहा है तो हम बेटर कैसे, हम 56 कैटेगरीज हैं, हम उनमें बेटर कैसे परफॉर्म करें, कैसे अपने आप को इस्टेब्लिश करें अगले 2, 4, 5 साल, वो तय करेगा कि हमारी भूमिका इन कमीशंस में, इन काउंसिल्स में कैसी होने वाली है। वहाँ आप यदि इतनी बड़ी वर्कफोर्स हम यहाँ से खूब जोर से कह रहे हैं कि वी आर द लार्जेस्ट वर्कफोर्स आफ्टर नर्सिस एंड डॉक्टर्स, जब ये बात कहते हैं तो उसी प्रपोर्शनेटली वी हैव लॉट ऑफ रेस्पॉन्सिबिलिटीज टू बी ए प्रोफेशनल। हमें लगना चाहिए कि हमारे पास सबसे ज़्यादा PhD इन मास्टर हैं। अभी भी कल रेडियोथेरेपी से हमारे साथी थे, उनके यहाँ अभी तक PhD क्या मास्टर भी नहीं हो रहा है। और एनेस्थीसिया ऑपरेशन थिएटर के एसोसिएशन के PGI के हमारे कलीग यहाँ पे हैं एज ए गेस्ट, इनसे पूछो, आज भी इनका चैलेंज है कि हम करिकुलम किसके लिए बनाएं। वी डोंट हैव ए करियर पाथवे फॉर द एनेस्थीसिया ऑपरेशन थिएटर टेक्नोलॉजी। सिंस आई एम ऑल्सो डीलिंग ए ज्वाइंट फोरम नेशनली, तो मेरा एक बड़ा इंटरेस्टिंग सी जर्नी है, उसमें लैब के अलावा भी काफ़ी लोगों से इंटरेक्शन है लीडरशिप के साथ। सो वी हैव रियली बहुत सारी डिफ़िकल्टीज़ हैं लैब में, फिर भी कम है क्योंकि वी हैव द क्वालिफिकेशंस, क्वालिफाइड पीपल आर देयर। बहुत आसान भी है। थिंग इज वी नीड टू बी ऑर्गेनाइज, वी नीड टू बी रियली प्रोफेशनल। प्रोफेशनल मीन्स हमारे पास हमारे पब्लिकेशंस हों, हमारे एक्रीडिटेड इंस्टीट्यूशंस हों, रियली एक्रीडिटेड हों, सिर्फ सर्टिफिकेशंस की सर्टिफिकेट की बात ना करें। और ऑफ कोर्स जब एजुकेशन एक्रीडिटेड होगी तो स्टैंडर्ड थोड़ा सा अप होगा, एथिक्स हो, स्टैंडर्ड हो प्रोफेशन में। और हमें लगना चाहिए कि यस वी आर ए प्रोफेशनल, हम टेक्नीशियन से टेक्नोलॉजिस्ट हुए, एंड टेक्नोलॉजिस्ट जो है वो प्रोफेशनल की तरह हैं, वो साइंटिस्ट की तरह हैं। यदि आपने साइंटिस्ट का सपना मास्टर होकर के देखना शुरू किया है तो उसके लिए प्रोफेशनल होना बहुत ज़रूरी है। बहुत डेडिकेटेड एरिया है एकेडमिक्स और साइंटिस्ट होने का। उसमें सिर्फ आप इतनी सी छलांग ऐसे नहीं हो पाएगा कि सरकार में कुछ कैड रिव्यू किया और हमने नाम बदल दिया, जैसे अभी इस बार हुआ है। अब आपको शायद मालूम नहीं, एम्स में जो क्वालिफाइड नहीं थे उस कैड रिव्यू में वो भी अपग्रेड होकर के यहाँ से, इस बात से हम इम्प्रेस नहीं है कोई STO यहाँ है, CTO यहाँ है। CTO इज ए क्लास 1 पोस्ट, बट वो उस कैडर रिव्यू की देन है। उसने या उन कैडर रिव्यू रिस्ट्रक्चरिंग ने उनके डेजिग्नेशन को अप किया है। बट अब थिंक द नीड ऑफ द आर इज जस्ट टू एम्पावर दैम एजुकेशनली, एम्पावर दैम प्रोफेशनली। सरकारी डेजिग्नेशन तो हो सकता है CTO, बट CTO जब आप कहते हैं लॉट ऑफ रेस्पॉन्सिबिलिटीज आर देयर इन डिपार्टमेंट, तब आपको पिपेटिंग और टेस्टिंग में ही इन्वॉल्व नहीं होना, तब आपके पास बहुत सारी चीज़ों की, ऐसे ही एकेडमिक इंस्टीट्यूशंस के लिए, फैकल्टीज़ के लिए। मैं फिर कमिंग बैक टू दिस 4-5 इंपॉर्टेंट थिंग्स, एजुकेशन एक चीज़ है। इन सब के बाद ये तो हमारी एक्सपेक्टेशंस हैं जस्ट टू एम्पावर द प्रोफेशन। हम जो सेंटर में पेशेंट है उसके लिए जो हम सब हैं, जो हमारा प्रोफेशन है वो पेशेंट के इर्द गिर्द है। यदि हम उन पेशेंट की चिंता नहीं करते हैं, प्राइवेट में तो बिजनेस की चिंता करते हैं, गवर्नमेंट में तो हम सैलरी स्ट्रक्चर की चिंता करते हैं, तब सब यूजलेस है। उस प्रोफेशन का ग्रो करने का भी फायदा, दैट विल बी ए काइंड ऑफ सुपरफिशियल प्रोग्रेशन ऑफ द प्रोफेशन। सो द फॉर द पेशेंट सेफ्टी एंड रिस्क मैनेजमेंट आप हर तरफ सोच सकते हैं, तब रियल अप्रिसिएशन आएगा कि पेशेंट केयर में, पब्लिक में, कि यस ये लैब प्रोफेशन बहुत रेगुलेटेड है, एक्रीडेटेड है। क्यों चाहिए रेगुलेशन? बिकॉज पेशेंट सेफ्टी इज देयर। हम कोई प्रोडक्ट क्रिएट नहीं कर रहे हैं, 2 खराब होंगे तो 2 ठीक हो जाएंगे। हम वी आर डीलिंग विद द वेरी साइंटिफिक एरिया ऑफ पेशेंट केयर। तो इन सब चीज़ों की ज़रूरत है। मैं क्योंकि ज़्यादा वक्त नहीं लेता हूँ, और क्विज के लिए थोड़ा सा हमारे पास, हमें थोड़ा सा 10 मिनट और चेंज करना होगा। इस बीच वी हैव, और ये कोई विज़न मुझे अच्छा ही नहीं लगता कि मैं कोई अपना विज़न प्रेजेंट करूं। इट्स ए कलेक्टिव जर्नी, कलेक्टिव विजन, कलेक्टिव मिशन, और कुछ ऑब्जेक्टिव्स हैं। मैंने बताया एजुकेशन को स्टैंडर्डाइज करना, कलेक्टिव रेस्पॉन्सिबिलिटी, सर्विस कंडीशन को सुधारना, ऑफ कोर्स एसोसिएशन इज देयर, बट आपकी लोकल लेवल पे लीडरशिप तो होनी चाहिए। फैकल्टी में लीडरशिप प्रोग्राम हो, वर्किंग प्रोफेशनल के लिए यंग लीडर हो, लेबोरेटरी हीरोज, लेबोरेटरी लीडर्स, स्टूडेंट के लीडर्स हों, बहुत कुछ है। तरीके हमें मालूम है कैसे होंगे, पर एम्पावर करने के लिए कलेक्टिव अप्रोच चाहिए। For that purpose, we will have a just 20-minute session again. और यदि इंद्रेश, if you can organize few chairs, तो हम दोबारा से कुछ सीनियर जो हमारे साथी हैं उनको बुलाते हैं, और उसके बाद जो है इस सेशन को ये कंक्लूड होगा। ये इंसाइट अब इस थीम के साथ वो इंसाइट देंगे आपको। हम समझना चाहते हैं कि वो क्या समझते हैं इस कॉन्फ्रेंस के बारे में, इस विजन और मिशन के बारे में। 7-8 चेयर्स तो उसके लिए आई वुड लाइक टू इनवाइट फ्यू सीनियर प्रोफेशनल। 2-3 चीज़ मुझसे स्किप हो जाएंगी। बहुत सारे, पहली बार मैंने नोटिस किया बहुत सारे सीनियर फैकल्टी यहाँ, इसके लिए मैं माफ़ी चाहूँगा कि आपके आई कार्ड पे ज़रूर डेलीगेट लिखा होगा. वी नो यू आर ए असिस्टेंट प्रोफेसर एंड फैकल्टी मेंबर्स एंड वी रिस्पेक्ट योर पोजीशंस. कॉन्फ्रेंस क्योंकि ये अगेन इट्स ए मल्टी डिसिप्लिनरी एरिया, नॉट ए सिंगल, कोई बायोकेमिस्ट्री की नहीं है, कोई माइक्रोबायोलॉजी की नहीं है, मेडिकल लैब साइंस इज ए वेरी डाइवर्स एरिया. उसमें भी हमें मालूम ही नहीं एक्चुअली कि किस पोजीशन पे कौन है, क्योंकि आपने जो भी सबमिट किया है पेपर हर किसी ने डिटेल नहीं. अब इसमें डिस्प्यूट क्या खड़ा होता है, जब रजिस्ट्रेशन काउंटर पे कोई कहता है मैं फैकल्टी हूँ, बट उन्होंने तो मेंशन नहीं किया है, तो हमने सिंपली डेलीगेट्स एंड जो फैकल्टी हमारे ICMLS के हैं उनको ही एज ए फैकल्टी ट्रीट किया है. इसका मतलब ये बिल्कुल नहीं है कि आप सीनियर पोजीशन होल्ड नहीं करते हैं, आप फैकल्टी नहीं है. तो इसके लिए मैं माफ़ी चाहूँगा कि हमने ऑर्गेनाइज करने में ये पता था हमें कि यू आर मीन्स स्कॉलर्स आर पार्टिसिपेटिंग, फैकल्टी मेंबर्स आर पार्टिसिपेटिंग, तो उनके लिए बहुत ड्यू रिस्पेक्ट है. एंड उनका एक ग्रुप फोटो हम अलग से भी चाहेंगे, स्टूडेंट का भी अलग से, फैकल्टी मेंबर्स का भी, सो दैट वी कैन ऑल्सो नो कि इतने सारे फैकल्टी एंड स्कॉलर्स इस बार, आपने भी देखा होगा बहुत सारे PhD स्कॉलर्स दे आर कमिंग फॉरवर्ड टू प्रेजेंट साइंटिफिक पेपर. आने वाले समय में आपको खुद लगेगा एक बड़ा स्ट्रॉन्ग PhD का एक फोरम बन जाएगा. PhD अभी तक हमें कोई प्लेटफॉर्म नहीं मिलता था कि हम कहाँ अपनी थीसिस को प्रेजेंट करें, और अभी मुझे मालूम है बहुत सारे चैलेंज है, एथिकल अप्रूवल, गाइड लाओ, को गाइड लाओ. मैंने भी डॉक्टरेट किया तो मुझे मालूम है एक सेंट्रल गवर्नमेंट इंस्टीट्यूट में बहुत बड़ी भीड़ के बीच से निकलने में बहुत मुश्किलें आती हैं, और कोविड टाइम था तो और ज़्यादा चैलेंजिंग हुआ. तो 3 बार एथिकल अप्रूवल के लिए मेरे को प्रेजेंट करना पड़ा था उस दौरान. तो ये, और मेरा वैसे ही पीडियाट्रिक्स था तो और ज़्यादा मुश्किलें थी. तो ये सब चीज़ें सबके साथ होती हैं, और ये कोई PhD कर लेने से मुझे ज़्यादा तसल्ली अब भी नहीं है, पहले भी ऐसा कोई सपना नहीं था कि PhD करने का. और मैं आपसे भी ये उम्मीद करता हूँ कि एक्चुअल लीडरशिप दें. एकेडमिक्स में तो एकेडमिक्स में, रिसर्च में है तो रिसर्च में, प्रोफेशनल डोमेन में है तो प्रोफेशनल डोमेन में, स्टूडेंट है तो स्टूडेंट के लिए. तो विदाउट वेस्टिंग मच टाइम आई वुड लाइक टू कॉल ऑन द स्टेज, और उनसे भी मैं थोड़ा चाहूँगा प्रिसाइज रहें, क्योंकि अब लोग आपको भी देख रहे हैं, और आपको जब स्टेज पे हैं तो इस बात का ख्याल रखना होगा कि माइक, क्योंकि टाइम मुश्किल है. मेरे लिए सबसे ज़्यादा नाराज़गी मुझे ये मिलेंगी कि रोकना पड़ता है सबको, और कॉन्फ्रेंस 4 दिन की हम कर नहीं सकते, इन 2 दिन में सब कुछ करना होता है. उसमें से भी एक दिन इस बात के लिए चला गया कि हम प्लानरी डिस्कशंस कितने ज़्यादा कर सकें. साइंटिफिक प्रोग्राम तो आपको बायोकेमिस्ट्री की कॉन्फ्रेंस मिल जाएंगी, माइक्रोबायोलॉजी की मिल जाएंगी, कोई इंटीग्रेटेड कॉम्प्रिहेंसिव प्लेटफॉर्म जहाँ आपके चैलेंजेस और अपॉर्चुनिटीज़ को डिस्कस किया जाए, वेयर वी कैन डिस्कस विद आवर एक्सपर्ट, जैसे डॉक्टर भट्ट, एक इंस्पायरिंग, मतलब कहाँ कुछ नहीं हो सकता, सब तरफ रास्ते हैं, बस आपको ढूंढना है. तो आई वुड लाइक टू कॉल डॉक्टर मलकीत सिंह सर, प्लीज़ आइए. सर की इंट्रोडक्शन कल रह गई थी. सर वैसे तो ज़रूरत नहीं है, मेरे स्टाफ था उनको नहीं मालूम होगा, बहुत सीनियर है, रिटायर्ड फ्रॉम PGI हैं, मेरे ख्याल 35-40 साल तो PGI को भी दिए हैं, अब ये प्राइवेट में हैं. ICMLS को देने की ज़रूरत है अब, क्योंकि अब तो नौकरी तो दोनों तरफ आप कर ही रहे हो, पहले भी कर ली. और दूसरी चीज़ ये है, हालांकि यहाँ तो प्रेजेंस रहती है, लेकिन मुझे फिर, बैठिए सर बैठिए प्लीज़, अभी आपके सामने क्वेश्चन भी तो आएंगे डेलीगेट्स के. तो मिस्टर हरीश कुमार पांडे, सॉरी पांडे जी कल पैनल डिस्कशन में थे, वो शोर शराबे में इनका नाम ही मिस हो गया उनसे, तो और जयपुर वालों ने सब गड़बड़ की थी. पांडे जी का नाम अनाउंस हुआ, शोर मचाना शुरू किया. पांडे जी कल, सॉरी कल के लिए हम, और सर आपकी इंट्रोडक्शन मैं फिर से डिटेल में देता हूँ. सर ये वो हीरो हैं जिन्होंने PhD में बहुत पहले PhD कर ली थी, PGI में सॉरी, और PGI को तो वैसे ही सलाम सब करते हैं, तो ये बड़े हीरो हैं, सुपर हीरो, और यहाँ के भी सुपर हीरो हैं, पर इनका ख्याल सबका रखना पड़ता है. वो इतने ज़्यादा सीनियर हो गए, अब गैप इतना हो गया, मुझे रोकने में भी हेजिटेशन होती है, पर रिस्पेक्टफुली रियली आप इस उम्र में, पर मैं फिर भी कहूँगा, ये ज़्यादा अप्रिशिएट करूँगा कि आप बहुत सीनियर हो गए तो ये काम करना बंद करेंगे. तो कल डॉक्टर लाल का एक एग्जाम्पल दे सकता हूँ, वो शायद मैंने एज तो चेक नहीं की, बट वो 70 क्रॉस कर चुके हैं, 75 के करीब. आपने उनकी टॉक को यदि किसी ने सुना होगा, सब नहीं सुना होगा, तो आप सोचिए 15 साल, 60 के बाद 15 साल, तो और वो इतनी एनर्जी में है, तो इनसे तो कम से कम हम 80 साल तक ऐसे उम्मीद करते हैं. ये अभी रिटायर हुए हैं तो 2 साल पहले. तो ऐसा जो मान लेते हैं हमारे, ये भी एक पिलर है. जो सीनियर है उन्होंने मान लिया 60 साल की नौकरी, प्राइवेट या सरकारी पूरी हो गया, हमें क्या मिलना, ऐसा नहीं है. और स्टूडेंट ऐसा सोचते हैं हमें क्या, उनके सपने बहुत बड़े हैं, बट वो समझना नहीं चाहते. तो दोनों तरफ से बैलेंस होगा, और वर्किंग प्रोफेशनल सैलरी से बाहर नहीं आते, अलाउंसेस से बाहर नहीं आते. तो ये जो गैप है इसको भर के एक इंटीग्रेटेड डेवलपमेंट ऑफ प्रोफेशन के लिए वी शुड ट्राई। सेकंड थर्ड पर्सन इंद्रेश कुमार सिंह, बहुत कम आपने इधर उधर भागते देखा होगा, मंच पे नहीं पाया। इंद्रेश इज द ऑर्गेनाइजिंग सेक्रेटरी ऑफ दिस कॉन्फ्रेंस, और इनको हमने सर को लाइफ टाइम अचीवमेंट अवार्ड भी ICMLS से दिया, और पांडे जी को कल ही आपने यंग लीडरशिप ICMLS की लीडरशिप के लिए अवार्ड। इंद्रेश वाज द फर्स्ट इन लेडी हार्डिंग कॉन्फ्रेंस, फर्स्ट कॉन्फ्रेंस में हमने इनको कोशिश की थी कि एम्स से कोई निकलना चाहिए, पर इनको कुछ साल तो लगे इस कॉन्फ्रेंस को करने में। 2017 की कॉन्फ्रेंस में इनको हमने यंग लीडर्स के रूप में अप्रिशिएट किया था अवार्ड से, तो अब कुछ साल के बाद सही, लेकिन नाउ ही इज़ द ऑर्गेनाइजिंग सेक्रेटरी। उनको बार बार याद दिलाया मैंने कि आपको हमने लीडरशिप में जो है रोल दिया हुआ और अप्रिशिएट किया हुआ है, तो आप कहीं पे तो आज इंद्रेश जी ओके, सो इज़ द ऑर्गेनाइजिंग सेक्रेटरी। डॉक्टर सुरेंद्र कुमार शर्मा, कल आपने देखा होगा, डॉक्टर सुरेंद्र इज ऑल्सो वन ऑफ द अवार्डी ऑफ ICMLS। कहाँ पे हैं डॉक्टर सुरेंद्र जी? डॉक्टर सुरेंद्र को अच्छा जी, थैंक यू सर। डॉक्टर सुरेंद्र इज अ यंग साइंटिस्ट ऑल्सो। इससे पहले हमने एक और भी अवार्ड से आपको नवाजा, क्या था दूसरा? बेस्ट लैब प्रैक्टिसेस, लास्ट कॉन्फ्रेंस में जिप में। तो डबल रेस्पॉन्सिबिलिटी अब लैब प्रैक्टिसेस में भी और रिसर्च में भी। मैं सोनल सांगवान फर्स्ट टाइम ये आई थिंक ICMLS कॉन्फ्रेंस में आए, फर्स्ट टाइम ही अवार्डी हैं। तो हम मतलब नॉमिनेशन बहुत कम थे, कोशिश भी की प्रमोट करने के लिए, फर्स्ट टाइम ऐसा अवार्ड भी एक तरह से अनाउंस किया गया था। तो सोनल सांगवान, यदि आप हैं तो आप भी ज्वाइन करें। ऑन गोइंग PhD स्कॉलर हैं PGI चंडीगढ़ की, तो हमें लगा कि ऑन गोइंग PhD को अप्रिशिएट करना ज़्यादा ईजी है। हम नए सब कंप्लाइंसिस इतने कम टाइम में चेक नहीं कर पाएंगे, एक कम अमाउंट है, लेकिन 25,000 की रिसर्च ग्रांट उनको हमने ICMLS की तरफ से दी है, और अप्रिसिएशन के लिए भी अवार्ड दिया। गोपाल शर्मा जी चेयर हैं, तो राजेश को भी बुलाओ आज, राजेश के क्वेश्चन रह जाएंगे नहीं तो। अच्छा यहाँ से पूछना, ठीक है। गोपाल जी भी अब ऊपर हैं, दोस्त आपस में पूछना, वो नीचे हैं जी। सरोज मैम, सरोज मैम है या नहीं है? ओके, यदि आ जाएंगी तो अब आपके लिए मैंने अपनी बात आपको इस नेविगेटिंग द फ्यूचर ऑफ मेडिकल लाइफ साइंसेस बताई। कल किसी का एक थोड़ा सा हल्का सा रिएक्शन ही आया, लेकिन ये बात सही है, बिना आपके विजन के, बिना आपकी डायरेक्शन की कोई कलेक्टिव विजन नहीं हो सकता, कलेक्टिव इंसाइट नहीं हो सकती। तो आप खुल के, जिसके माइंड में स्टूडेंट के जो है, ये सामने पैनलिस्ट हैं, कोई यदि पैनलिस्ट अभी नहीं है ज्वाइन कर पाए हैं, राणा जी भी तो थे इसमें, राणा सर तो अब आ रहे हैं, राणा सर एक मिनट आइए आप भी। यही तो दिक्कत है, आप लोग जब मैं बुलाता हूं तब बाहर होते हो कहीं। तो अच्छा, मिस्टर राणा इज ए ट्यूटर टेक्नोलॉजिस्ट, रिटायर फ्रॉम PGI, बहुत सीनियर। हिमेटोलॉजी में कोई टकराना मत, सुबह देखा था ना आपने, हिमेटोलॉजी के जितने टॉक आ रहे थे वो माइक पे थे, तो बहुत सारे स्टूडेंट इनके शायद वो भी बड़ी बड़ी पोजीशन पे होंगे PGI से। तो ये PGI से कोई पहले ही सलाम कर दो आप, PGI से मिल जाए कोई और टीचिंग में मिल जाए फैकल्टी, तो अच्छा तरीका है, पहले से सलामी दे दो कि सर। तो कई तो टीचर वहाँ ऐसे ही हैं कि वहाँ स्टूडेंट ने यदि सलामी नहीं दी तो उसको पहले उसके नॉलेज से उसको डाउन करते हैं कि आप। तो चलिए आप भी आए मैम। तो अब ये सेशन आपके लिए खुला, जो आप क्वेश्चन करेंगे मैं जस्ट मॉडरेट करूंगा, अगली 10-15 मिनट हम दे सकते हैं इस सेशन में, और एक एक क्वेश्चन तो आप सबसे आना चाहिए, हर सेक्शन से आना चाहिए, बिना हिचक के आना चाहिए, तब अच्छा लगेगा। अदरवाइज मैंने कोशिश की है, आप भी कोशिश करिए कुछ पूछने की इनसे, देखते हैं इनकी इनसाइट क्या है, और फिर हम देखते हैं उसमें हम क्या कर सकते हैं एज ए ऑर्गेनाइजेशन। ओपन सेशन है सबके लिए, कोई स्टूडेंट के माइंड में कुछ है, लेकिन मैं फिर कोशिश करूंगा कौन अच्छा आंसर दे सकता है। आई वुड लाइक टू मॉडरेट दिस सेशन ऑल्सो। पैनलिस्ट आपके पास हैं जी जी, प्लीज माइक कोई है वहाँ, एक माइक रखिए प्लीज। थोड़ा सा कोशिश आप भी प्रिसाइज करिएगा और प्रिसाइज क्वेश्चन रखिएगा जी।
Sir, my name is Rekha. I am a PhD scholar from NIMS University and running my own blood collection franchisee of Mankind Pharma in Pratap Vihar, Ghaziabad. So you have made the norms for technician, for education and all that, but what was the norm for salary wages in private institution? I know lots of technician, they are doing in working salary of 13,000, 10,000. Nobody is going to pay attention towards that. So what is the survival about that, medical lab technologist?
So there is norms for that also. And you also say that nobody is paying attention in private institution about all that. And nobody is taking care about that. They said that if you are working in that condition, it's your norms, your responsibility. You say no, but how can?
Good question, ma'am. Any other question?
One fresher person has to survival for doing all of that. His family is also dependent upon that.
I got it. Thank you, ma'am. Thank you for, this is a very valid question. Who will respond? But quick response should be there. बहुत अच्छा क्वेश्चन आपका, बहुत बड़ा.
हेलो
जी.
Ma'am, thank you very much. You had a courage to ask such a question. You have raised a very, very important point. इसमें बहुत सी चीज़ें रिस्पॉन्सिबल हैं जहाँ तक मैं समझता हूँ. सबसे पहले तो गवर्नमेंट पॉलिसीज ही रिस्पॉन्सिबल हैं. गवर्नमेंट पॉलिसी, मैं अभी जब मैं एज ए डीन एकेडमिक्स ज्वाइन किया, इट वाज ए सरप्राइज टू मी कि एज पर यूनिवर्सिटी ग्रांट्स कमीशन एक असिस्टेंट प्रोफेसर की मिनिमम सैलरी 21,600 है. असिस्टेंट प्रोफेसर की एज पर यूनिवर्सिटी ग्रांट्स कमीशन. इफ यूनिवर्सिटी ग्रांट्स कमीशन सेज के 21,000 सफिशिएंट है प्रोफेसर के लिए जो एमबीबीएस जो मास्टर्स है या पीएचडी है, तो उसी के हिसाब से जो लोग प्राइवेट कॉलेजेस तो उससे ज़्यादा देंगे नहीं जो यूजीसी ने मिनिमम क्राइटेरिया दे दिया. ठीक है.
No, sir, एक मिनट, सॉरी टू इंटरप्ट, मुझे करना पड़ेगा बीच बीच में, टाइम की प्रेशर बहुत बढ़ता जाएगा. आप मुझे थोड़ा सा, ये उनका क्वेश्चन बहुत वैलिड है. टेक्नीशियन है, टेक्नोलॉजिस्ट है, साइंटिस्ट है, कुछ भी है, गवर्नमेंट की पॉलिसी को भी रोना बंद करिए. आप एज एसोसिएशन हम क्या कर सकते हैं और कैसे करना चाहिए, इस पे इंसाइट चाहिए आपको, क्योंकि मैं सब कुछ तय नहीं कर सकता. ये कॉमन कलेक्टिव इंसाइट चाहिए मुझे भी कि हम क्या कर सकते हैं, क्योंकि गवर्नमेंट तो इनको 10,000 में रख रही है. नर्सिंग के लिए भी ऐसा हुआ था एक बार कि उनको भी ऐसे आउटसोर्स करना शुरू कर दिया था, बट अगेन दैट इज ए पावरफुल वॉइस. तो आप देश भर में जो 10,000 में टेक्नीशियन
है ना, हमारी जो सिचुएशन है उस सिचुएशन में हम जब हमें जॉब ऑफर होता है हम उसी वक्त एक्सेप्ट कर लेते हैं उसको. हमारी पॉपुलेशन बहुत ज़्यादा है, अनएम्प्लॉयमेंट बहुत ज़्यादा है इस सिचुएशन में, और वो उसका नजायज़ फ़ायदा प्राइवेट कंपनियां उठा रही हैं. आप 10,000 पे एग्री कर रहे हो, 8,000 वाला 5,000 वाला भी वहाँ खड़ा होता है करने के लिए. और मुझे जो इंस्टीट्यूशंस हैं वो कोई भी इंस्टीट्यूशन आपको उससे ज़्यादा नहीं देगा जो उनके पास कैंडिडेट खड़ा हुआ है. तो हमें सबको मिलके एक जा तो कुछ जो हमारी प्रोफेशनल ऑर्गेनाइजेशंस है जैसे ये ऑर्गेनाइजेशन है, इस पे हम लोग कुछ डिसीजन करें, इससे कोई एक्शन हो. अगर कप्तान सिंह जी इसमें कुछ सजेशन दे सकते हैं कि क्या ऑर्गेनाइजेशनल व्यू पे हम कुछ कर सकते हैं.
तो चलिए मैं इसको टाइम, एक सेकंड सर, नहीं अभी पैनलिस्ट है और आप क्वेश्चन कर सकते हो, आप आंसर नहीं देना.
I just want to add in this very small input, like if you have studied from a good institution, so definitely you are going to get good perks. If you have some, the expertise, so you will get the proper salaries. So rest assured, that is fine, ma'am, that is fine. Just listen to me. Now the NCHP is there. If you will be having a license examination, some minimum standards to qualify to do as a practice, okay? So in that situation, now we are in the transition phase. Probably the good era is about to come. Once you will be having the license, definitely we are going to have some minimum perks, minimum wages for that. And I hope our NCHP chairman will form some guidelines for this. And our association definitely will write your concern, which we are getting the inputs from all the audience, and we will cater the private practitioners also regarding the competencies examination of particular qualifications, okay?
Any other input or insight on this, sir? Mike. Ji, sir.
Your question is very valid, and in my view, it is the duty of our organizations also to change that designation as MLS or Junior Medical Life Scientist. Unless we write on to the government from our organization, nobody will take care of that.
Hello. Good afternoon. May I
एक में अभी स्ट्राइक किया, जैसे कि हम एनएबीएल में एक्रेडिशन करते हैं तो देयर इज सम मिनिमम क्वालिफिकेशन, कैन वी वर्क ऑन द पे स्केल्स आल्सो ऑन दैट?
No, they are very.
They are putting it, but my
No, but
observation
they
is
yes, वो घूम के क्वेश्चन तो आएगा मेरे पास, लेकिन she is particular about the private health sector where people are employer are just hiring them on just 10,000, 5,000, 15,000. So this is the question. I think
because
this is
NABL accredited हो जाएगा अगर उसके
नहीं,
साथ qualification
कुछ फर्क नहीं पड़ता मैम, NABL accreditation is voluntary process. चलिए इस क्वेश्चन को हम एक आधा क्वेश्चन और लेते हैं, ये एक क्वेश्चन है आपके लिए, इसको मैं एक साथ रिस्पॉन्ड करता हूँ फिर।
सर मैं एक क्वेश्चन करना चाहता हूँ।
हाँ जी क्वेश्चन करिए।
सर गवर्नमेंट ऑफ इंडिया ने कुछ नोटिफिकेशन जारी किए हैं, मैं पैनलिस्ट से अनुरोध करूंगा कि अपने अपने हॉस्पिटल में ये सभी टेक्निकल कैटेगराइजेशन किया है, स्किल्ड प्रोफेशन, सेमी स्किल्ड प्रोफेशन और नॉन स्किल्ड प्रोफेशन। लेबोरेटरी कैडर में एक नॉन स्किल्ड प्रोफेशन होता था जो लैब अटेंडेंट होता था, जो कि ऑलमोस्ट धीरे धीरे अब एवोल्यूस हो गया है। अब रह गया है सेमी स्किल्ड और स्किल्ड, जहाँ क्वालिफिकेशन अमेंडमेंट हो गए हैं, जहाँ बीएससी प्रोफेशनल हो गया है, वो स्किल्ड में आते हैं। हमारे यहाँ एम्स में 21,000 सैलरी मिलता था, अभी रिसेंटली नोटिफिकेशन स्किल्ड में आके उनको 41,000 एंड सर्कुलेट हो गया है, या मिनिमम जो आपकी क्वालिफिकेशन है वो प्रोफेशनल हो गई है। इसी प्रकार उसका एडवर्टाइज करना चाहिए कि जो लेबोरेटरी में काम करते हैं वो सभी स्किल्ड है।
सुनिए तो सही है, मेरी भी तो सुनिए, आप फिर एम्स पे आगे, मैं कहता हूँ वो प्राइवेट के लिए क्वेश्चन पूछ रही है।
प्राइवेट का जो ये जो नियम निकाले हैं लेबर लॉ ने निकाले हैं, क्या मिनिमम वेजेज जो लेबर मिनिस्ट्री के निकाले हुए हैं, ये निकाले हुए, तो जब ये मिनिमम वेजेज हैं तो ये सभी कैटेगरी
that will be only applicable in government sectors, that limited to the government only. So if a person is doing diploma from Lal Pathology Laboratory for 6 months just for phleboing, so how will they pay more
सर
salary?
जब स्टेट वाइज मिनिमम वेजेस स्किल्ड, सेमी स्किल्ड और नॉन स्किल्ड जो एप्लीकेबल है तो उस पर थोड़ा लागू पैनलिस्ट में अनुरोध।
ओके लेट मी क्लैरिफाई, क्योंकि ये क्वेश्चन फंसता चला जाएगा, टाइम ज़्यादा ले रहा है। 2-3 चीज़ें इसके, सीधा ना मेरे पास आंसर है ना इन सब के पास होगा, इसका सीधा आंसर ये, दैट इज वेरी प्रोपोर्शनेट टू द क्वालिटी ऑफ एजुकेशन। नंबर 1, आप सिर्फ ये क्लेम करेंगे एक डिग्री करता है कोई एम्स से, पीजीआई चंडीगढ़ से, जिपमेर से, एक करता है कोई किसी दुकान से, तो एम्प्लॉयर कोई पूरा राइट है वो उसे रखे ना रखे, 10,000 में रखे, 5 में रखे, क्योंकि उसका कैलिबर इंटरव्यूअर कोई डिसाइड करना। नंबर 1, कोई भी ऐसे नहीं करेगा कि आप BSc MLTO डिग्री आपके पास भी है लेकिन आपको 25,000 से स्टार्ट करें। एक तो बात यहाँ दिक्कत आती है, क्योंकि एजुकेशनल स्टैंडर्ड उसको इंटरव्यूअर को पूरे राइट। बट अब बात आई कि मिनिमम वेजेज इन द प्राइवेट हेल्थ सेक्टर, उसके लिए एक तो पॉसिबिलिटी बहुत जल्दी ये है कि व्हेन वी विल हैव एक एडवोकेसी ग्रुप फ्रॉम द गवर्नमेंट। अभी तक क्या होती है, एसोसिएशन शोर मचाती है, मुझे इनको पे ठीक दो, गवर्नमेंट में, प्राइवेट में, जो प्राइवेट के लिए काम करते होंगे, जो भी कुछ है। और लिमिटेशंस ये है कि स्टैंडर्ड ऑफ एजुकेशन इतने पुअर है कि जो जिसने कभी कहीं पढ़ा नहीं, घर पे ही डिप्लोमा डिग्री किया है, उसके लिए तो 10,000 की मिले, 20 की मिले, 30 की मिले। अब मैं एक एग्जांपल देता हूँ आपको, इस एम्स की 2 साल नौकरी करके गई लड़की गुवाहाटी से, क्योंकि मैं एक ग्रुप को रिप्रेजेंट करता हूँ जिसमें 19 एम्स के बच्चे हैं और उनका मैं जानता हूँ। कल इनसे मैं ये रिक्वेस्ट कर रहा था कि उनकी दुनिया कुछ और है, एम्स तो वो भी है, चमचमाती बिल्डिंग है, वो यहाँ से 2 साल एक्सपीरियंस है इस एम्स की, उसने नौकरी कंफर्म नहीं थी, वो यहाँ किसी प्रोजेक्ट में रही होगी, एम्स गुवाहाटी में ज्वाइन कर लिया लैब अटेंडेंट की पोस्ट पे, क्योंकि वहाँ डिप्लोमा है, BSc MLT है। अब उसको कहा जा रहा है कि स्ट्रेचर, वो जैसे अटेंडेंट का जो जॉब टिपिकली होता है, अब उसको सब वही काम कहा जा रहा है डिपार्टमेंट। फीमेल लड़की भी है बेचारी, उसने एक दिन बड़ा इमोशनल लंबा चौड़ा मैसेज भेजा मेरे मोबाइल में, तो मैं एक कुछ देर के लिए इग्नोर किया, क्या मैं मेरे से पूछ के थोड़ा जॉब ज्वाइन की थी, ये तो हो गया कैजुअल रिएक्शन। बट इसको सोच के देखो कि डिग्रेडेशन कितना है इन चीज़ों में। तो ये सब की एक ही उम्मीद है, एसोसिएशन जादू नहीं कर सकती, या तो वो इंडिविजुअल कोर्ट चला जाए या उनकी कोई एसोसिएशन कोर्ट चली जाए। हम क्यों जाए, हमारे पास वो लोग आए, पहले तो उनका स्टेक दिखना चाहिए। कोर्ट पूछता तुम किसकी बात कर रहे हो, गवर्नमेंट तो ये है नहीं, प्राइवेट को तुम कैसे तय कर दोगे। ऐसा एक केस हुआ था नर्सिंग प्रोफेशन में, सुप्रीम कोर्ट में सीधा उनकी PIL हुई, सुप्रीम कोर्ट ने मिनिस्ट्री ऑफ हेल्थ को नोटिस इश्यू करके कहा कि ये तमाशा नहीं चलेगा, तुम एक प्रोफेशन है उसको इतना डिग्रेड नहीं कर सकते। तो उसके अंदर फिर डायरेक्शन हुई, उन्होंने खाना पूर्ति के लिए कुछ नॉर्म्स बनाए हैं। मिनिमम वेजेस आज की डेट में कोई प्राइवेट में भी करता है तो सब नहीं मानते उस बात को, क्योंकि प्राइवेट में मैं हूँ, यदि मेरे यहाँ PPF नहीं करता, कुछ नहीं करता, मैं किसी एक्ट में नहीं आता, मेरी एक प्राइवेट लैब चलती है, तब गवर्नमेंट देख ही नहीं पा सकती मुझे मेरे यहाँ कौन किस सैलरी पे काम करता है। तो ओके, इस पे तो हम इतना ही कर पाएंगे। बहुत जल्दी जब NCHP एक्ट काउंसिल कमीशन होगा तो ये ग्रीवेंस हमारा बीइंग एसोसिएशन, बीइंग एडवोकेसी ग्रुप थ्रू आर रिप्रेजेंटेटिव इन काउंसिल, हम इस बात को रेज करेंगे कि यह प्रोफेशन बहुत इंपॉर्टेंट है, आप इतना नीचे नहीं ला सकते। देयर शुड बी अ मिनिमम वेजेस एंड दिस इज अ स्किल्ड एरिया। ओके, सो इस क्वेश्चन को यहीं खत्म। जी मैम, थोड़ा सा क्विक, क्योंकि दूसरा भी कोई क्वेश्चन होगा, स्टूडेंट भी हैं, फैकल्टी। जी आप बोलिए।
About wages only, though I'm from PGI, we have a government sector, बहुत अच्छी salaries हमारी हैं। हमारे students जब immediately pass out होते हैं, research projects में सारे उनको hire करते हैं। Everybody wants कि हम आपका ही pass out student लेंगे, और जो minimum wages उनको मिलती है 18,000 सर, और वो उससे पूरे एक लैब टेक्नोलॉजिस्ट से भी ज़्यादा काम कराते हैं, मॉलिक्यूलर काम भी कराते हैं। उनके लिए कोई गाइडलाइंस नहीं है सर। स्टूडेंट्स एवरी टाइम दे कम टू अस और वो बोलते हैं कि मैम हम 18,000 में लगे, 20,000 में लगे, बट दे एक्सेप्ट द जॉब, क्योंकि चंडीगढ़ है, रिप्यूटेड डिपार्टमेंट है, रिप्यूटेड इंस्टीट्यूट है। सर उनके लिए हमारी काउंसिल कुछ कर सकती है?
वही मैंने कहा था, दोबारा से वही रिपीट हो रहा है क्वेश्चन। मैं कहता हूँ उसकी एक ही उम्मीद है, या तो इंडिविजुअल जो उनका इंडिविजुअल का ग्रुप किसी लिटिगेशन में जाए, नंबर 1। नंबर 2 है कि वेट फॉर सम टाइम कि NCHP आए। कोर्स केस में, कोर्ट केस में अननेसेसरी कोई जा नहीं सकता जब तक अनटिल यू डोंट हैव एनी।
एक सेकंड लूंगा कप्तान जी। एसोसिएशन सिर्फ उसमें एक मदद कर सकती है, और वो मदद सिर्फ एक ये है कि ये प्रैक्टिकल हम कर चुके हैं कप्तान जी, आपको बता रहे हैं। और ये रेडिएशन थेरेपी में हमने किया था। हम लोग पूरे भारत में सिर्फ 4,000 हैं, और आप शायद 4 लाख से ज़्यादा होंगे। तो उसमें ये चीज़ कर सकते हो आप, और आपकी एसोसिएशन और ये ICML के हर इंस्टीट्यूट को सीट कम करने के लिए बोले कि भाई क्यों जितना प्रोडक्शन कर रहे हैं उसको क्या नाम है आप लगा तो नहीं पा रहे। वो एम्प्लॉयर के जो ट्रेनिंग कराता है उसकी जिम्मेवारी होती है कि उसको जॉब मिले ना मिले। कम नहीं है, ज़्यादा आपके यहाँ। आप क्या, मेरे को जो पता चल रहा है, आपके 2-3 बार से जब मैं कॉन्फ्रेंस अटेंड कर रहा हूँ, आप लोगों को बहुत ज़्यादा सीटें हैं।
मिस्टर अजीत, प्लीज मिस्टर अजीत, जो आप बात बोल रहे हो कम करना, गवर्नमेंट वो नहीं कर सकते हैं। कम करने की तो बात ही कम करो। हमारे पास अभी इतनी पोस्टें खाली पड़ी हुई हैं इंडिया में, लैक्स में है।
हेलो,
पोस्टों की बात है
नहीं सर, सीट्स की बात नहीं,
कम करेंगे तो
बिल्कुल नहीं
कमी पूरी नहीं होगी। ये बेसिकली हमें एक्सप्लॉयटेशन को रोकना है।
हाँ जी, हाँ जी।
एक्सप्लॉयटेशन हो रहा है, जो एक्सप्लॉयटेशन है अभी क्या है, जैसे सर ने बताया अभी कि नॉन स्किल्ड का हो गया है, अभी स्किल्ड का, सेमी स्किल्ड का होना है। अभी भी इंडस्ट्री में भी, मैंने 3 साल इंडस्ट्री में भी काम किया एज डायरेक्टर, वहाँ पे भी क्या है कि 14,000 रुपीज़ MSc के माइक्रोबायोलॉजिस्ट, बायोटेक्नोलॉजिस्ट सिर्फ 14,000 रुपये देते हैं। उनको क्यों? क्योंकि गवर्नमेंट ने 14,000 रुपया नॉन स्किल्ड के लिए
चलिए इस क्वेश्चन को आप यहीं पे करते हैं। सॉरी, आप राजेश जी बताइए, कल भी आप रूठ गए थे मुझसे।
हम ICMLS के माध्यम से, NCHP एक्ट के माध्यम से मॉडल कैरिकुलम पूरे स्टेटों में कैसे लागू करा सकते हैं, इसके लिए आपका क्या प्लान है? दूसरा, जो डॉक्टर्स इसमें अपने घुसे हुए हैं टीचिंग में, इनको बाहर निकालने के लिए ICMLS का क्या प्लान है? 2 चीज भाई।
लॉडेड क्वेश्चन, डायरेक्ट
चलो
बताइए, थोड़ा सा क्विक आंसर
इसमें। देखो मैं ब्रीफ में
एक मिनट, अभी राजस्थान में रिक्रूटमेंट रूल्स में DMLT लिखा हुआ है अभी तक भी, है ना, BSc हो रही है, और हमारा जो NCHP एक्ट में वो PG मांग रहे हैं, MSc। तो सरकार जब MSc करा रही नहीं है तो हम कहाँ से PG वाले लेके आएंगे? और जो PG वाले आएंगे वो तो किसी दुकान से जो लेके आते हैं डिग्रियां, वो लोग घुस जाएंगे, तो हम उसमें क्या कर सकते हैं? ये 3 क्वेश्चन है।
3 क्वेश्चन में तो इनको पौने घंटा चाहिएगा।
वो तो चाहिए सर,
पहले
एक ही में
15 मिनट में भूमिका बनाएंगे, वो फिर
सब कुछ एक ही में हो जाएगा कवर।
तो
देखो, नेशनल कमीशन फॉर एलाइड हेल्थ प्रोफेशनल्स जो बना है, वो अभी कमीशन बना है, अभी काउंसिल जो है स्टेट्स बना रही हैं, रूल्स रेगुलेशंस SOPs अभी कुछ भी नहीं बना है। हमें उसका इंतजार इसके लिए करना पड़ेगा, दैट्स इम्पॉर्टेंट। वही है, वो सब कुछ करेगा जी। देखो जैसे पहले शुरू में इन्होंने कुछ स्टेट्स ने अपनी काउंसिल्स बनाई थी, उनमें सारे मेडिकोज रखे थे उन्होंने, ठीक है। इन्होंने अपने कप्तान सिंह जी ने एक लेटर लिखा मिनिस्ट्री को, उस लेटर के बाद जो काफ़ी वो लेटर्स वो कमेटीज़ जो थी बनाई हुई वो वापस हुई और वो कंस्ट्रक्ट की गई। हिमाचल की पहले बन गई थी कमेटी मेडिकोज की, उसके बाद वहाँ पे अब जो है अपने रिस्पेक्टिव अलाइड हेल्थ साइंसेज के लोगों की काउंसिल्स बन रही हैं।
कहाँ से आएंगे जब वहाँ सरकार करा ही नहीं रही है, पीजी करा ही नहीं रही, एमएससी नहीं करा रही है हमारे लेबोरेटरी में, तो आदमी कहाँ से आएंगे?
बात सुनो, जब नेशनल कमीशन लागू होगा, जब काउंसिल्स बनेंगी, काउंसिल्स में ये सब कुछ होगा कि ये कराओ।
सर जो होगा, अभी जो मेंबर बन रहे हैं उनको लिए एमएससी चाहिए, हम कहाँ से लाएंगे? और जो आएंगे वो तो खुद ही फर्जी है, वो जो एमएससी वाले मैक्सिमम फर्जी है, वो क्या जानेंगे उसमें?
Rajesh ji, I think you are also heading one of the leading association of MLT in Rajasthan. Is a particular matter of Rajasthan, sir?
नहीं सब जगह ही है, राजस्थान में सब जगह, ऐसा कहीं नहीं है सरकार वहाँ पे।
चलिए मैं करता हूँ रेस्पॉन्ड राजेश जी, क्योंकि मैं आई वाज एक्सपेक्टिंग ए क्वेश्चन फ्रॉम स्टूडेंट बहुत थे, पता नहीं नॉर्थ ईस्ट से भी, अरुणाचल से भी स्टूडेंट है, गुवाहाटी से स्टूडेंट है। सर या एक सेकंड मैम, एक सेकंड सर, पीछे कुछ एक सेकंड जी 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 जी।
I am sorry to interrupt here. So similar condition everywhere. संसार भर ऐसा ही चलता है, हिंदी में बोलना पड़ेगा क्योंकि जो सर ने अभी क्वेश्चन उठाया है और कौन बोलेगा क्या करेगा, इसके लिए यहाँ पे क्लियर है, या तो स्टूडेंट को बोलना पड़ेगा या तो रिटायर्ड वालों को बोलना पड़ेगा। बीच में जो जॉब के लिए भाग रहे हैं वो नहीं बोल सकते भाई साहब, कहीं भी नहीं बोल सकते, क्योंकि उनको 10,000 में जॉब दी रहा है, 5 में लेने के लिए जाएगा क्योंकि खाना है उसको,
उल्टा हमें डांट के भेज देगी।
इसलिए रिटायर्ड फेलो मस्ट हैव दिस रिस्पॉन्सिबिलिटी। मैंने बोला रिसर्च इज वेरी इंपॉर्टेंट इन लैबोरेटरी मेडिसिन बिकॉज वी आर नॉट गेटिंग मच मनी इन रिसर्च, है कि नहीं? इसलिए दूसरी एक लास्ट बात बोलता हूँ, काउंसिल इज वेरी इंपॉर्टेंट बिकॉज council accredited only the faculties those are licensed by the professional, I mean council. जैसे नेपाल में एनाटॉमी पढ़ाने के लिए कोई भी MBBS और फिजियोथेरेपिस्ट नहीं आएगा BMLT में, नॉट अलाउड, नो नर्सिंग, इवन MD DM करके भी ही इज नॉट एलिजिबल टू टीच एनाटॉमी और न्यूरोसाइंस और व्हाट एवर सब्जेक्ट। इसलिए सेम काउंसिल से लैबोरेटरी मेडिसिन का सर्टिफिकेशन होना चाहिए, एवरीथिंग, आई मीन बायोकेमिस्ट्री, माइक्रोबायोलॉजी पढ़ाने के लिए। ओनली पैथोलॉजिस्ट आर टुगेदर विथ अस।
Sir, Mahendra sir, I just want to interrupt in this.
वो पढ़ा सकते हैं लेकिन
excuse me, Dr.
they are
Mahendra.
not,
Dr.
they are
Mahendra.
also suffering. उनका
I just want to add up on this. अभी हिंदुस्तान में NCH
नहीं, मेरा जॉब है मॉडरेट करने का, आप मेरी बगैर परमिशन के नहीं आप बोलिए मैम, अब ऐसे एक साथ नहीं जी।
इम्पोर्टेंट मेरा जो सजेशन है, जो मैडम ने बहुत ही वैलिड वो किया कि पिछले अराउंड 2015-16 तक लैब टेक्नीशियंस को 32,000 33,000 मिलता था, एंड ICMR स्लैश डाउन टू 16,000 18,000। सो ये मेरा कहना यहाँ पर ये है कि हम इस फोरम से एक रिप्रेजेंटेशन ICMR को दे और गवर्नमेंट ऑफ इंडिया को दे कि जो प्रोजेक्ट्स में जो हायर करते हैं दैट शुड बी लाइक, अभी कॉन्ट्रैक्ट में उन्होंने 40,000 कर दिया लेकिन ICMR प्रोजेक्ट्स में जो है वो
ये नोट डाउन कर लिया हमने पॉइंट।
ये एक बहुत इंपॉर्टेंट जो वैलिड एक्शन जो है होना चाहिए।
लेकिन आपको एक अभी ये इस क्वेश्चन पे आगे नहीं बढ़ पाएंगे, सैलरी से बाहर नहीं आए हम, आई एम अगेन
नहीं ये मैडम का जो था ना वो बिल्कुल सही था।
मैडम मैं समझ गया ना, एक ही क्वेश्चन को हम रिपीट करते रहेंगे। सर ने जो डॉक्टर भट्ट ने जो रिप्लाई किया था, यदि आप लेजिस्लेटिव ग्राउंड पे चीजों को समझते हैं तो तरीका क्या है, अनटिल अनलेस कोई एडवोकेसी रेगुलेटरी बॉडी, पहले एक नंबर 1 पॉसिबिलिटीज रेगुलेटर हमारे लिए एडवोकेसी करेगा, ये उम्मीद है, बट नहीं करते कभी कभी, तब हमारे लिए कुछ जो रिटायर्ड बहुत सारे लोग हैं, स्टूडेंट्स बहुत हैं, यदि उन्हें अपने फ्यूचर की चिंता है, मैं कोर्ट में जाता हूं कि हमारे स्टूडेंट के साथ ये हो रहा है। जैसे मैं एक एग्जांपल से बताऊं, हमने 2011 में पब्लिक इंटरेस्ट लिटिगेशन फाइल की उत्तराखंड हाई कोर्ट में, कहा कि देश भर में सब स्टैंडर्ड इंस्टीट्यूट चल रहे हैं, बंद होने चाहिए। उन्होंने कहा कोई देश में कानून है ऐसा जिसके बेस पे तुम यहाँ आए? नोटिस तो हो गया, बट हमसे ही पूछा पहले उनको ढूंढ के बताओ वो कौन कौन है। मैंने 27 पार्टी बना दी, उसमें बहुत कम से पैसे थे, वो उन्होंने 27 ने बड़े बड़े वकील खड़े कर दिए नैनीताल में और हमें चुप करा दिया, क्योंकि वो हमारा ही वकील चुप हो गया वहाँ पे सुप्रीम कोर्ट में। 1 साल के बाद वो मैटर डिस्पोज ऑफ हो गया। अब दूसरी पॉसिबिलिटी क्या है, या स्टूडेंट आए या रिटायर्ड आए, वो भी नहीं आते हैं, तब हम क्या कर सकते हैं? नंबर 1 हम चिट्ठी लिख सकते हैं नंबर 2, जिस दिन हमारे पास प्राइवेट वर्कफोर्स का अच्छा सा साइज हो जाएगा, आई एम रेडी टू फाइल द केस इन हाई कोर्ट और सुप्रीम कोर्ट एज ए PIL। बट ये जादू से नहीं होगा, ये हवा में हम बातें करें एक दूसरे से, कुछ नहीं होगा इससे। पे स्केल किसी का बढ़ाना तो सरकार में ही बहुत मुश्किल है, यहाँ तो प्राइवेट की बात हो रही है, मेरी मर्जी मेरी लैब में। लेकिन जिस दिन काउंसिल होगी, ये सही बात है कि जब आपका एजुकेशनल प्रोग्राम इज रेगुलेटेड है, जब आपका ट्रेनिंग सेंटर ही रेगुलेटेड है, तो एडवोकेसी बहुत स्ट्रांग होगी हमारी तरफ से कि आप ऐसे कैसे कर सकते हैं एक प्रोफेशन के साथ। और उस काउंसिल को तो हम भी देखेंगे ना फिर एज ए प्रोफेशनल बॉडी, हमारा भी एक स्टेक होगा, वी विल हैव द एडवोकेसी आल्सो। सो यही एक इसका आंसर था। इस पे हम स्टूडेंट कोई यदि इसका मैडम कुछ कह रही थी वो सविता मैम, यस आपने तो कर दिया था। उस पर मैं किसी दिन वर्कशॉप करेंगे एक अलग से, एम्स में आके करूंगा और आपके सारे लीडर्स के साथ एक दिन बैठ के, मेरे को भी मजा आएगा इस बात। बहुत सारे कारण है, मैं उन पे जाना नहीं चाहता क्योंकि टाइम नहीं परमिट कर रहा, बहुत सारे रीजन होते हैं आज की डेट में। उस आप फिर गवर्नमेंट में आ गए, वो क्वेश्चन शुरू हुआ था प्राइवेट हेल्थ सेक्टर से। नहीं आप बीच में आए हो, क्वेश्चन ओरिजिनेट हुआ था कि प्राइवेट हेल्थ सेक्टर में 10,000 में लोग काम करते हैं। ओके प्लीज स्टूडेंट,
सरकारी में भी ऐसा
है। स्टूडेंट यस प्लीज, यू आर ए स्टूडेंट
सर।
ओके जी
एज यू सेड कि प्राइवेट में है सर, हमारे यहाँ पे NHM पे हायर हो रहा है, 10-10 हजार में हायर हो रहा है।
जी
गवर्नमेंट जो परमानेंट एम्प्लॉयज है वो DST पे दिखते नहीं है। इवन इन द दिवाली वेकेशंस वी आर वर्किंग देयर, बट हमारी कोई ना काउंटिंग हो रही है ना हमसे कोई पूछ रहा है।
आप एक बार इंट्रोडक्शन दे, आप किस स्टेट से, कहां से?
सौरभ बाजपेयी फ्रॉम यूपी।
हाँ। और किस, एक सेकंड, कहां से आपने डिप्लोमा डिग्री किया, क्या किया?
फ्रॉम एरा यूनिवर्सिटी एंड आई एम अ PG स्कॉलर इन MLT ओनली फ्रॉम द गढ़वाल यूनिवर्सिटी।
तो 10,000 में आपने ज्वाइन करे क्या हुआ है?
आई एम नॉट सेइंग मैंने ज्वाइन किया है, आई एम आस्किंग।
ओके, यू हैव नॉट ज्वाइन। किसने ज्वाइन किया? क्वेश्चन किसका? आपका ही है ना?
हाँ, ये मेरा ही क्वेश्चन है क्योंकि मेरी ही DST।
तो व्हाई दे आर नॉट फाइलिंग ए पब्लिक इंटरेस्ट लिटिगेशन?
लेट मी कंप्लीट। आई वांट टू आस्क वन थिंग दैट समवन हैज सेड फ्रॉम हियर कि प्रेस्टिजियस इंस्टीट्यूट से हो तो मिल जाती है। क्या सारे MLT करा रहे हैं?
नहीं, सवाल ये नहीं है। प्रेस्टिजियस इंस्टीट्यूट के बारे में एक परसेप्शन ये है कि कम से कम कुछ तो मिनिमम स्टैंडर्ड मेंटेन, अदरवाइज कोई ऐसा लेवल नहीं है कि प्रेस्टिजियस।
आई वांट टू से दैट हमारे यहाँ पे LA को LT कर दिया गया, क्या वो प्रेस्टिजियस इंस्टीट्यूट से थे या वो एक स्टैंडर्ड में थे?
उसका एक सॉल्यूशन है डियर, कि हम जब कोई रास्ता नजर ना आए तो उसके लिए एक ही उम्मीद बचती है कि देश में कोर्ट है। और कोई आप देखिए, ऐसे तो मैं भी हाथ हिला के कह दूंगा मुझे क्या फर्क पड़ता है, लेकिन हम इस चीज का पॉजिटिव सॉल्यूशन ये है कि आप एक यू मेक ए विजिबल ग्रुप ऑफ स्टूडेंट्स या जो एम्प्लॉय जो वो थोड़े दिन के लिए रिस्क में जाएं। आप ये ना सोचें कि मैं तो 10,000 में करूंगा, मेरी लड़ाई कोई और आके लड़ेगा, किसी को चिंता नहीं, सरकारी वाले भी अपनी चिंता करेंगे, तुम भी अपनी चिंता करो, थोड़ा सा स्टार्ट करो कुछ करना। वहां से यदि आप 10,000 में नौकरी भी ज्वाइन करोगे, फिर आप किसी पड़ोसी से जाकर पूछोगे मुझे 10,000 में रखा है, इसको मार क्या, तो ऐसे कोई नहीं करने वाला।
नो, माय क्वेश्चन इज नॉट दैट कि 10,000 में रखा है या ये है। मेरा क्वेश्चन ये है, सिंपल सा क्वेश्चन है कि व्हाट वी कैन डू द फर्दर कि हमें हमारी जैसे LT की वैकेंसी खत्म कर दी, LA को वो वैकेंसी दे दी।
कोर्ट इज द ओनली ऑप्शन। कोर्ट इज द ओनली ऑप्शन व्हेन देयर इज नो जस्टिस फॉर यू, कोर्ट इज द ओनली ऑप्शन। हमने प्रूव किया उस चीज को।
सर एक अभी देखो, शायद बुरी लगेगी मेरी बात, लगती है सबको। पता है क्या, हम ना अपनी कमियां देखते ही नहीं है। अगर हम अपनी कमियां देखना शुरू कर देना तो शायद आधे प्रॉब्लम तो वैसे ही सॉल्व हो जाएंगे। ये इंडिया है, यहाँ पे बहुत सारे प्रॉब्लम्स हैं, तो सॉल्यूशंस के लिए बस हम गवर्नमेंट को या कुछ इंस्टीट्यूट्स को या कुछ एसोसिएशंस को बोलते यही सब कर दें। हम कब करेंगे अपने लिए? मैं जब पढ़ता था ना तो मेरे को 2,500 मिलते थे, करता था मैं काम, पार्ट टाइम करता था। उसके बाद जब मैं मेरे बैक ऑफ माइंड में आता था अबे 5,000 की भी नौकरी मिलेगी नहीं मिलेगी मुझे, तो फिर मैं पास हुआ, 5,000 की नौकरी मिल गई, पर उससे मैं सेटिस्फाई नहीं हुआ। मैंने विद इन 1 मंथ छोड़ी, MSc ज्वाइन करी, फिर भी मुझे नौकरी मिली थी, पर मैं फिर भी मैं हार नहीं मानी, मैं बस एग्जाम देता था, पढ़ता था, करता रहा, तो हुआ मेरा। मैं अगर ये सोच के बैठा था यार ये जॉब ही नहीं निकालते, मैं आज एम्स में हूँ, 2 बार एम्स में जॉब ले चुका हूँ, दिल्ली गवर्नमेंट में भी हो चुका हूँ। ऐसा नहीं है, आप एफर्ट्स तो करो। सर जैसे बोले, आप जैसे आप सबके क्वेश्चंस हैं, आपको सॉल्यूशन नहीं मिलता ना कि गवर्नमेंट नहीं दे रही, बोले कोर्ट है, आप जाओ ना, मिलो ना, आप में से यूट्यूब सब चला लोगे, पर लोगों को जोड़ो, सबके पास सेम प्रॉब्लम्स होगी आपके आसपास, उनको जोड़ो, बोलो यार कोर्ट चलो यार, क्या दिक्कत है? क्योंकि इंडिया में ना आपके लिए कोई सोचने वाला नहीं है जब तक आप अपने लिए नहीं सोच सकते। तो ये भूल जाओ, बहुत ईजी है। अरे मम्मी पापा कुछ करा नहीं रहे, मेरा टीचर कुछ करता नहीं, कप्तान से कुछ कर नहीं रहे, अरे क्या कर लेंगे भाई, हम अपने लिए भी तो कर रहे पहले, वो कर रहे हैं, उसके बाद जितना एफर्ट्स हो सकता है आप लोगों के लिए कर रहे हैं। और रही इसकी बात, ये ICMR और ये आपका प्रोजेक्ट और ये सब, आप कभी ये सोचो एक PhD और MSc वाला जो जिसने अच्छे कॉलेज से नहीं हो पाया होगा, वो भी उसी की गलती है क्योंकि उसका अच्छे कॉलेज में नहीं हुई, क्योंकि उसने नहीं पढ़ाया। जब मेरे साथ वाले IAS बैठे हुए ना, तो मैं ये सोचूं मैंने नहीं पढ़ाई करी थी, उन्होंने दी इसलिए थे वहाँ। और अगर आपको कोई चीज़ ICMR में सैलरी अच्छी नहीं, मैडम मैं जब स्टार्ट किया ना, मेरे को हर सब बोलते थे कौन एक्सपीरियंस का है, मैंने बोला, मेरे भाई ने भी, मैंने भी, उसने जॉब छोड़ के फ्री में उसके फीड के लिए, और मैंने भी अपने लिए, हम सिर्फ एक्सपीरियंस के लिए ढूंढते थे कि हमें जॉब मिले, कि हम एक्सपीरियंस है यार, 6 महीने 1 साल कर लो और पढ़ाई करो, लगे रहो। कैसे नहीं होगा, कहीं ना कहीं तो जरूर होगा, अगर आप में एबिलिटी है तो होगा। आप किसी और को पॉइंट आउट करते रहोगे पर अपने को नहीं करोगे, फैक्ट ये है।
एंड इंद्रेश के बारे में एक और याद आ गई मुझे स्टोरी, ये ही वाज द फर्स्ट पर्सन फ्रॉम एम्स, मुझे बाद में पता चला ये बात, हमने 2014 में अलाइड हेल्थ साइंसेज की ज्वाइंट फोरम की कॉन्फ्रेंस की थी, ये तो ICMLS तो 2016 में ही तो बना, 14 में ज्वाइंट फोरम की कॉन्फ्रेंस थी HP कॉन, पहली बार इंडिया की कोई अलाइड हेल्थ साइंसेज की ज्वाइंट कॉन्फ्रेंस हुई, सेक्रेटरी हेल्थ। ये जब कॉन्ट्रैक्ट की, शायद आप दैट टाइम यू आर इन कॉन्ट्रैक्ट जॉब में मौलाना आजाद या कहीं पे थे, तो एम्स में थे, तो पार्टिसिपेंट रहे हैं। आप तो ये सोच सकते हो यार कॉन्ट्रैक्ट की नौकरी में रजिस्टर करूंगा, हमने फीस भी ली होगी इनसे, रजिस्टर किया था ना, तो ऐसे जब चेंज होता है, जैसे ट्रांसफॉर्म होती है चीजें, अच्छी लगती हैं। आज वो एक ऑर्गेनाइजिंग सेक्रेटरी इस कॉन्फ्रेंस का, तो देखिए ना आप कब इसका सही कह रही है, आप रिलेट करें इस चीजों को कि कहीं ना कहीं पैसन रहा होगा दिमाग में कि 2014 में जब वो जॉब रेगुलर नहीं है, तब वो एक साइंटिफिक कॉन्फ्रेंस को अटेंड कर रहे हैं जानने के लिए कुछ हो रहा है, कहाँ पर हो रहा है, तो ये रास्ता ऐसे ही तय होता है। तो खैर एक और स्टूडेंट से, अच्छा क्वेश्चन था डियर, फिर भी हम ठीक से आपको सेटिस्फाइड नहीं कर पाए होंगे, आप खुश भी नहीं होंगे, पर फिर भी स्टूडेंट से फिर कोई क्वेश्चन, एक लास्ट क्वेश्चन हम लेते हैं, फिर ये सेशन जो क्लोज होगा। लास्ट क्वेश्चन
इसमें
ओके जी आपने पहले हाथ खड़ा किया था, आप एक बार इंट्रोडक्शन दे दीजिए अपना। ऐसे ही होना चाहिए इंटरेक्शन, आपसे कोई हमें शिकायत नहीं है कि आप क्वेश्चन क्यों पूछ। जी
सर, आई एम जैनब फ्रॉम डिप्सरूट टेलीफार्माक्यूटिकल साइंस एंड रिसर्च यूनिवर्सिटी। सर मेरा क्वेश्चन ये है कि कल एक पॉइंट निकला था कि डिप्लोमा ग्रेजुएट्स जो हैं, मतलब जो डिप्लोमा क्वालिफाइड हैं, वो भी लैब में टेस्ट कर रहे हैं, और जैसे नॉर्मल बेसिक टेस्ट जब वो डिप्लोमा वाले कर रहे हैं और उनको जैसे हाई लेवल के टेस्ट है तो उनको PG क्वालिफाइड चाहिए, तो हम बैचलर्स वालों का क्या होगा फिर?
देखिए इसमें इसका आंसर आई थिंक हरीश जी आप रेस्पॉन्ड करना चाहोगे?
आप कह रहे हैं कि BSc वालों का क्या होगा?
सर जैसे मैंने 2-3 लैब्स में ऐसे पूछा था जैसे जॉब के लिए, तो या तो उनको ये चाहिए कि वो आप सिर्फ बैठ के सैंपल कलेक्शन करो, तो सैंपल कलेक्शन करना था तो हम डिप्लोमा ही कर लेते सिंपल, और जो अगर टेस्ट परफॉर्म करना है तो उनको सिर्फ चाहिए कि आप PG क्वालिफाइड हो।
नहीं, ऐसा नहीं है कि आप उनको BSc वाले नहीं चाहिए।
सैलरी भी इतनी है नहीं,
सैलरी का तो देखो अभी इन्होंने काफी लोगों ने सैलरी पे चर्चा की और बताया
मेन चीज तो वही है इतना पढ़ने के बाद।
देखिए वो फिर आपका
एवरीथिंग रिवॉल्व्स अराउंड मनी, तो इतना इन्वेस्ट कर रहे हैं पेरेंट्स, तो उनको रिटर्न में सैलरी तो चाहिए होगी। अगर हम 90,000 पे कर रहे हैं तो हम 10,000 में कैसे सेटल होंगे?
सरकारी के लिए कंपटीशन करो और सरकारी में सिलेक्शन करो तो वहाँ आपको 60,000 सीधे मिल जाएगी। प्राइवेट में एक अपना भी एक थोड़ा सा स्टेटस रखो कि अगर कोई आपको 10,000 के लिए रख रहा है तो आप मत जाओ। आप क्यों जाते हो 10,000 के लिए? तभी तो वो 10,000 वाला रख लेता है।
सर कुछ नहीं से तो 10,000 पैसा लगता है।
आप एक डॉक्टर को 10,000 में रख सकते हो क्या कोई? क्योंकि उसको वो नहीं जाता, उसको अपना स्टेटस थोड़ा मेंटेन आपको खुद भी करना पड़ेगा। अगर आपको कोई BSc करने के बाद MSc करने के बाद कह रहा है कि मैं 10,000 सैलरी में आपको रखूंगा, तो आप भी थोड़ा सा उसको एजिटेट होए कि भाई क्यों मैं 10,000 में जाऊं, मैंने डिग्री की है, मैं दूसरा ढूंढूंगा कोई जहाँ पे मेरे को 50,000 मिलेंगे।
बात 10,000 वाली नहीं है ना।
और जो आपका क्वेश्चन था कि BSc वाले को नहीं लेते, तो वो ऐसा है नहीं, डिप्लोमा वालों को भी प्राइवेट में लेते हैं, BSc वालों को भी लेते हैं और MSc वालों को भी लेते हैं। फर्क सिर्फ इतना है कि जिसकी जैसी रिक्वायरमेंट होती है क्लिनिक की, वो उस तरीके से आपको काम के लिए रखेगा। आप ये नहीं कह सकते उनसे कि मैं BSc हूँ तो मैं सैंपल कलेक्शन नहीं करूंगी, क्योंकि वहाँ पे उनको मल्टी टास्क वाला आदमी चाहिए जो और भी 10 काम करे, कलेक्शन पे भी बैठ जाए,
जो सैंपल रिसीव भी कर ले, जो टेस्ट भी लगा ले, इस तरह का आदमी चाहिए। और ऐसा कुछ नहीं है कि सिर्फ उनको MSc ही चाहिए, उनको BSc भी चाहिए, डिप्लोमा भी चाहिए, सारे लोग
सर
चाहिए।
मेरा एक क्वेश्चन ये भी है कि जैसे बाकी कोर्सेज में ही होता है, आपने MBBS किया है तो आपकी 30 to 50,000 सैलरी होती ही है। और
तो आप
जैसे
नीट
आपने
नहीं,
मास्टर
प्राइवेट में
किया
कहीं
है,
मेंशन नहीं है,
लेकिन-
प्राइवेट में कहीं मेंशन नहीं है कि 32-35,000 की होगी।
सर हमें तो यही बताया जाता है जब हम कोर्स में
गलत सोर्स से इन्फॉर्मेशन ले रहे हो ना।
नहीं, ऐसा उनके लिए भी नहीं है, चूंकि
चलिए ठीक है, नहीं वो सही है। चलिए ये क्वेश्चन इसका सीधा सा आंसर नहीं होगा जो आप ढूंढ रहे हैं कि जी कितनी सैलरी होगी, उसके लिए तो मैंने सर ने जो मैं कमिंग बैक टू सेम आंसर जो भट्ट साहब ने बताया था कि इट्स वेरी प्रोपोर्शनेट टू योर क्वालिटी ऑफ योर एजुकेशन। हम सुधार नहीं पा रहे हैं एकेडमिक इंस्टीट्यूशंस के लिए। मेरे पास बहुत सारे क्वेश्चन है आपकी तरफ से, बट टाइम नहीं अलाउ कर रहा। स्टूडेंट बन के भी मैं क्वेश्चन करता कि कितनी तरह के प्रोग्राम्स आप रोक पा रहे हैं। वहां पे बीवोक आ गया तो बीवोक ज्वाइन कर लिया। हम तो पिछले 7 साल से स्ट्रगल कर रहे हैं, BMLS कोर्स है उसके लिए है, लेकिन आप नहीं चेंज कर पाएंगे क्योंकि हम नहीं चेंज कर पा रहे एकेडमिक इंस्टीट्यूशंस को, कि या फैकल्टी बैठे वो चेंज नहीं कर पा रहे। तो ये बहुत मुश्किल होता है। ऐसे में पूरे देश में सिस्टम को एकदम स्ट्रीमलाइन करना, इट विल टेक टाइम, चीजें बदलेंगी, सही होगा, बट वी हैव स्टार्टेड आवर स्ट्रगल फॉर दैट आल्सो।
अभी पैनलिस्ट के सामने सभी स्टूडेंट्स बैठे हुए हैं। एम्स में काफी वर्कआउट हुआ है। अभी विद इन 6 मंथ आपके पास करीब 200 पोस्ट वेकेंट नोटिफिकेशन आने वाला है, जिसमें 70 पोस्ट मेडिकल लेबोरेटरी टेक्नोलॉजी एम्स में आएंगी। जूनियर मेडिकल लेबोरेटरी टेक्नोलॉजी की 40 पोस्ट आ रही हैं और ये विद इन 2-3 मंथ एडवर्टाइज हो जाएगा।
तैयारी शुरू कर दो, विजय जी ने अनाउंसमेंट कर दी।
सर आई जस्ट वांट टू ऐड इन दिस,
एक सेकंड, लास्ट
टोटल नंबर ऑफ पोस्ट 200 के आसपास होगी, तो CRE एग्जाम के तहत आएगी। तो आप लोग प्रिपेयर हो जाएं और अच्छा मौका है एम्स से जुड़ने का
बड़ी पारी के लिए। तो थैंक यू, क्योंकि थोड़ी फिर अगेन लिमिटेशन क्या है। एक सेकंड सर, एक सेकंड मुझे कंप्लीट। चीफ गेस्ट को मैंने 2:30 की बजाय 2:45 पे बोला है, मेंबर ऑफ पार्लियामेंट है क्लोजिंग सेशन में। और एक और रिक्वेस्ट है, थोड़ा सा डेकोरम स्टूडेंट भी रखें। हम किसी को भी गेस्ट, वो एक इंप्रेशन लेके जाएगा, वो मुझे भी कभी फोन करेंगे कोई भी, and he is the person who is leading our case in Supreme Court also, other than member of parliament. तो थोड़ा सा ऐसा ना हो फर्स्ट टाइम किसी का इंटरेक्शन हुआ, वो हमारी उसको लड़ाई को सुप्रीम कोर्ट तक लड़े और वो यहाँ से ये इंप्रेशन लेके जाए यार बेकार में शोर मचा रहे हैं, कुछ नहीं है, ये जहाँ है ठीक है। तो ऐसा ना करें। जो भी आप एक तो टाइमिंग का ख्याल रखें, एक गैदरिंग के लिए क्लोजिंग सेरेमनी है, तो बहुत अच्छी अपॉर्चुनिटी है। एम्स के डिग्नेटरीज का अजीत जी बताएंगे कोई आ रहे हैं नहीं आ रहे हैं, लेकिन कम से कम उनका कंफर्म है। और हम टाइम से लंच करके वापस आ जाएं तो अच्छा, इसमें बहुत मतलब अच्छा लगेगा। मैं जी सर, फाइनल कमेंट।
सर आपने नाम ले ही लिया, फिर बोलना पड़ेगा थोड़ा
जी
बहुत। ये भी नॉलेज शेयरिंग की बात है, एक्सपीरियंस शेयरिंग। नेपाल में मेडिकल लैब टेक्नोलॉजिस्ट इज फुली ऑथराइज्ड फॉर द सिग्नेचर इन एवरी टेस्ट एक्सेप्ट हिस्टोपैथोलॉजी एंड साइटोलॉजी कवर्ड बाय पैथोलॉजिस्ट. Some part of hematology is covered by the pathologist. So, from even though biochemist from MD background or biochemist from the MLT background, both are equivalent for the reporting system. This is internationally valid. It is possible only after establishment of council. If you must have the license. License is very important.
We are in process, sir. That is very soon we'll have license. Everybody will be licensed.
Yeah, in the council everything will be covered. And one more thing I want to add. So health ministry is authorized body to register hospitals. कोई भी private हो या
they have already a mechanism.
100 bedded hospital का criteria होता है, उसमें laboratory में staff कितना होना चाहिए, किस
It is already there, sir.
हाँ,
Everything is there.
सबको बोलना पड़ेगा, वहीं पे कवर हो जाएगा सैलरी का।
लास्ट फाइनल कमेंट, गोपाल जी इज देयर, फाइनल कमेंट इनका इनसाइट
खड़ा होके कुछ कहना चाहूँगा।
जी,
मैं 21 ईयर्स से, मेरी उम्र जब 21 साल थी तब से काम कर रहा हूँ इस फील्ड में, और प्राइवेट में ही काम किया है। ब्लड बैंक में रहा हूँ बहुत वर्षों तक। और जो कुछ बच्चों का कुछ एक सवाल ये था कि मैंने BSc कर ली, MSc कर ली और मुझे कुछ नहीं मिल रहा है प्राइवेट में, सरकारी जो भी है, सरकारी में जो कुछ मिलता है, लेकिन उस टाइम से लेकर आज तक 2024 में यानी 92 से मैं काम कर रहा हूँ और इसी कोर्स के भरोसे, और मैंने फॉरेन का एग्ज़ाम क्लियर किया, मैंने दुबई में काम किया है 10 साल तक। ऐसा नहीं है कि मेरी क्वालिफिकेशन बहुत ज़्यादा है, बीएससी एमएलटी की है, एमएससी एमएलटी की है, लेकिन हमेशा ट्राई ये करिए कि आप अपनी क्वालिफिकेशन को बढ़ाते रहिए। अच्छे इंस्टीट्यूट की जो सर ने बात कही है, अच्छे इंस्टीट्यूट में मौका सबको नहीं मिलता है, हमें भी नहीं मिला, लेकिन हमने प्रयास रखा और विदेश तक जाके मिनिस्ट्री ऑफ हेल्थ में मैंने जॉब की है 10 साल तक। और मैं ये चाहूँगा कि हमारे हिंदुस्तान के जब फिलिपिनोज दे कैन वर्क इन अमेरिका, कनाडा, इंग्लैंड, यूएसए, व्हाई नॉट आवर पीपल्स? वी हैव मोर देन दैट पॉपुलेशन, हमारे स्टूडेंट्स हैं, तो हम लोग क्यों नहीं वहाँ पे जाके काम कर सकते? तो मेरी तो यही आशा है कि इन फ्यूचर जो है हमारे स्टूडेंट्स बीएससी एमएलटी, एमएससी एमएलटी, पीएचडी स्कॉलर्स फॉरेन में ज़्यादा काम करेंगे। थैंक यू।
Thank you for your active participant. I would like to thank to all panelists also, students and the working professionals, faculty members. Thank you very much. बस एक हम्बल रिक्वेस्ट है, आप 2:45 का टारगेट रखें दोबारा से यहाँ पहुँचने का, क्योंकि मुश्किल होगा उस टाइम 10 लोग यहाँ बैठे होंगे और क्लोजिंग सेरेमनी में आप सबका मेमेंटो एंड जो भी ग्रुप फोटो उसके बाद होंगे। डिफरेंट जो ग्रुप के मैंने शेयर किए थे, या भी कर सकते हैं
सर, क्विज कर लेते हैं।
नहीं, लंच दिन, हाँ क्विज इसके, सॉरी क्विज भी तो आप याद नहीं दिलाया ना मुझे। क्विज 10-15 मिनट का क्विज चलता रहेगा, स्टूडेंट को तो पार्टिसिपेट करना, डेलीगेट्स।
ऑल द स्टूडेंट्स प्लीज रिमेन सीटेड।
स्टूडेंट है ना सिर्फ, तो स्टूडेंट आप पार्टिसिपेट कर ले, 15 मिनट की क्विज है, बाकी लंच के लिए जा सकते हैं।
कैश प्राइज एंड आल्सो दैट ऑल द स्टूडेंट रिमेन सीटेड हियर।
अब नहीं हो सकता सर, सब समझो। क्या है 2:30 बजे खुलना है? कितने बजे हैं? नहीं मिल जाएगा, 2:30 नहीं करके 2:20 पे कर दो, 2:30 बजे कर दो, 2:30 बजे कर दो, 2:30 बजे कर दो, यहीं होगा 2:30 बजे, वो इसके बढ़ने से इकट्ठे हो जाएंगे।
Dear students, please proceed for the lunch. At sharp 2:30 we'll start the quiz and it is just going to take 10 minutes. So be remain seated at 2:30 sharp in the Audi. So go fast and had your lunch and we are waiting for you. हम भी खा लेंगे ना फिर। Dear students, please call your friends to come assemble in the hall as soon as possible. Please call them. You are going to help me for the quiz. You haven't lunch? मेरा भी यही हाल हुआ सर, वो कर दिया post पे I hope all the students are registered in the registered group. If somebody is not registered, kindly raise your hands. All students available here are having that registration WhatsApp group or not? How many of you are not entered in that WhatsApp group? Kindly raise your hands. Ashna, you are there? You are not in that student group, that registration group? Gurpreet, you are having in registration WhatsApp group. So we are going to have the QR code over here. Those are not yet registered. Kindly scan that code and start participating in the quiz. Okay? So just for clarification, I'm going to tell you all the conditions of the quiz, though that is already been shared yesterday night in the group. The first condition is it is exclusively only for the students who are registered here and sitting in the auditorium. Once they will qualify for first, second, third, we are going to check your ID card that you must be a student, or will ask your respective faculties that you must be registered as a regular full-time students. And if in case of ties, we are going to ask the questions physically to shortlist among top 3. In this quiz, we are going to have total 20 questions, and the time allotted is exactly 10 minutes. Within 10 minutes, you are supposed to attempt the quiz. So I hope everybody is ready. I would like to request Ashna, kindly come here. Sneh, please come forward. You are going to help me in case of the ties. Fakrundeep ji, please come here to help me if in case of any ties. Please sit forward. Just. Be seated fast. We are going to share the link. It is remain open only for the 10 minutes. Be seated close. Atri sir, please sit. Either arrangement kar lenge. You just sit with along with Fakhruddin sir. Sir, bas wo online jayega. We'll share the link at exactly 2:35. It will remain live till 2:45. Okay? Another 1 minute you are going to have one scanner code over here, as well as in your WhatsApp group. The quiz is open. Please open the link which is sent in the group. You can scan the QR code that is already there in group. Kindly we have the QR code on the screen, please. Can we have the QR code on the screen? QR code? Yeah. Start attempting fast. Come on. You can scan the QR code from here also. That is there in the group also. Atri sir. Hope everybody is able to open the Google quiz. साथ वालों से डिस्कस करेंगे तो आपका गलत होने वाला है. हम देख रहे हैं आपको. Gurpreet, you cannot help. Come outside. Scan here from here. We have given the condition that internet connectivity supposed to be there. So we have received 2 responses. 3 response we received. three guys are very fast. They completed the quiz within 3 minutes. Twelve students completed. 13. Halfway has gone. Another 5 minutes for you. Those still roaming here and there, please fill the form fast. Quiz is going on. बच्चों फटाफट बैठो ना, जल्दी से स्कैन करो अगर करना है, आपने अटेम्प्ट करना है तो. Just scan the QR code and start attempting. 25 students already responded. Till now 38 students have responded. Another 4 minutes left. Please be fast. Come on guys, 45 students already responded. We have received around 50 registration. Already 50 response we have received. Still 3 minutes left. It's the last 3 minutes. Be fast. Sixty-six response already received. $75. Last 2 minutes. Total 80 response we have already received. If somebody left, kindly raise your hand. Last 2 minutes. So the 100 students already attempted this question. अगर कोई बच्चे का रह गया है तो हैंड रेज करें प्लीज. सब लोगों ने अटेम्प्ट कर लिया है? ओके, प्लीज फिल इट फास्ट. 115 responses received. Last 1 minute. Be fast. Countdown start. If somebody left, we will going to give another 1 minute. Just last 1 minute. Hope everybody have submitted their forms. If not, kindly submit right now. Otherwise, they won't be able to submit the form. Five, 4, 3, 2, 1. The quiz is closed now. Thank you. We'll declare the results in the validity.
Respected dignitaries, my dear colleagues and delegates, good afternoon. It's with immense pleasure and a sense of accomplishment that we stand before you today to extend a warm welcome to all of you at this valedictory function. This event marks the culmination of 5th National Conference of ICMLS 2024, welcoming the chief guest and our guests of honor for the evening onto the dais.
Welcoming onto the dais, our chief guest for the evening, Dr. Sasmit Patra, Honorable Member of Parliament and Advocate Supreme Court. Professor Harish Pemde, Medical Superintendent, Kalavati Saran Children's Hospital, New Delhi. Dr. Kaptan Singh Shehrawat, President, ICMLS. Dr. Pankaj Kaul, Secretary, ICMLS. Ms. Saroj Singh, Organizing Chairperson. Mr. Indresh Singh, Organizing Secretary. As we start the function, we request members of the organizing committee to welcome our chief guests and guests of honor for the evening. I call on Mr. Vijay Singh, co-chairperson ICMLS 2024, to give a green welcome to our chief guest, Dr. Sasmit Patra, Honorable Member of Parliament. I invite Mr. Ajit Singh, President Officers Association, to welcome Professor Dr. Harish Pemde, Medical Superintendent, Kalavati Saran Children's Hospital. Next, I invite Mr. Ajit Singh from Physiology Department to invite Dr. Kaptan Singh Shehrawat, President, ICMLS. Calling upon Mr. Amit Kumar, General Secretary, Officers Association, to invite Dr. Pankaj Kaul, Secretary, ICMLS. General Secretary, ICMLS. Can we have Mr. Hari Mohan Jangit, Kalavati Saran Children's Hospital, to welcome Ms. Saroj Singh, Organizing Chairperson of ICMLS 2024. Inviting Ms. Shriti to welcome Mr. Indresh Singh, Organizing Secretary of ICMLS 2024.
Now, I would like to request Dr. Kaptan Singh Sarawat, President of ICMLS, to address the gathering.
Good afternoon to all of you. Honorable, Dr. Sasmit Patraji, Honorable Member of Parliament Rajya Sabha, our Chief Guest of the valedictory function, our Guest of Honor, Dr. Harish Pemde, Director Professor and Medical Superintendent of our hospital, Kalavati Saran Children's Hospital and Lady Hardinge Medical College. Welcome you, sir. My organizational colleague, Dr. Pankaj Kaul, who is the General Secretary of Indian Confederation of Medical Laboratory Sciences, Mrs. Saroj Singh, Organizing Chairperson of ICMLS-2024, Mr. Indresh Kumar Singh, is Organizing Secretary of ICMLS-2024. On behalf of the Indian Confederation of Medical Lab Sciences, I welcome you all, sir, in this August gathering of our national conference. Sir, before starting my the welcome address, I would like to apprise you about this brief overview of this association or profession, sir. So since I think first time you are meeting with us. So this is a national confederation. Basically in India we have departmental wise association, even at the institutional level. This is a very scattered workforce and unregulated also till now, since we are dealing with the NCHP Act. So first the initiative was taken in 2016 just to unite all these technical fraternity under the one umbrella organization, sir, that is Indian Confederation of Medical Lab Sciences. Means it's a group of associations. But at the same time, we have also the individual membership. Those who are not associated with any association, they can also directly be part of this association. We have very senior professionals from the Institute of National Importance in our membership from the PGI Chandigarh. It's a good membership from AIIMS Delhi, from NIMENS, from this NIGRIMS. Everywhere the members are from the INIs. As far as the central government is concerned, from central government also we have good numbers from the central hospitals. Even from the CGHS we have the almost 90% membership. Then from one of the largest healthcare provider now is ESIC, who is now expanding its medical education and healthcare services beyond this insurance scheme. So we have the ESIC Medical Laboratory Technologists Association, which is also member association under this confederation. So we have a good number of students who are coming forward as young leaders in profession, and they have high expectations. But at the same time, lot of energy is there, lot of expectations are there. We are also struggling a lot for the last many years for the standardization of education, which is a major challenge, because right now we don't have a uniformity in the entry point qualifications. Even sometime in the central organization there was no uniformity, so that was the major challenge. Although we could get the cadre restructuring done in our central hospital, and the same was recommended through the central pay commissions. Now all INIs, Institute of National Importance, are also following the same pattern. Even CGHS is following, even ESIC have, but there is again a very big workforce in private health sector which is looking after the technical support of laboratories. They are performing various tests. So again the major issue is that patient safety at risk, because there is no uniform entry in profession, no licensing is there, no registration is there. So this creates a lot of challenging situation for us in profession. So since we have a very experienced professional from the PGI and other prestigious institutions, we have so under their leadership and good team, we started this forum to settle these national issues, policy issues. So first attempt was to include them as to constitute this ICMLS. After that, just after in 2016, we started holding these national conferences. First conference was organized in Lady Hardinge Medical College in 2017. Then after that, in 2019, the second conference was in ICMLS Bangalore, which was a good gathering. And then in 2019 also we had a conference in in COVID time, it was a break. Then last conference was in Jipmer, Puducherry, and now it's our 5th national conference, sir. And next, till 2030, every conference has been, annual conference has been planned. Next conference is there in GMCH Guwahati, sir. So all Northeast states are now part of this forum. So good thing is that we have very senior professional, we have student leaders, we have our working professional who are now coming forward for these national issues of education and standardization for patient care, leaving aside their salary structure issues, salary pay allowances issues. And I would like to specially mention you, sir, since you are leading our national legal matter at Apex Court, and it was a good direction, a very good direction, landmark development in our history of allied health sciences, when Honorable Supreme Court just 2 months back given a direction to all central government, state governments, UTs, and even to central commission also, which is now temporarily functional, that it should be, it's a matter of importance, and it should be implemented in a time-bound manner. So thank you very much, sir, for your support and guidance, and we are really appreciating your support, although first time I'm meeting with you, but through some of my colleagues who discuss about these matters, and you wholeheartedly supported this initiative. This is not a matter of an organization, this is not a matter of a particular category, this is a matter of a patient care services and standardization of education throughout the country, sir. The students have very high expectations, even after having the doctorate degree in medical laboratory sciences. We have very senior colleague, Dr. Pankaj, he's a retired technologist from the PGI Chandigarh. We have gold medalists trained from the, educated from the PGI and AIIMS and other institutions, but still there is no career pathway, no defined salary structure, because entry point is not defined so far. So since morning we had a first day of this conference was full day on plenary talks. We had invited many speakers from the other countries, Asian countries, even from the other countries. So we discussed various issues, academic, regulatory, and we could get the very good insight how we can proceed further in future, how we can make this profession more visible, more accountable through registration and licensing. Once again, I would like to thank our own medical superintendent of Kalavati Sir and Children Hospital. Thank you, sir. आपने just एक मैंने message से ही आपने accept कर लिया था. Thank you very much. And sir is very renowned pediatrician in the country. Sir is very, very active in the pediatrics, and now it's a proud moment for us. He's the first medical superintendent of Kalavati Sir and Children Hospital. It was a long stated demand under ministry. Now proudly we can say we have also a medical superintendent. In central hospital also, medical superintendent is very important post. So thank you, sir, for accepting our invitation. And sir, there are lot of issues I would like not to take much time about to discuss these issues, but thing is that even after the direction of the Apex Court, the major challenge with us is that where we should go now, when the Supreme Court itself has directed to all our India, every healthcare establishment, every authority to standardize to implement this national act, which was enacted during the COVID pandemic, and it was well appreciated by the parliamentarian in both this house. But unfortunately, the states who were earlier saying that there is no law, we have a law. But thing is, we are seeking a speedy implementation of this act. Lot of major issues will be addressed just after the implementation of this. I know the organization or the profession which are already regulated have also some challenges, but we are in the very primitive stage of this regulation. So at least few key issues related to regulation of education, standardization, entry point will be addressed. And we as an organization assure you that we are there to support for the every kind of the national initiative, state initiative. I am proud to share with you, sir, we have a lot of initiatives with the central government, state government as well, since you are from, I think, Odisha, sir. So we had a project with the Odisha government for the competency assessment 2-3 years back. The MOU was signed, and it was a good document which was created with the support of ICMLS. Now Odisha government is following that guidelines for the working professionals and the, for the competency assessment, which is a very important issue for the technocrats who are there in healthcare establishment. So other initiative which was taken by our team, dedicated team of expert. Before that, no standard model curricula was there in the country. Every institutions were following their own standards for degree, diploma, duration, nomenclature. Everything is in a very mismatched manner. So the first time we had a meeting with the ministry, multiple meetings in fact, then we could convince them that there should be a model curriculum. Although we don't have a regulator, it's correct, but still we should have some uniformity. So curriculum was designed, and our 7-8 experts from our team were the part of that National Task Force Committee also. We have now a standard model curriculum, but it could not be implemented due to lack of legal binding from the commission. And commission was not there, council were not there. So luckily we got implemented in few INIs. PGI Chandigarh is now following a revised model curriculum of BMLS, Bachelor in Medical Laboratory Sciences. Then JIPMER Puducherry is also following the revised model structure of 4-year degree program, master program also. And PGI had started a long back this program, almost 60 years back. But in Central Hospital also could convince our health secretary a few years back. Now Sabdarang have started this course. Now we are in process of getting the approval of Delhi University for the Lady Harding also. Already the Minister of Health has already given the approval, Nadaji, in 3-4 years back. So now we are in process of starting that course in Central Hospital also, sir. These are few things I wanted to share with you. So a lot of good developments are there. We are taking everything very positively. We know it's a very kind of single act in India, as per my understanding, where 56 categories of allied health sciences are to be regulated in a single act. Maybe it may be a complex issue in future because a lot of stakeholders are there. But we are, for the timing, we are taking everything very positively. At least we should have some framework. We should have some regulations. Then only step by step we can improve the things. So these are the few developments or challenges also. But thing is that you have accepted our invitation, sir, on a short notice. Thank you so much, sir. Thank you.
Thank you, sir. Inviting Medical Superintendent, Kalavadi Saran Children's Hospital, Professor Dr. Harish Pamdi, to say a few words. Sir.
Namaskar. Chief guest of today's program, Dr. Sasmit Patra, Honorable Member of Parliament, Dr. Kaptan Singh, Madam Saroj Singh, Dr. Pankaj Kaul, Shri Indresh Kumar Singh, faculty, delegates, guests, ladies and gentlemen. First of all, I thank Dr. Kaptan Singh and ICMLS for inviting me. And I came to know that this is a group of various associations, but this has a word science in it, which is a little different than other association. So I believe ICMLS for promotion of science amongst technicians and technical people who are working in labs and producing good quality, accurate reports, which are very, very important for management of patients and diagnosis of patients. Because whatever reports comes from the labs, clinicians depend on those reports and provide those things. So knowledge and skills of all the people who are working in healthcare is very, very important, including the people who are working in labs. Although lots of labs are now machinized and mechanized, robotics are there, but Dr. Patra, I believe that still man behind the machine will be more important than the machine. So they need regular and continuous update in the knowledge, because science improves every day. Some new thing comes every day, and that we must know about it. Then only we can perform better. and then only we can serve the patients who are coming to us better. As you people have joined this conference, I congratulate you because you have chosen to learn more about the work which you are doing daily, which you have learned during your education, but you want to learn new thing and learn more. So my request and suggestion will be, so when you go back to your labs, just find at least one thing which you can change, just one thing which you can improve, so that you feel happy, all others feel happy, and ultimately the patient gets benefited. Because we all are working for the benefit of the patients only. So that is the ultimate beneficiary. So whatever we do, patient should be benefited, and all we have to work for welfare of the patient through our updated work, through our better skills, and through our updated knowledge. So this is about one thing. Kaptan Singh was talking about lots of welfare issues. So Dr. Patra sir, I have started little new steps in my hospital. I have made an employee welfare committee. This thing was not heard of in any organization. So this we are trying on an experimental basis. If we can invite the employee, come to us, tell us what better we can do for you, what we can do for your welfare. Because many things what he talked about the welfare of the people. Unless administration works for welfare of the individuals who are working there, we cannot justify our presence, we cannot justify our work there. So one thing we have started, and let us see how much it works. Associations and unions are there, so they will have their own role in a separate way. But through this committee, we are inviting every single person in the institution, come to us, tell us what better we can do for your welfare. This is something more than the grievance redressal. There are separate committees for grievance redressal, but we want to talk about the welfare. So education of technician and other things of technician, their promotions, their creation of new posts, all these things will be discussed in this manner. So with these few words, I again thank you for inviting me. Thank you very much.
Thank you so much, sir. With great pleasure, we invite our chief guest, Honorable Member of Parliament, Dr. Sasmit Patra, to address the gathering and share his thoughts. Please, sir.
Thank you so much. Professor Dr. Harish Pemde ji, Medical Superintendent of Kalavati Saran Children's Hospital, New Delhi. Dr. Kaptan Singh Sherawat ji, President ICMLS. Dr. Pankaj Singh ji, General Secretary ICMLS. Mrs. Saroj Singh, Organizing Chairperson of the 5th National Conference of Indian Confederation of Medical Laboratory Science. Mr. Indresh Kumar Singh, Organizing Secretary of this conference. Distinguished delegates, ladies and gentlemen, I firstly thank the organizers for this wonderful conference and for taking up this very active role about the issues that are important to this profession. I do understand you have been here for 2 days. 2 दिन से आप यहाँ पर हैं? है नहीं? थक गए होंगे। जल्दी खत्म हो, घर चले। सैटरडे संडे दोनों ही पे दे दिए। कल से फिर ऑफिस चालू है, भाई खत्म करो, एटलीस्ट 1-8 घंटे शाम का मिल ही जाए। कब तक चलता रहेगा? जल्दी खत्म हो, घर जाए। मैं आपकी भावनाओं के साथ सहमत हूं। मगर मैं आपको कोई भाषण नहीं दूंगा. I'll not give you a long lecture. I'll not give you a lecture about why your profession is important. Because you know your profession is important. I won't also try to tell you why your issues need to be resolved. Because they are important issues. आपके हृदय में यह सवाल होगा कि भाई ये डॉक्टर पात्रा को क्यों बुलाया गया है? ये राज्यसभा सांसद हैं, इनका हमारे प्रोफेशन से कुछ ताल्लुक नहीं है. He is not a doctor. I'm a PhD in management, so don't get confused with the Dr. Patra. So why am I here? It's a little story that I'd like to share with you. A few months back, a friend of mine, who is a Supreme Court advocate on record, Mr. Joby Verghese, he approached me. उन्होंने कहा कि सर एक बहुत इंपॉर्टेंट मैटर है. आई एम ऑल्सो एन एडवोकेट एंड अ मेंबर ऑफ द सुप्रीम कोर्ट बार एसोसिएशन. तो वो आके मुझे बोले कि एक मैटर है, बहुत सेंसिटिव मैटर है, एंड द फंडामेंटल राइट्स ऑफ द नेशनल अलाइड हेल्थ केयर वर्कर्स आर बीइंग वायलेटेड. योर राइट्स आर बीइंग नॉट टेकन इनटू कंसिडरेशन. मैंने बोला क्या बात है? तो ने बोला कि आप लोगों ने, जब मैं पार्लियामेंट में था, आई केम टू पार्लियामेंट इन 2019 जुलाई. सो इन 2021 वी फॉर्म्ड अ एक्ट, NCAHP एक्ट. आप लोगों को पता है? You're all associated with that act. And in 2021 we enacted that act in parliament, trying to ensure कि आप लोगों की प्रोफेशन को recognition मिले, whether it is the intake, eligibility, education, recognition, licensing, standardization, all of this should be taken care of. But sir, for the last 3 years it is not being implemented. I said, how is it possible? An act passed by parliament has not been implemented yet? I said, no. So we took up the matter. कोर्ट नंबर 1 सुप्रीम कोर्ट में यह मैटर पहले आया. वी स्टार्टेड. पहले तो मैटर उठना मुश्किल, उठ जाए तो बोर्ड में आना मुश्किल, बोर्ड पे आ जाए तो बाय द एंड ऑफ द डे बीइंग हर्ड इज डिफिकल्ट. So finally, after mentioning before the Honorable Chief Justice, then Chief Justice, Justice Chandrachud, he listed the matter. And the day the matter came, the government from the other side said, sir, please give us some time, we will come back, we don't have the information. फिर matter आगे चला गया. तारीख पे तारीख, तारीख पे तारीख. And finally, we beseeched before the Honorable Chief Justice of India in Court 1, Supreme Court, saying, sir, this is a travesty of justice. For 3 years, a law passed by the parliament is not being enacted, and our healthcare professionals are not being recognized. Standardization, eligibility, all of that is not done. Finally, I must thank the former Chief Justice of India, Justice D.Y. Chandrachud. He was so kind, he said, next date, whatever comes, we will give definitive orders, Dr. Patra. And true to his word, today he is not the Chief Justice anymore, but true to his word, the then Chief Justice, on the day ये जो matter आई थी Supreme Court के court number 1 में, we appealed, we argued. On the other side, the government again asked for time. But thanks to the government, thanks to the Supreme Court and the Honorable Chief Justice, he said no, I will pass definitive orders. आपने वो definitive orders देखे हैं? पढ़े हैं आप लोगों ने? For the first time in 3 years, directions were passed that it must be implemented by October. And the government of India has to take cognizance of the matter. बैकग्राउंड यह है क्योंकि मैं वकील हूं आप लोगों का, इसलिए मुझे बुला लिया चीफ गेस्ट करके. कोई सांसद वांसद नहीं हूं, इस वजह से नहीं बुलाया गया है. Now what is the way forward? मैं कोई भाषण नहीं दूंगा, आप लोगों ने बहुत अच्छा काम किया है, इसके ऊपर कोई चर्चा नहीं करूंगा. What is the way forward? यहां से हम कहां जाएंगे? From here where? या फिर ऐसे ही आएंगे, बैठेंगे, चर्चा करेंगे, बातचीत करेंगे, we will talk, discuss, sit, have lunch, have dinner, think, how do we take it forward, and we keep on fighting. I'd like to provide you 3 simple steps in which I am willing to walk with you. The first step, Supreme Court. मामला कोर्ट में लंबित था, आज भी है, ऐसा नहीं dispose of हो गया है. The matter is still there. Compliance has been sought, and as I understand, compliance has been filed by the government. So one way of doing it is we again raise the matter. We say, despite the Honorable Supreme Court directing the union and the states, the implementation is slow, it is not appropriate, it is inadequate, and the national healthcare professionals are not only being deprived of their right under the Act, but the people of this country, 1.4 billion people, are being deprived from having a proper law being implemented that will save lives. I agree. I'm very grateful today, and I agree with every statement that was made by Professor Dr. Harish Premde ji when he said that jitni machines aa jaएं, nothing can equal the human intelligence of all of you and your colleagues across this country. It cannot. Because machines give an outcome, but the interpretation is always that of the human. And that is why you will always be required, and you are more important than the machines that give us an outcome. So one is the Supreme Court route, and I am with you, we are with you, the entire association is with you. We will continue to raise it, and we will see how we can take up the adequate legal recourse and again approach and again raise this matter. Second, the health ministry. I'm willing to work with your association and see how we can get a delegation to go and meet the Honorable Union Minister of Health, Shri J.P. Nadda ji. The Parliament session starts on 25th of November. It goes up to 20th of December. इस दौरान अगर आपके association appropriate feel करे, or during the budget session from February, whenever you are ready, I will organize your meeting with the Honorable Union Minister for Health. We will go. Nadda ji is a very sensitive, a very competent, and a very dynamic minister. And I'm very confident that under his leadership, many of these issues that are still pending, we can find ways of doing it. The third is regarding states. Along with your association, I'm willing to write to various states in my capacity as a parliamentarian to see that where are these implementations lagging, to talk to their resident commissioners. हर state का एक resident commissioner है यहाँ दिल्ली में. To raise issues with them and see how we can keep pushing. बोलते रहेंगे. उड़िया में एक कहावत है. कोई उड़ीसा से है यहाँ पर? Anyone from Odisha? Odisha रू आपण आसचंती. उड़िया में एक कहावत है. पिला न कांदिले मां भी खीरो दिए नहीं. It means जब तक बच्चा नहीं रोता है मां भी दूध नहीं पिलाती है. उसको कैसे पता चलेगा कि भैया बच्चे को दूध चाहिए? बच्चा रोता है तो बोलती है अरे बच्चा रो रहा है दूध दे दो. तो वैसे ही हमें अपनी आवाज को उठाते रहना चाहिए in various forums. लोगों को जताते रहना चाहिए, whether at the judiciary level, whether at the government level, whether at the parliament level, till whatever is rightfully ours is received. Are you with us? इसलिए कोई लंबा भाषण नहीं, 3 outcomes हैं, 3 काम हैं, and these 3 activities we'll have to do together. I'm willing to walk with you, I'm willing to work with you, I have been walking and working with you, and I'll just say one thing, that you are actually the lifesavers along with the doctors and the nurses. Everybody says that when COVID happened, you were the warriors who saved us. No, you save lives every day. Because you take the samples, you test the samples, you ensure. It is for the doctor to look at. A brother of mine, he is a doctor, and he's done his MD in biochemistry and he was there, so I keep on understanding about the labs and the equipments that all of you use. But at the end of the day, I always say that irrespective of whatever it happens, that decimal point being at the rightful place is more important than is the interpretation of the doctor. The doctor will interpret what you provide as a medical lab technician or a laboratory professional. So I believe each one of you, your voices are not going unheard. We will work together, and we have made some strides in 2023 with the Supreme Court, so 2024 in the Supreme Court judgment, but the way is still ahead, and we'll keep on marching forward. Thank you so much for inviting me here.
Thank you, sir. That was motivating. We heartfully thank our special dignitaries to have accepted our invitation amidst their busy schedule. As a token of appreciation and gratitude, I request the President of ICMLS, Dr. Kaptan Singh Sehrawat, to kindly honor our chief guest, Honorable Member of Parliament, Rajya Sabha, and Advocate Supreme Court, Dr. Sasmit Patra, with a memento.
Immense pleasure to address you on this opening ceremony of 5th National Conference of Indian Confederation of Medical. To address you on this opening ceremony of 5th National Conference of Indian Confederation of Medical Laboratory Sciences. The medical lab professionals play a very important role in healthcare system by contributing in the diagnostic services and medical research. The importance of medical lab professionals in India's healthcare setup was evident during the COVID pandemic. You were one of the frontline warriors who fearlessly worked during those hard times without caring for your own life. It is our endeavor to develop a talented pool of qualified allied health professionals apart from doctors and nursing personnel under the visionary leadership of Honorable Prime Minister Shri Narendra Modi ji. The National Commission for Allied and Healthcare Professionals Act 2021 has been passed, and the process of implementation of this act has already been started. I assure you all that we will make all possible efforts towards speedy implementation of this act. I believe that this conference will provide a platform for young professionals to showcase their talent and to collaborate with the experts in the field. I am sure that the deliberations during the conference would disseminate much needed knowledge, improve the patient care, and would enhance productivity in the field. I wish ICMLS 2024 conference a grand success.
With such assurance from our Supremos, we are really glad that this will happen soon. I now request the President of ICMLS, Dr. Kaptan Singh Serawat, to kindly honor our Chief Guest, Honorable Member of Parliament, Rajya Sabha, and Advocate, Supreme Court, Dr. Sasmit Patra, with a memento. Thank you, sir. Requesting the General Secretary of ICMLS, Dr. Pankaj Kaur, to kindly honor our Chief Guest of Honor, Professor Dr. Harish Pamde, Medical Superintendent, Kalavati Sharan Children's Hospital, Delhi. Thank you, sir.
Any conference is not complete without appreciation, without recognition, and without selecting, without a competition. So, likewise, we have many prizes and awards to be given here, and I request the dignitaries to kindly hand over the prizes and mementos to the winners of the various events organized in line with ICMLS 2024. I call on Ms. Deepa Saini to come and call out the names of the winners.
Good afternoon, everyone. So starting with Chairperson Scientific Session, I would like to invite Dr. Malenga. Next, Dr. Thirumurgan Murli P. Dr. Pramod Kumar Verma. Dr. Malkeet Singh. Dr. C.P. Pandey, Chairperson, Scientific Committee. Mr. Vijay Singh, Co-Organizing Chairperson, ICMLS-2024. Ms. Mamta, Co-Organizing Secretary, ICMLS-2024. Mr. Indresh Kumar Singh, come forward, please. He is the Organizing Secretary, ICMLS 2024 Organizing Secretary. Dr. Surendra Kumar Sharma. Dr. Monica Mahajan. इसके बाद डॉक्टर सुधीर कुमार Dr. Sudhir Kumar Sharma. Next. Oral presentation. Now for oral presentation, first award goes to Ms. Renu Rani, PPD 07. She is from AIIMS and she has got 66 out of 80. I'm so sorry. For oral presentation, Ms. Monu Kumari. Ms. Monu Kumari, oral presentation. Okay, sir. Okay. She has got the first prize in oral presentation. Second prize, Miss Nalli Rasi R. She is from Mahatma Gandhi Medical College, Pondicherry. Third prize goes to R.G. Tyagi. Aarti Tyagi. On her behalf, she's taking the award for Aarti Tyagi. Next is poster presentation delegate. First prize goes to Miss Renu Rani. Second prize goes to Divya Rathi. Miss Divya Rathi. Rathis. Someone please come on the stage and collect the award on her behalf. Amit, please you come. You come. Third prize goes to Miss Priya R. Miss Priya R. हो गया. Best poster presentation student. First prize goes to Miss Aditi Bhal. And we want to give an appreciation award to Mr. Saurabh also for poster presentation student category.
Though there was only one award for the student, but out of around 10 students who presented their posters, it was excellent efforts from their side. Since these two students presented the actual research paper, so we additionally add this award for Mr. Saurabh. Second one? Okay, now so today we conducted an online quiz. For the first award goes to Amana Mahshood, and she achieved 80 marks. Please come. Second prize goes to Jishana Kabir. She'll receive 3,000 cash prize along with a memento. Jishana Kabir, second prize. Although all three students got the same marks, sir, but on the basis of their attemptation speed. So only, and they came across from South India. Third prize goes to Mishriya DA.
Coming to the next set of awards, appreciation award. Please. Read out, yes. You are also there. You are also going, okay. Mr. Fakhruddin Ahmed, Ms. Sugandha Sharma, Ms. Sunita Rani, Mr. Ajay Atri, Mr. M.K. Pasha, Prabhat Kumar, Mr. Prabhat Kumar, Mr. Mangal Singh, Ms. Yogita Rani, Mr. Gopal Sharma, Mr. Narendra, Mr. Rajesh Kumar Sharma, Ms. Monica. Mr. Hari Mohan Jangir. Appreciation. These are the appreciation award for ICMLS-2024. Mrs. Velvizi Gunesh Taran, Mrs. Sujata Rajesh, Mrs. Sushya Kanan, Mr. Harish Chandra Pandey, Mr. Senthil Kumar J. Well busy announced. Mr. Ajit Singh, President Officer Association, please come on the stage. Okay. I would like to call Miss Aarti Tyagi for oral presentation, third prize. Okay. Earlier she was not there. Now she want to. Now, I call Mr. Amit Kumar from AIIMS for Appreciation Award, Mr. Gajay Singh, Mr. Muhammad Yusuf, Miss Sweetie, Mr. Arvind Dabas, Mr. Ruchika Kanojia, next. Ajiji is taking on Arvind the bus. Ms. Ruchika Kanojia. Next is Mr. Sanjay Kumar. Mr. Sanjay Kumar. Mr. Mohit Gulati. Vijay sir is taking on the behalf of Arvind Dabas. Sanjay sir, Sanjay sir. Mr. Mohit Gulati. Mr. Ranjit Singh. Ms. Uma Vohra. Mr. Shankar Ram Arya. Ranjit Kumar Singh. Ms. Uma Vohra. Mr. Shankar Ram Arya. Mr. Shiv Govind Shah. Mr. Naveen Nishchal Sharma. Mr. Naveen Nishchal Sharma. Mr. Keshav Dev. Mr. Chetan Singh Gehlot. Miss Shriti Biswas. You go. Miss Shriti Biswas, next. Miss Monica Tiwari. Mr. Sunil Kumar. Mr. Pradeep Kumar. Miss Yogita Dikshit. So last. Miss Leena.
Miss Deepa Saini.
Requesting all the awardees and prize winners to come on stage for group photo. awardees, prize winners, and the organizing team.
Arjun and Mr. Sunil. Okay. They both are here. Deepa, come. Deepa.
और तो कुछ नहीं। हाँ यही ठीक है सर। आप लोग आ गए।
आप आगे आ जाओ ना।
मैम आप लोग आ गए।
उधर कैसे जाएगा? चलो उधर।
आप लोग उधर चले जाओ। बहुत जगह है। छोटी में ठीक है। आगे आओ तुम आगे आओ। वोटर टैक्स
They received, ma'am. They called at the time and they received. So shared it.
ये लो जी मैडम।
I would like to announce few names who got missed. So, Mr. Sunil Kumar. Mr. Sunil Kumar. Yes, sir, after this. Yeah, after this. Mr. Arjun. Ms. Preeti Sharma.
जल्दी इधर जल्दी जल्दी एक ना ये औरत का जिसको फर्स्ट प्राइज था वो आगे लड़की तो बस एंट्री कर देंगे बुला के दिला देंगे अभी एक सेकंड एंट्री कर रही है आगे आगे आ रही है जो फर्स्ट प्राइज जिसको मिला था इसको अभी अभी एक मिनट हो जाएगी
Congratulations to Ms. Monu Kumari for first prize in Best Oral Presentation. She's just joining us now to collect her prize. A big round of applause. Next, we are inviting the representative of the Northeastern Branch Unit of ICMLS to announce the venue of the next annual conference, ICMLS 2025.
Namaskar. Honorable President of ICMLS, Dr. Kaptan Singh Sarawat ji, Honorable General Secretary of ICMLS, Dr. Pankaj Kaul ji, esteemed dignitaries of the dais and off dais, distinguished members of the Executive Committee, respected delegates and their students. First of all, I would like to thank Mr. Dinabandhu Teka, President of Amaltan, General Secretary Mr. Fakhruddin Ahmed, who has given me the opportunity to stand before you today at this prestigious gathering of ICMLS here in New Delhi today. It is privileged that Assam will have the honor of hosting the next ICMLS conference in Guwahati, Assam 2025. This is the moment of immense pride for us, and we extend our deepest gratitude to ICMLS for the prestigious opportunity. ICMLS always play a vital role in empowering Amalta, providing us with platform to engage with a broader community of MLT professionals across India. As you know, that Amalta founded on 1987, but the beginning of the ICMLS 2016, we are always cooperating with ICMLS consistently. We are committed to ensuring that the conference will be the milestone event filled with knowledge sharing, professional development, and innovation discussion. We would like to extend a heartfelt invitation to all delegates, not only attend the conference, but explore the beautiful state Assam and Northeast as well. We have prepared some slides for you to get some ideas about the next event in Assam tourism and Northeast tourism. This is the venue, GMCH Auditorium. GMCH Auditorium is a key facility within the institution. The modern auditorium is designed to accommodate large audience and is equipped with advanced audio-visual system. This auditorium has a seating capacity of 1,400 at a time. If you go on GMCH overview, the Guwahati Medical College and Hospital is a multi-super specialty hospital, is a substantial bed capacity of 3,214 and including 600 ICU beds. Department of GMCH encompasses 33 departments and 5 super specialty centers. Paramedical education of GMCH also offers a various paramedical degree diploma program through the Institute of Paramedical Sciences under the Srimanta Shankardev University of Health Sciences. The seat capacity of MLT is around 130 per year at GMCH, where 100 is diploma, 20 is BSc, and 10 is MSc in every session. Communication to GMCH, Guwahati. LGB International Airport, that is Lokopriya Gopinath Bordoloi Airport, is located approximately 25 km distance from the GMCH. Most common transportation via taxi, cab, and public transport. The nearest railway station is Guwahati Railway Station, that is Paltan Bazar, which is approximately 6 km from the GMCH. Accommodation, you will have all categories of hotels, lodge, guest house within 1 to 2 km in ranges. We'll list out some branded hotels given here at screen. You can read there. If you go about Guwahati, then Guwahati is the largest city in Assam, as served as a metropolitan hub in Northeast India and also known as the gateway of Northeast India. It is situated on the bank of mighty Brahmaputra River, and if you go some notable site, then as you know all, that Shaktipit Kamakhya is there. Then Umananda Temple, the world's smallest river island in River Island, Basista Temple, Shankardev Kalakshetra, State Museum, Science Museum, State Zoo, and many more beautiful parks. Tourism places of Assam and Northeast. If you tell about tourism of Assam, the first thing will come to your mind is Kaziranga. The Kaziranga is the national park of famous for one horned rhino. That national park was declared a World Heritage Site by the UNESCO for the natural environment in 1985. The park also holds on the record of having the highest density of Royal Bengal tiger in the world. Overall, visiting Kaziranga can be an experience of lifetime with nature. Soraideo Moidam Srongor Karangor is also there. The latest entry of the UNESCO heritage sites from Assam is Soraideo Moidam or burial mounds of Ahom royals. It has been recognized as a World Heritage Site in the cultural category. Moidams also called the pyramids of India, where Ahom royals are laid to rest. Then next, Majuli. Majuli is the world's largest river island, and it attracts tourists from all over the world. It is the island of Brahmaputra River, and in 2016, it became the first island be made at a district of India. Mahamrityunjay temple is also there. It is a Hindu temple dedicated to God Shiva, and it is special in architectural as a built in form of Shivling. Azanpir Dargah also there. The sacred mausoleum had been built in the memory of a well-known Muslim reformer and saint named Azan Fakir. Assam tea, as you all know that about Assam tea, as always famous Assam tea and its natural oil. The world's largest and oldest research center founded in 1911, that is Assam Tea Institute Toklai, Jorhat. This is about 300 kilometers from distance from the Guwahati. The another district of Assam is Karbi Anglong sightseeing. Located at central part of Assam, distance from the Guwahati is 213 kilometers by road. It is known for hills, forest, and rich cultural heritage. You can visit the famous waterfall that is beautiful Kakosang and Velugat waterfall. The Dima Asau is another district, is a hilly district of Assam, is formerly known as Switzerland of Northeast. It is approximately 275 kilometers from Guwahati, usually takes 6 to 7 hours by road. There is, you also visit Tumjang Park, the highest peak of Assam. It is 1.86 kilometers. Then Jatinga, well known for the being location of mysterious bird death. Umbrangso, the famous for beautiful artificial lake created out of the building of dam NAPCO across the Kopili River. Then another Panimur waterfall. It is a popular tourist destination in Assam, known for its scenic beauty and waterfalls along the Kopili River. Okay. The Shillong is a hilly station in northeast India and state of Meghalaya. It is known for the manicured gardens and Lady Harden Park. Nearby Walls Lake is surrounded by walking trails. The source of Shillong. Tawang, Arunachal Pradesh. You can visit also Tawang, Arunachal Pradesh, the beautiful place, that northeast, Tawang Monastery, Pengteng Lake, and Tawang City. If you say about the hospitality, as you all know that the Bihu festival is always heart and soul of Assamese people. Jalpan, Khar, that Satriya Nitya, fauna, all is there. I am conclusion. We are committed to ensuring that the conference will be a milestone event filled with knowledge sharing, professional development, and innovation discussion. Our team is already gearing up to deliver a seamless and memorable experience of delegates. So we invite all your esteemed delegates to country to join us at ICMLS Conference 2025 and explore the wonder of Assam. Please have a look on this video. Sound. I would like to call the delegates from Assam and Northeast on the stage to honor and invite all for the next conference to Guwahati, Assam. Please come. In the meantime, we want to invite on the stage Honorable President Secretary of ICMLS to receive our invitation formally on behalf of ICMLS. I request Mr. Fakhruddin Ahmed, General Secretary of All Assam Medical Laboratory Technician Association, to invitational honor to Dr. Kaptan Singh Sarwatji by symbol of Assamese pride by Fulam Gamusa. I also request Mr. Dinobandhu Deka, the President of Amalta, All Assam Medical Laboratory Technicians Association, to honor with the invitational honor to Dr. Pankaj Kolji by a gamusa, Fulam Gamusa. Thank you very much.
Two people, Mr. Ajit Singh. Sir, vote of thanks, sir. Okay. National anthem.
जनगणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Please be seated for just a few minutes more. Please remain for just a few minutes more. Once you play the national anthem, we cannot extract it. No, none of the dignitaries are there to give, no. No one is there. Madam is there. Ma'am will give. Sir, Pankaj sir. Sir. Couple of appreciation awards have been left out. Calling on Mr. Ajit Singh from Physiology, AIIMS, and Mr. Praveen Kumar Bharadwaj from RP Center, AIIMS, to come and get the appreciation awards. Mr. Ajit Singh, Physiology Department, AIIMS. RP Center.
As we pull the curtains down for ICMLS 2024, I thank each and everyone for being a part of this memorable journey.
Looking forward to seeing you all at Assam in 2025 with the same vibe. Thank you. Mr. Ajit Singh from Physiology Department, please come to collect your award of appreciation.
Sometimes, in the hustle of life, we forget to live. We forget to calm down. We forget to think. We forget to care for ourselves. Why? Come, step out. For here is rest. Walk in the woods and breathe the wild air. Where nature will always surprise you. Feel the love. Let your heart rejoice. Soak yourself in the echo of the past. Wrap yourself in the beautiful works of those hands. Let culture widen your mind and spirit. And smiles melt your heart. Let the food nourish your soul. Let the restful old river reveal its secrets and renew your spirits. Discover yourself. And when your mind is at peace, take home a stream of joy and timeless memories. Assam. Where else? It is so much more than you know. Come, explore